ACL rehab is one of the longest and most complicated rehab processes we deal with on a regular basis as physical therapists. Unfortunately, just following a weekly protocol is sometimes not enough. In this comprehensive ACL guide, I am going to walk you through the entire ACL injury process, from diagnosis and treatment all the way to return to sport. We're going to give you a comprehensive background, talk about what to do after your patient gets an ACL injury. We'll talk about non-op rehab versus operative rehab, which is going to be better. We'll chat about the cross bracing literature and whether or not this is going to be a good decision for your patient. We'll go in depth about all the different types of surgeries your patient could have for an ACL tear. And we'll also talk about the different grafts your patient can use for reconstruction. We'll talk about pre-op rehab for your patients prior to surgery. And then we'll chat about how rehab goes from the early stages of restoring range of motion and reducing swelling all the way back to return sport. Most importantly, we're giving you a framework for making clinical decisions in your ACL patients and not just another protocol. And if you like this content and you want to see my entire masterclass on ACL rehabilitation from A to Z with Mike Reinold and Kevin Coughlin, this is basically exactly what we do at Champion PT and Performance. I'll leave a link in the description and you can check that course out. Let's get down to business. The first lesson is a background on ACL injuries. All right, what are our learning points for today? We're going to go over prevalence, population, anatomy, biomechanics, mechanisms of injury, and predisposing risk factors for ACL injuries. You ready to do this, Kevin?
Let's go.
Let's go. Let's start off with prevalence. So, ACL injuries are a common injury in physically active individuals. There are approximately 250,000 ACL injuries that occur per year in the United States of America. And around 50% of those injuries undergo ACL reconstruction, which I thought was pretty interesting. So essentially, about half of folks that get ACL tear end up getting surgery, half don't. We'll talk about surgical versus conservative on a later show. There's an incidence of approximately 85 injuries per 100,000 in patient aged between 16 and 39 years. Probably should edit that a bit better because that sentence sounded terrible, but I think you guys get the point. And every year, around 3% of recreational athletes injure their ACL, and then up to 15% of elite athletes will tear their ACL. We'll talk about this a little bit later, but it does seem that as you progress up the ladder of more challenging sporting levels, there's a higher incidence of ACL injuries. Anything to add there before we move on, Kevin?
Just that's like a staggeringly high number, like 250,000 athletes per year in the U.S., and it doesn't seem to be going down over time. So that is definitely something to keep an eye out on and figure out why and what we can do to minimize tears.
I think it's great. Great for business, man.
Keeps us busy. That's definitely true.
Yeah, we would not be, living as lavishly as we do if it weren't for these folks. Just kidding. All right, so what population do you see this in? So it's greatest in athletes between the ages of 19 and 40 years old. I think part of this is just because we kind of stop playing sports as we get over the age of 40, right? And then non-contact is the primary mechanism of injury. This does change a little bit based on the sport you're involved in. I mean, if you think about football, there's going to be more contact injuries, right? Than you're going to see in something like soccer, just based on the nature of the sport, right? And we typically see this in pivoting sports. So think about soccer, basketball, football, volleyball, handball, gymnastics, and skiing. I always think it's funny when I look at a study and they say like the most common population for the injury is in netball. I'm like, I don't even know what netball is. You know what I mean? It's like, why didn't you include soccer? Everyone knows what that is.
Yeah.
And then, and this is a big one. So these injuries tend to be much more common in females. And it really depends on the study you look at, but somewhere between 2 and 8 or so females are around 2 to 8 times as likely to sustain an ACL injury compared to their male counterparts. Any of that sound new, exciting, weird, interesting to you, Kevin?
I think that's pretty in line with what we see, right? We tend to see ACL injuries occurring most frequently in younger athletes, high school, college age. Definitely seems more prevalent in females, just anecdotally. Like a lot of the athletes we have coming in are lacrosse players or soccer players or, field and court sport type athletes. That definitely seems pretty common. But definitely, like you said, we do see it in people older than 40 as well. But I think you're probably spot on with why. It's just that older people aren't doing field and court sports at the same frequency as younger people. So you will see it more commonly in that younger population. But I think across the age spectrum, you can expect to see some people present with this type of injury.
Yeah, we see a lot of skiers too. And some of these studies did mention downhill skiing, but recreational skiers all the time. I'd say that's one of the biggest populations that we see. When I was in Denver, Colorado, we saw a crazy amount, probably more ski injuries than sport injuries, right? So yeah, you definitely see that with skiers as well. So I hope you're ready for your head to blow up in a good way, of course, because I have something that you're going to love. It's an evidence-based cheat sheet for ACL injuries. Staying up to date on the literature is a pain in the butt, and my butt hurts. But yours doesn't have to, because I've done the work and going out there and reviewing the literature. I've taken all the good stuff and none of the fluffy stuff and condensed it into a nice little cheat sheet. My promise to you is I'm going to catch you up to date on the latest literature on these ligament injuries in under 10 minutes. These babies are action-packed, but not too packed. We go over prevalence and incidence, common populations with this injury, anatomy, mechanism of injury, clinical examination, differential diagnosis, and all the different treatments, conservative and surgical. Best of all, this bad boy is free. So I'm going to leave a link in the description. Go ahead and click on that and download it. My promise, I want to catch you up to date in under 10 minutes. I hope you enjoy. Now, back to the learning. All right, a little bit about ACL anatomy. I apologize to the folks that are listening to this. If you're listening to this at some point, if you want to see this a little bit better, you can go to YouTube and check out the video there. So ligaments connect bone to bone, right? So the ACL is no different. It attaches from the femur to the tibia, and it blends with the anterior horn of the medial meniscus, which is interesting, right? Sometimes the two are injured together. So it does attach with the meniscus a little bit here, right? And you can see that they kind of cross in the center of the joint. Kind of goes from the front of the joint to the back of the joint, and the same thing with the PCL. So you think about cruciate or cross ligaments, they kind of cross together on the inside of the joint there. And there are also two parts of the ACL. You have the anteromedial bundle, or the AMB, and this is typically a little bit smaller, and it's lax in knee extension, but then it becomes tall, or it tightens in knee flexion. And it's a primary stabilizer and higher degrees of knee flexion. In general, if you flex the knee to around 90 or so, it does slack the ACL more in general, but these bundles actually behave a little bit differently. You also have the posterolateral bundle, or the PLB, and this is larger, and it's tightened or taut in knee extension, so kind of the opposite of the anteromedial bundle. And it's a primary stabilizer in knee flexion, less than 30 degrees. So as I get closer to full knee extension, helps to reduce rotation and shear within the joint, and it's more lax in knee flexion. Any thoughts on that, Kevin?
No, yeah, just interesting anatomy, and something to keep in mind is that there are different bundles that have slightly different functions, and maybe plays a role in, like you said, what forces are being resisted. So just something interesting to keep in mind when we get into our special tests. If we're seeing certain things, it could give us maybe some insight into where the tear may be.
Yeah, and I think that these are getting a little less popular. I'm not sure. But I remember when the double bundle technique from a surgical repair standpoint, or reconstruction standpoint, was very popular. So they can try to reconstruct both of these bundles in surgery too. So more relevant in a future podcast episode. All right, let's talk a little bit about biomechanics. What is the function of the ACL? So it resists anterior tibial translation, is the primary restraint to anterior tibial translation. So you think about your anterior drawer test, patients laying on their back, knees bent to 90. We grab the backside of their knee on the tibia. We try to pull it forward, right? And if the ACL is intact, it shouldn't move very much. And if it's not intact, it tends to move a little bit more, right? The ACL is also going to prevent tibial internal rotation, particularly in knee extension. And spoiler alert, this is the common mechanism of injury you tend to see in these folks. So the knee is close to full knee extension, and then we have a valgus load. The tibia may or may not go into internal rotation, sometimes an external rotation, but this can tear the ACL. And ACL deficient knees present with more tibial anterior translation, as well as rotary instability, which makes total sense. The ligament is either stretched or gone, then you're going to have more motion at the knee. Another thing that's going to be very relevant is that the ACL contains mechanoreceptors that influence neuromuscular control of the knee. So after you have an ACL injury, we We want to work on things that restore proprioception, balance, neuromuscular control, so on and so forth. What do you think about that, Kevin?
I think you're spot on there, dude. Good job. Got nothing to add there.
All right, let's move it on then. Let's talk about mechanisms of injury. And I thought this study was great. I tried to use relevant recent articles for this presentation just because there's so much ACL research. It's really hard to stay on top of. And one of the things that I found, especially in the risk factor section, is that new research will invalidate old research, and then newer research will revalidate the old research, and back and forth, so on and so forth. So it's a little bit confusing, and I wanted to use the most up-to-date literature that I could find. This study was in arthroscopy in 2024, and it's called Most Anterior Cruciate Ligament Injuries in Professional Athletes Occur Without Contact to the Injured Knee, a systematic review of video analysis studies. So essentially, they're looking at athletes that tore their ACL, and they're remarking about how they did it, right? They were looking at 13 studies, 542 athletes, and this was 91% pro athletes and 71% male, which we know is maybe not the most accurate reflection of the average person that tears their ACL, because we tend to work with a lot of folks that are, say, high school athletes, right, or middle school athletes. We also see a lot of ACL injuries in females. So take this with a grain of salt, but it was very up to date, and I thought it was pretty good. And it was very similar to other studies I saw. Essentially, 33% of the athletes in this study, soccer players. Football was the second most common with 26%. And they had a whole bunch of other types of sports included in the study as well. So they saw 42% of those injuries were non-contact injuries. And here's what I will say. That's a little low compared to the other studies I saw, because you'll see other studies that show around 70% of all ACL injuries are non-contact in nature. This one's quite a bit lower. And I'm curious if it's just because there were so many like football injuries, or there may be more contact sports included, or maybe because there's more males. I'm not really sure. But that was one thing I saw that was a little bit different with this study compared to others. In terms of contact injuries, so they remarked on direct versus indirect contact injuries. So essentially, a direct contact injury would be a football player plants their foot, and then another player drives their shoulder into their knee, delivering a valgus force and tears their ACL, right? An indirect contact would be a person collides with another person, but doesn't directly hit their knee, hits somewhere else, right? That would be an indirect contact injury. And of those total injuries, indirect contact injuries made up 32% of all injuries. And then for the direct contact injuries, they made up 22% of all injuries, right? So in this study, it actually showed more contact injuries than a lot of the other studies, which I thought was interesting. What I will say is that most of the research on ACL tears are in non-contact injuries. I think the major reason why is that we feel like we can potentially change these non-contact injuries more so than the contact injuries. They're kind of happenstance that just kind of happen with the sport. Although I bet you we could probably try to prevent some of these contact injuries as well, you know. In terms of how these injuries occurred, about 91% of these injuries occurred with the foot planted on the ground. So generally speaking, the large majority of patients are tearing their ACL once their foot hits the ground. It's not happening on the opposite side leg that's in the air, or when they're in the air in general. The other piece is that 84% of these folks were at full or near full knee extension. So that's another big one. Once that knee flexes, it protects the ACL a little bit. When you're at your close to full knee extension, less likely to be safe. And this is one of the reasons why quad strength is so important, because if you don't have the strength to go into knee flexion when you land, cut, change direction, you might be more at risk for having an injury. But it's a double-edged sword, and we'll talk about that a little bit later too. Axial loading occurred in 81% of folks. So think about, let's say you're decelerating from a jump, you're loading up that joint. That's an axial load. The 50.4% of athletes had an ACL injury. This occurred during a deceleration or a shift in momentum, which makes sense. 36% of these injuries occurred while an athlete was pivoting. And then 76% of these athletes had some form of knee valgus with associated internal or external rotation. And that was 50-50 split. So about half of those folks happened with tibial internal rotation, half with tibial external rotation. So I thought that was interesting too, because I kind of thought that tibial internal rotation was the big one, but it looks like it's kind of split. And it seems like that knee valgus can just tear it regardless. Doesn't matter where your spinning of your tibia is, you can tear that thing regardless. So any thoughts on that, Kevin, before we move on?
Yeah, I think one thing that just popped in mind, just curiously, if we do see higher rates of contact ACL injuries in men, and maybe if the study had more women for whatever reason, non-contact may be more common. That's just speculation, totally guessing, but seems potentially reasonable. But I do think like those are the mechanisms that we tend to see, is that non-contact, I think, is a little more common that I see. Like you had said, we see a lot of skiing injuries, and that tends to be non-contact, and they kind of get stuck in their ski, and they have either their planted foot in their ski with an internal or external rotation moment with that valgus stress. And I think using these types of mechanisms to, think about not non-op, but preventative rehab programs for ACL tears is something that I think a lot of researchers are always trying to figure out. So I think the more we understand about the mechanism, the more we try to apply those concepts in the gym preventatively. And hopefully that will continue to pan out over time. And as we get better at exercise dosage and prescription, maybe we can use that information to try to prevent, some of these tears from happening. So, we'll see what the future holds there.
Totally. Yeah, we'll definitely talk about that. There's a ton of injury prevention research too, very promising injury prevention research too, which I think is great. We'll talk about that a little bit in future episodes. Okay. What are some other common mechanisms of injury? So basically, valgus was only like 76% of injuries. How are other people getting hurt? So there are a couple other mechanisms that I think are important to think about. So knee hyperextension is one of those. In cadaver studies, they'll actually just bend the knee backwards until it breaks. And essentially what they find is that the ACL and the PCL simultaneously tear together. And I've certainly seen some patients that had their primary mechanism of injury was hyperextension. Knee bends backwards. Think about a flamingo. Their knees bend backwards. They do a flamingo maneuver. They go in for some imaging, and yep, looks like that ACL is torn. So that's a common mechanism. I've seen some patients have that. Whenever I see that, sometimes patients will say, well, I didn't have knee in, so I don't think I tore my ACL. And my thought is like, yeah, we'll see. Hopefully it's negative with that MRI, but that can certainly happen. These are anecdotes. I tend to work in weirder sports. So I see a lot of Olympic weightlifters, and I've seen a lot of Olympic weightlifters tear their ACL now, which is really interesting, right? I can think of 3 athletes off the top of my head that I've seen that have torn their ACL with Olympic weightlifting, right? The one that's weird to me is push jerks and split jerks. So Sarah Sigmund's daughter is a popular CrossFit athlete who this happened to her recently, was performing a split jerk, right? If you think about a split jerk, you're driving a weight overhead. You would think that you're not going to injure your ACL when you do that. But essentially in a split jerk, that lead leg, you're kicking forward. And a few things can happen. My thought is that if you're directing the bar anteriorly, when you catch, that means that you're going to put more weight on that lead leg. And the quad is going to be very, very active when you land. The other thing about the split jerk is you're actively kicking that leg forward. So if you end up kicking the ground, you've got a very forceful quad contraction in the absence of a hamstring contraction. It's just like you're kicking the ground super hard, and then you're catching a heavy load overhead. So your quad has to be firing aggressively. And maybe that just ends up tearing the ACL. It shears that joint. I've seen the same thing happen in a push jerk. Athlete kind of pushed it forward a little bit more so than they wanted to. They caught the weight a little toesy, kind of weight on the front of the foot, probably fired that quad a lot, and then the ACL tore, right? You also see those freak videos where people are doing sissy squats and the quad is super active, hamstring is not, and then you see the knee just shear, bloop, and you probably just tear the ACL. That's a terrible injury. I had an athlete recently that caught a clean or didn't catch a clean, and essentially the bar dropped straight down. One knee went way into valgus. The bar dropped directly on his quads, and he actually had a bunch of injuries, but one of which was an ACL tear. With that, I've seen an athlete starfish with a power clean before, which means that you catch the clean, and as opposed to going into a deep squat when you catch the clean, you spread your legs out super wide, and then you have a valgus force the knee, and she tore ACL there. So you see a bunch of funky things in the fitness world, but I have seen a few of these. just kind of interesting anecdotes. But yeah, the large majority are going to be in field sports, but you do see in the gym sometimes, just less commonly. Have you seen any really funky ACL injuries, Kevin?
No, I think the ones I have are a little more common with the field or court sport athlete or skiers, but I think that mechanism with the forceful quad contraction makes sense. I think in those examples, like a split squat or push jerk, if you're really pushing your foot forward in the catch, you're getting a lot of anterior tibial translation, and if it just happens, with the right timing and the right load, that tibia is going to keep going, and the biomechanics are such that you could tear the ACL. But I think it's interesting to think about how that would fit into return to sport, because I think once they're further down the road from their rehab, that's going to be something cool to get back to, where we're really putting on the brakes with that forward leg and testing that ACL. So yeah, I think that's definitely your population. So you see some crazy things there in terms of kind of scary things with all the load involved. But yeah,
Yeah. Yeah, they're like catastrophes when they happen, but they don't happen that often. You know what I mean? It's
yeah.
so freaky. I
Well,
don't
that
know.
one you were describing, the starfish, I thought you were going to say she had two bilateral ACL tears, because that would be a nightmare. But I'm sure that
Yeah,
that's happened, right?
just
Got
one.
to.
The other athlete I was talking about, he had like 3 surgeries. He had 2 surgeries back to back because he tore quad tendon and quad muscle, right? And he tore his ACL too, but they actually staged that. They did the ACL later. So
Wow,
that was a tough one. He's doing great now, though. It's really
that's
cool. It took him a
awesome.
long time to get back, but
Mm.
way to go. All right. So let's look at some predisposing risk factors. These were anatomic risk factors. And I found a really nice up to date study to try to investigate which risk factors are going to be relevant for ACL injuries. This study was from the American Journal of Sports Medicine 2024. This is really nice because there's a lot of prior research on this. And essentially, what the study had stated was that there are a lot of different risk factors that had shown to be predictors of future ACL injuries, except these weren't great studies. They weren't really high powered. So, what they wanted to do was to look at some of these risk factors again and see if they actually ended up being true risk factors. And there are a lot of prior risk factors, intrinsic risk factors, that are shown to correlate with ACL injuries. So, some of these in females are high body mass, knee hyperextension, and anterior-posterior AP laxity of the knee, decreased ACL size, narrow intercondylar notch, increased posterior tibial slope, poor tibiofemoral congruity, and increased hip anteversion. For males, you'll find generalized joint hypermobility, and knee hyperextension increases ACL injury risk. So all of these risk factors have been shown to increase your risk of ACL tears in the future. Now, one of the other things that this study looked at was whether or not having certain variables present after your primary injury and primary surgery will increase your risk of having a secondary injury. And they found a few different things that actually did correlate with a new ACL injury after the primary one. And those were having a medial collateral ligament injury of grade equal to or greater than 2, lateral meniscus posterior root tears, medial meniscus ramp lesions, and an anterolateral structure injuries. These are all associated with residual rotary laxity and have been shown to be risk factors for ACL failure, as well as younger age, increased posterior tibial slope, and knee hyperextension. So all of these things were in the past shown to correlate with another injury after a prior ACL injury. So like I was saying, in this study, they were trying to have more people in the study to increase the power of the study. And they included 880 non-contact ACL injuries. It was higher powered than some of the prior studies. And they looked at all of the risk factors that we just mentioned previously to see if it held up in a higher powered study. For female athletes, static knee valgus was significantly higher in the new injury group, and the tendency was clear in the previous ACL injury players. So essentially, if you have regular valgus, not dynamic valgus, okay, so if you just stand up nice and tall and the knee comes in when you're standing straight, that was a risk factor for getting a primary ACL injury, an even stronger risk factor for a secondary injury, right? And then players with a secondary injury also had a higher degree of genial recurvatum or knee hyperextension statically as compared with previously injured players who did not have a secondary injury. So it wasn't a risk factor for primary injuries, but it was a risk factor for the secondary injuries, right? And I think the takeaway with this study is that all of those intrinsic factors we talked about previously had correlated with an increased risk of injury. When we looked at it in this study that was higher powered, it seemed that they weren't risk factors. Okay. So you have to take that with a grain of salt when you're looking at some of these older studies, because the newer studies weren't showing the same thing. Any thoughts on that before we move on, Kevin?
Yeah, that's interesting. So just to clarify, so the first slide that was showing all those things that predispose people to ACL injury were in previous studies, versus the newer study that was higher powered was showing that what seemed to correlate with increased injury risk was static knee valgus and kind of hyper knee extension or genu recurvatum. Is that correct?
Yeah, only for the secondary ones though.
So that's a secondary injury after they
Yeah.
already
So
went through reconstruction.
overall, what they said is that there's little to no correlation of anything with these injuries. And I think that's relevant just because a lot of the prior studies did show a connection. They were just really underpowered. This one had a higher power to it, just more participants, and they showed there wasn't a connection between all of these things. So frustrating, but this was a better study, most likely.
But I think good too, because I do hear sometimes people, blame their anatomy or, think that they were, destined with this bound to happen because of their anatomy. And, maybe it's a good thing if we keep finding out that there's maybe it's more, biomechanical and sport force related than your specific genetics. I'm sure there's got to be some combination, but, I think that's so important, is that we look for studies for answers, but some studies just aren't the best studies. They're not high powered, or they don't have the best methods or whatever. So it's good when better studies come out that we can bring awareness to that, and just something to keep an eye on as the research progresses.
Yeah. I also feel like we probably need to get an expert on here to kind of someone who's like sifting through this research all the time.
Right.
Right. To give
Yeah.
us some more answers, because things I found is that as I read through everything, I was like, there's a lot that I still don't know, despite like going down stupid rabbit holes and reading all these studies. So yeah, we'll do our best to do that in future episodes, do some interviews, right?
Yeah.
Okay. New study, intrinsic risk factors for non-contact ACL injury in young female soccer players. This was 145 female Japanese soccer players, and they're looking for potential risk factors for non-contact injuries, similar to the last study. They're looking specifically at intrinsic risk factors, and they took 25 different variables. So this was kind of cool. They're looking at a lot of different things too, and this consisted of anthropometric data, joint range of motion, muscle flexibility, muscle strength, and balance measurements. They basically monitored these players throughout a single season for non-contact ACL injuries, and they found 13 total injuries. So not a ton of injuries, right? But this was a recent article, so I wanted to include it. I would have liked to see some more recent systematic reviews. I'm sure they will pop up more so, right? And what they found as risk factors associated with ACL injury were lower hamstring to quadriceps ratio, or the strength of the hamstring versus the quadricep. Generally speaking, I went back and kind of looked at what's acceptable in terms of being protective, and it's around a 0.6, right? So if you had a 1-to-1 ratio, that would be, let's say, 100 pounds of force in knee extension, 100 pounds of force with knee flexion, which would be very odd. Normal is somewhere between 50 to 80% of hamstring to quad ratio. So if you're below about 0.6 or so, your risk of injury goes up, which I thought was interesting because I learned a little bit about this in college, and then I didn't see a ton of it in the medical literature. And here's a more recent article showing that it's still relevant, right? And there's two thoughts. So essentially, if your hamstring is not strong enough, then when you do like a landing or cutting maneuver, you're going to rely more on the quad. The quad is going to pull the tibia forward, and the ACL prevents that. So if you're overusing your quad and not using the hamstring, what may happen is that the tibia is being pulled forward, the ACL is getting stretched. The hamstring normally prevents anterior tibial translation. The hamstring's not strong enough, could shear too much and just tear that ACL, right? There's also some cool research about timing of muscular contraction. So if you land and the quad fires before the hamstring, thought is you're getting that shear in the absence of any sort of restriction from the hamstring. So interesting stuff. I mean, this study did suggest that's a problem, right? The other thing they found, which is also interesting, is greater knee extension muscle strength correlated with more injuries, which kind of makes sense too. If that quad is overpowering the hamstring, getting more anterior shear forces, forcing more strain on that ACL, causing more injury. And the last one is longer soccer experience. So if you played for more years, then that also correlated with injury too. So any thoughts on this one, Kevin? Kind of interesting. Hey there, you little learner. Do you like this content and want to go a little deeper with that learning? You should join us with our online community, Insiders Academy. It's our premium subscription membership to help you become a better coach and clinician. We do a lot of good stuff at Insiders. We fill in those gaps in knowledge that school didn't teach you. We go over things like exercise technique and prescription, programming, periodization, strength conditioning principles, and advanced rehab. Let's get you proficient there. We also help to keep you up to date on the latest medical literature, even if you don't have time. And we do this with cheat sheets. And these are PDF downloads that catch you up to date on a given topic in under 10 minutes. And we've got a lot of them, over 50, and we're constantly updating them and adding new ones. It's pretty much the exact same thing as downloading all of our knowledge directly into your own brain. We also keep you up to date with our master courses. We cover pathologies in depth so you know exactly how to diagnose and treat patients with these issues. And we're really thorough, going over prevalence and prognosis, risk factors, anatomy, history, clinical presentation, diagnosis, differential diagnosis, patient education, and exercise prescription, as well as manual therapies. We have a whole bunch of master courses and we're always updating and adding new ones. Some of the big dogs are rotator cuff related pain, knee osteoarthritis, shoulder instability, femoral acetabular impingement syndrome, SLAP pathology, cervical radiculopathy, lateral ankle sprains, and radicular low back pain. Who doesn't love some searing back pain going down their leg? We also include case studies with every one of our courses. This way, you can see exactly how we diagnose and treat. Each master course comes with in-depth protocols, both non-op and post-op. This way, you know the exact exercise we'd like to use with videos of all movements, how many sets, how many reps, how do the exercises progress over the course of time, what are the relevant manual therapies when they're indicated, and exactly what you should educate your patient about. Hey, are you a physical therapist, athletic trainer, or physical therapy assistant and looking for some CEUs? Well, we got you covered, and you can even earn CEUs for watching the content you're watching right now. Finish up the master course, take the exam, get the CEUs. Easy peasy. With Insiders Academy, you also have community access. Basically, you can have all of your questions answered by me and the rest of our team at Fitness Pain Free. This way, as you go through the learning and you have a question, you'll get it answered. Best of all, you get started with Insiders Academy for just $1 for a week-long trial. After that, it's $25 per month. If you want to save 2 months, get them for free, then sign up for the yearly membership. I'm going to leave that link with a discount in the description below so you can check it out, and I'll see you there. Now, back to your learning.
Yeah, it is. I think we hyper focus on the quads in rehab post-op, and for good reason, I think. But I think this is important if we're looking at potential predisposing factors for who's tearing their ACL, to look at hamstring as well and make sure that we're getting like good co-contractions and we're hammering both sides of the lower extremity, the quad and the hamstring. So that is interesting, and it makes intuitive sense. I think it'd be good to see with higher powered studies if that continues to play out. But I think definitely just for performance too, that's something we're looking at, is the hamstring to quad ratio. And like you said, I think over that 60% is probably a good minimum to shoot for. And I usually say about 2/3 or something like that. Like you said, it would be very strange if it was a 1-to-1 ratio. Something's wrong with the quad. But yeah, you don't want like under 50%. That'd be bad too.
Yeah, makes total sense. Very interesting. It seems like it is still a relevant thing. So,
Yeah.
All right. So now we're looking at predisposing extrinsic risk factors. So previously we're looking at intrinsic risk factors, things like strength, things like the size of the ACL. These are extrinsic risk factors, things like weather, right? Things like shoe wear. So a different type of risk factor. This was also a recent study in 2024 entitled Extrinsic Risk Factors for Primary Non-Contact ACL Injury in Adolescents, aged between 14 and 18. So take in mind, this is 14 to 18-year-olds, different than college or professional, right? And they're examining prior risk factors linked to primary ACL injury. Similar to the last study we talked about for intrinsic risk factors, they were kind of doing the same thing, but with these extrinsic risk factors with hopefully a higher powered study, right? Because more and more studies are released over the course of time. They're trying to see if these former extrinsic risk factors that were related to injury are still going to be relevant when there's a higher powered study available. So they used 16 total studies. So the extrinsic factors they were looking at was the specific sport. So let's say soccer versus football versus basketball. This was in 8 studies. They're looking at sport exposure amount. So maybe like the total hours of participation in 5 studies. Looking at the sport level. So think about middle school, high school, and then collegiate and professional. That was in 3 studies. Looking at sport season in 1 study. Looking at in the environment in 2 studies, and looking at equipment in 1 study, things like shoes. Basically, there is contrasting evidence about associations between sport exposure and biomechanical/neuromuscular risk factors. There is weak evidence of differences in biomechanical risk factors. So essentially what they're saying in this study is that some of the prior research that was looking at, let's say, dynamic valgus when people are jumping and landing, let's say the firing of the quad versus the hamstring, some studies were in favor of this being a risk factor and some was not, right? So kind of interesting that there's been so much research over the course of time that it gets even more confusing. And one thing they did show is higher sport level may be associated with increased injury risk. And this is pretty consistent with a lot of the other studies that I saw. But I just thought that was pretty interesting that in this study, they didn't find many, if any, extrinsic risk factors were actually relevant to injury. Similar to the prior study on intrinsic risk factors, basically when they have a bigger study with more sports involved, it didn't make a lot of sense to me because essentially like it seems pretty clear that you would have more injuries in soccer compared to something like powerlifting. You know what I mean? I don't think they include any powerlifting studies, but it would make sense that there'd be a difference. I wanted to include this because this was a little bit different than a lot of the other studies that I saw, and it was more up to date. But again, it was just confusing to me. It's like, okay, this doesn't even make sense, right? Any thoughts before we move on?
Yeah, I think, like you said, it is a little bit confusing, have to dive into it, but you do hear oftentimes people say like, I think I tore it because I was playing on turf instead of grass, or I was wearing my turf shoes instead of my cleats or something like that. And, or, it was crappy weather, stuff like that. So I think we'll need more information on this, but I could think, like you said, at least this study wasn't finding anything too definitive in terms of those types of things. But I totally agree with you. Like there has to be, I wonder what those 8 studies that included different types of sports. Was it like lacrosse versus soccer versus, very similar sports? It's not going to show a difference because obviously we know that certain sports, your risk is just going to be lower. Like, I'd say a soccer goalie or a hockey goalie would have to have a lower risk than a soccer forward or like a lacrosse, attack player or something like that. So I think we could use our common sense with that kind of thing. But, interesting study though, and nice that it's new.
I know. I think one of the takeaways is maybe that these things aren't that important in the grand scheme of things, right?
Mm-hmm.
You certainly, I mean, there's research that shows like the amount of rain you get over the course of the season correlates with the risk of injury. And when it's drier, the idea is that when you plant, your foot doesn't spin as well as if it rains a certain amount over the course of the month. Where when your foot spins, the cleat will spin in the ground because the ground is softer, right? So yeah, you will find that research as well, but maybe it's not as important as we thought in the past. Maybe that was kind of my takeaway.
Mm-hmm.
So, all right. So let's look at some other risk factors that popped up a lot, and these were individual studies. So you take this with a grain of salt because the prior studies didn't really show the same results, but a lot of this makes a lot of sense to me intuitively. And I looked at a few different studies here, but essentially, does the sport that you play, your sex, and your level of competition influence your rates of injury, right? And essentially, being a college athlete, you have a higher injury risk over high school athletes. And this was consistent with those other systematic reviews. And then females were greater than 2 times as likely to be injured as males, which we know that. Okay, so that's consistent with some of those other reviews. This study was showing only 2 times as likely, although we said up to 8 times depending on the study. Also, your relevant risk is greater in basketball and soccer than other sports. For female, soccer is the number one rate of injury, and then followed by basketball and followed by lacrosse. For males, it's a little bit different. Number one is football, followed by lacrosse, then followed by soccer. And the other stat that I thought was interesting is that you were 6 to 8 times more likely to be injured during a match or a game situation compared to practice. Any thoughts on that? These studies were a little easier to wrap my brain around and a little bit more in terms of my expectations.
Yeah, I think a little more consistent, right? I agree with you there. And then in terms of, more likely to tear during a match, I think that kind of correlates with that finding that we see that higher level athletes are more likely to tear than lower level athletes. And it's probably effort related. So if you're, comes down to forces. If you're running really hard in a match, your effort level's higher. You're probably producing more force with running and cutting. And we see the injury maybe occur in that setting a little bit more. So I think that definitely makes sense.
Now that you know the background, it's time for clinical examination. Let's do it.
All right. So what we're going to cover, we have this huge slide with this little text, but
good.
Just try to space it out.
Keep those eyes nice and sharp,
Right.
Get those, followers to really squint. It's good.
So yeah, I mean, this is a pretty concise episode. I think we're really going to focus on the tests associated with diagnosing ACL. So we're going to go over the subjective examination and what you're going to hear from the patient, what questions you want to ask to rule in or rule out an ACL tear. We're going to go over the objective examination, so all the basics, but then include a special section on special tests, and then kind of putting it all together for coming up with the accurate diagnosis.
I'm so pumped.
Let's go. All right. So for the subjective examination, Dan had talked a lot in our previous episode on kind of the background of ACL tears, about a mechanism of injury. But just to kind of reiterate that and what some of the studies I was looking at were talking about, is the ACL tear often occurs during activities involving sudden deceleration, pivoting, changing direction, or landing awkwardly. Patients often report a popping sensation at the time of the injury. And as we get into clustering tests, this is one thing that they'll talk about, is if the patient does report a pop, it tends to correlate pretty highly with an ACL tear in conjunction with other things. So not in isolation, but when it's part of a big picture, it is pretty important. So you want to ask, did they feel a pop or hear a pop at the time of the injury? And I would say anecdotally, the patients I have on my schedule now with an ACL tear, they all felt a pop when it happened. So that's something to ask, again, in conjunction with other positive findings. I think it's pretty significant. Obviously, you can have a pop with like a muscle tear or, something like that. But this is something we see. A difference, kind of interesting. I didn't know this much until I was going through more of this research between meniscus and ACL, but kind of a good differentiator if you're thinking someone has some joint involvement is the ACL, or intra-articular ligament injuries, tend to present with pretty immediate swelling in the joint, and that can be within the first couple of hours. So that person might have swelling almost right away, versus the meniscus, we see a little bit of a delay in swelling. So a little bit of differential diagnosis there. If they didn't notice swelling till a day or two later, maybe we're thinking meniscus. But if they had kind of a very quick onset of swelling, maybe we're thinking ACL or another ligament in the knee. And one of these studies was saying that about 70% of patients will present with swelling. So I think if someone comes in and their injury was maybe a week ago, and they're just doing pretty well, functioning at a pretty high level, we might not see swelling, but that's going to be something that they're going to say is, I've noticed swelling in my knee. They're going to report difficulties walking or with other functional activities, potentially having feelings of instability and just a general lack of confidence. Maybe they feel okay with ADLs, but they don't feel like they could do running, cutting, explosive type movements. So these are things you're going to hear and you want to ask for in the subjective exam. So getting into the objective examination, kind of like with all our lower extremity injuries, I think it makes sense to start with like a gait analysis. And what we're looking for, like, do they have an antalgic gait pattern? Do they have pain? Are they avoiding loading their quad? Are they using an assistive device? I think these can give us insight before we perform our special tests that, yeah, this person obviously has a intra-articular, joint pathology and something we're going to be testing for. Are they fearful of movement? What's the movement quality and quantity? These are things we can document. We're going to be testing range of motion, which is often going to be limited. I think a lot of times we can chalk that up to swelling. If they do have a bunch of swelling in the knee and we're trying to flex their knee and get a good flexion range of motion measurement, we're not going to be able to get a ton of motion. They're going to feel quite a bit of pain, and the swelling is going to be almost a mechanical block to getting a full range of motion. We also want to be testing extension range of motion. Like we had talked about previously, when we are trying to rehab this thing, regaining extension is very important. And we want to compare that to the unaffected side. So we want to know how much range of motion do you have in the unaffected side? And that tells us how much of a difference there is here. And again, tells us, is this something that we think might be an ACL tear that we're trying to help the patient diagnose? I misspelled swelling, which is pretty embarrassing.
Swelling.
Swelling has 2 L's. I do know that, but we want to assess swelling. We want to do so with a sweep test, which is when you kind of provide a downward medial pressure to the medial part of the knee. And then you want to go ahead laterally and sweep it back. And you want to see how much swelling goes into that medial compartment of the knee. And we do grade that. So we kind of say if someone has a 3+ swelling, that's the most significant amount of swelling. You're trying to do the sweep test and no fluid is moving at all, versus if we do this test and we sweep it out and it comes back on its own, we call that a 2+. If we go ahead and sweep it out and then sweep it back, and I'm sure Dan will do amazing videos on this in the future for diagnosis. But a 1+ is you have to sweep it back in. And then trace is there's just a little bit of visible swelling that, would call a little less than that 1+. So we're trying to quantify that, something we can track over time. I also think it makes sense to take circumference measurements. So I like to measure at the joint line compared to the uninvolved side. I usually do about 5 centimeters above the joint line, which is that suprapatellar pouch where we do see a lot of swelling kind of hang out. And then I'll also measure halfway up their quad. So for a lot of people, that tends to be 15 or 20 centimeters up above the joint line, and then about 15 centimeters below. So we're looking at the size of their calf and the size of their quad. And that's just good information that we want to get because that's something we can track over time. We know they're probably going to lose strength. They're going to lose muscle mass, and it's good to quantify that. And then if you have the ability to, I think on that first visit, if you're thinking they have an ACL tear, you want to do strength testing on the non-operative or the uninvolved side, because that's going to give us our best strength number for their current level of function. If this injury happened only 2 or 3 days ago, then we know they probably haven't lost much strength yet. And having that number as a good gauge long-term is going to be more helpful than relying on if this person does have an ACL tear and goes on to get a surgery. It's going to be more helpful than that first strength test at like 3 months, because we know the uninvolved limb has gotten weaker. So if you do have the ability to test strength, go ahead and get it, at least on the uninvolved side. I would say I typically don't test strength on the involved side. It depends how much pain they're in. And, is it really going to tell me a bunch right now? If it's pretty pain-free and they feel like they can exert some good force in a safe manner, we'll test it. But I think oftentimes just having the uninvolved side is probably enough to get you through there. So I think before we get to special tests, these are good things we want to kind of quantify in our objective exam to, if this person does go on to get surgery or we try to rehab this thing non-operatively, these are measurements we can always come back to and see how we're progressing over time.
Yeah, I think you nailed it, because a lot of these tests are very important for the diagnosis, but we also want these numbers to help track whether or not you're making progress over the course of time. So like the circumferential swelling measurements are going to be really good. Like, oh, it's swollen, there's a chance there's an ACL, but also, is this getting better over the course of time? And like you said, we're also measuring muscle mass. Is the muscle kind of getting better? Is it getting worse? Like, what's kind of going on? What's the trend there? The other thing I will say is that we can use those pre-op numbers on the contralateral side, but also the operative side, potentially if you're going to go operative, as a guide, whether or not someone's ready for surgery. So I think that's kind of worth mentioning. So we want to make sure that that pre-op quad hamstring strength is pretty dang good before surgery, because that's going to affect those long-term outcomes. So maybe not visit one, right? But if we know that patient is eventually going to be going into surgery, we want to make sure that swelling is minimal, range of motion is good, and also that strength is kind of back to a degree. And we probably just need to do some handheld dynamometry measurements to figure out if they're ready or not for surgery, not just from a diagnostic standpoint.
Yeah, I think that's a great point. We're using this information from our assessment not only to come up with a diagnosis, but to make our lives easier as we come up with a rehab plan and make sure that we're retesting these things and seeing if we can get the patient in the optimal state for surgery. Because I'm sure we'll get into this when we look at future podcast episodes in ACL surgeries, but I'm sure there's really good evidence that the stronger you go in, and if you do some good prehab, that you're going to get better outcomes. So, that is all good information to get. But getting into kind of the nitty gritty of this episode is figuring out if our special tests are valid and what tests should we perform. Because if you tell someone you think they have an ACL tear, hopefully you have good testing to back that up, because I think it is a pretty significant diagnosis to lay on somebody. And, you don't want to say the wrong thing and say that you think they do, but then they don't, and they lose faith in you. So, looking through this research, I think you see a lot of different things. If you look up sensitivity and specificity of kind of our gold standard tests like the Lachman or the anterior drawer. So I thought this was a cool study because it's relatively new, study from 2023. And kind of special testing forms the cornerstone of the objective assessment in ACL diagnosis. And this study was from February of 2023. And it's called the Clinical Exam in the Diagnosis of ACL Injury, a Blinded Cross-Sectional Evaluation. Getting into the study a little bit, the objective of the study was to compare the effectiveness of different clinical tests for a suspected ACL injury. For the methods, the examiner evaluated and performed the Lachman, the anterior drawer, and the lever test to diagnose an ACL tear. I think the cool thing here is the examiner was blinded to the patient history, the symptoms in the laterality of pain, and at the time of the examination. So they tried to blind the examiner. I think if some of the things we said are apparent, right, they're just going to have swelling, I think you might have a good idea of what side it is. It's not generally too confusing, but I think it makes for a higher quality study. The findings were compared to an MRI, which is kind of our gold standard for diagnosis. I guess underneath arthroscopy, because some of these studies, they would, we'll talk about MRI, but the study would do MRI and then compare that to when they actually went in arthroscopically. And that's where they're really going to absolutely have a good indication of if there was damage to the ACL or not. And they're also actually using this information to see how reliable is our MRI. And that's pretty cool. So the study had 133 patients. The average age was 30 years old, but there was a range of 14 to 59 years old. So just, keep that in mind there. A summary quote here from the study in terms of the findings is that all patients with an MRI indicative of an ACL tear who underwent arthroscopy had intraoperative evidence of an ACL tear. So just before I continue the quote, what that's saying is that the MRI picked up an ACL tear and there were no false positives. Everyone that had an MRI positive ACL tear intraoperatively had an ACL tear. So MRI was really good at picking that up. And no patients were diagnosed with an ACL tear intraoperatively without positive findings of an MRI. So in this specific study, the MRI had 100% sensitivity and specificities. Every person who had one on imaging ended up having one intraoperatively. And once they were kind of in surgery, they didn't miss any. So MRI was very, very good here diagnosing ACL. And that makes me think, we never hear of someone I've never heard of anyone going in for a meniscus surgery and they say, oh, wow, we didn't know this, but your ACL was torn. But conversely, I do see a lot of people go in for an ACL surgery who had an MRI, and then the doc goes, "Oh, I didn't, the MRI didn't pick this up, but you did have a meniscus tear." So I know we're not reporting on the sensitivity and specificity of MRI for meniscus tears right now, but it's generally very, very good for ACL tears. So, that's good to know.
Yeah, I think so too, because think of all the times that we have MRIs that come back and they show so much stuff and you're not really sure what's relevant, like in the low back. My dad
Mhm.
just sent me an MRI of his spine and he's, upper there in the upper 60s. Like there's all sorts of stuff. And my first thought was like, not bad given your age, but there was like a, 30 line readout of all the different things within his spine, right? Where tendinopathies are kind of same. We find these tendinopathies all the time. Any small partial thickness cuff tears, like, are these even relevant? At least for the ACL, it's a little bit more cut and dry, right? MRI shows this. That's probably what's going on. That's kind of nice,
Totally. So just a little explanation about the studies, the tests used in this study. So like I had said, they used the Lachman, the anterior drawer, in the lever test. One that they didn't use, but I included it because we're going to talk about it in other tests, is the pivot shift. So just, I think, again, spoiler for, I think, Dan's future social media, but I assume he's going to have the best videos ever on these tests with good quality demonstrations, so you can replicate them as good as possible, because reliability here is definitely important, right? So
I'm nervous.
dude, they're gonna be the best tests. I sound like Donald Trump, right?
It's gonna be good.
All right, we won't make it political, but all right. So the Lachman test is performed with the patient in supine and the knees bent to about 30 degrees of knee flexion. You're going to, the examiner is stabilizing the distal femur, and they're providing an anterior force to the tibia. A positive test yields excessive anterior translation compared to the contralateral side. So that's the first test that they did. The anterior drawer is performed very similarly, but this time the patient is in supine with the knee flexed to 90 degrees. So that's the same position where you would do a posterior drawer looking at the PCL. And generally, the examiner will sit on the patient's foot to stabilize kind of the lower extremity there. And then they're providing an anterior force to the tibia. Again, they're looking at the amount of anterior tibial translation, compare that to the contralateral side. I'm going to jump down to number 4 because the lever test was included in the study that I was just talking about. The patient is supine, and this might be kind of a newer one, I guess, they were seeing in the research, but the patient is supine with the knee extended. The examiner will place a fist behind the proximal third of the tibia, and then with their other hand, they're going to provide a downward force on the distal femur. And a positive test here is that the heel remains in contact with the table. What you would expect is in a healthy ACL, you have your hand underneath the proximal tibia, you push down the femur, and the heel pops up. And then the pivot shift test. This test is the patient's in supine with their knee extended. The examiner will internally rotate the tibia, and then they flex the knee while providing a valgus force. And a positive test will yield a subluxation of the tibia. Sounds terrible. And when you watch videos of it, especially under anesthesia, it can be kind of gross to look at. But we're getting some stress on the ACL there, and if it's not doing its job, we see that kind of excessive movement there. So those are kind of 4 standard tests that we'll see and talk about.
Yeah, it's pretty cool. I know that Lenny's been using the lever test more. He actually had a patient the other day with a lever test on all the students and was positive, basically pushing, and then the heel didn't pop whatsoever, just because all the anterior, I don't know, laxity, right? Tibia's moving forward, but it's not popping up the heel. So kind of cool to see. My thought, and I generally don't do the pivot shift, and I've heard this, and to be honest, I'd love to look at the numbers and hear your thoughts on this, but I'd kind of seen that most of the studies reporting on pivot shift are under anesthesia. So it's like, how relevant is this when someone's actually awake? You know what I mean? It's also pretty aggressive. If you have a patient that you suspect had an ACL tear and you're just ripping on that knee, I don't know. It's pretty intense, but I tend not to use it myself as much for those reasons. But yeah, seems to be a pretty valid test. Hey, pardon the interruption, but if you're liking this content, I think I have something else that you're going to love. It's a free mini course where we go over solving some of the biggest problems that physical therapists are facing today. So what are these problems? Number 1, Failing reimbursement. Medicare reimbursement has dropped 10% over the past 10 years, despite inflation going up 32% in the same time period. Documentation and admin overload. Physical therapists are often spending significant time doing notes and communicating with insurance companies, and this is often unpaid. High productivity quotas. Failing reimbursement rates force physical therapists to see more and more patients. Burnout and poor work-life balance. High productivity demands and extra work drive burnout. Insurance-driven restrictions. Insurance companies often cut patients off before they're ready, like ACL reconstruction patients, or they won't cover insurance for certain populations. Let's say a very athletic individual. They don't care about your athlete getting back to Olympic weightlifting. Debt versus pay imbalance. The average student debt after graduation is $153,000, and our salaries are not matching this amount of debt. Lack of public awareness and referral dependence. Patients don't always choose PT first. They don't know our strengths as physical therapists, and they oftentimes will favor other healthcare providers. So how the heck do we solve this? We do this through a 6C process to help you start working towards that career of your dreams. And before we go into that, we got to figure out first, what do physical therapists want? So we want to be incredible clinicians. We want to be respected and valued. We often want to work with a specific population in a specific setting. We want to be able to practice the way we want to be able to practice. And generally, we want higher incomes. Now, given the current state of physical therapy, it makes a lot of sense that folks like you and I are upset. So in this mini course, we go over the 6C framework to get off the hamster wheel. It starts with clarity. What is the ideal patient that you want to work with? Next is connection. How do we become part of their community? Next is captivation. How can you help them with their specific problems? Next is competence. You have to learn how to treat these patients inside and out. Next is building confidence. That comes with time and reps, because perfect practice makes you perfect. And lastly, compensation. You want to get paid what you deserve. And this mini course will start you on your journey there. I help you to transform your career, start doing more of what you love and less of what you hate. This mini course is 100% free, and better yet, if you finish the course and then finish the quiz afterwards, which is nice and short, you can get 3.2 CEUs for physical therapists, physical therapy assistants, and athletic trainers. Again, it's 100% free. I'll leave a link in the description. Go ahead and click on that and download it, and I'll see you inside of the mini course. Now, back to your program.
Okay, so looking here, we have a couple tables that I took from this study. And I think if you have time to pull up the video and look at these, I think it's really helpful to see, or pull up the study. It's reference number 3 in the show notes. So definitely worth looking at, I think. But what they're looking at, and they're comparing these tests to the benchmark in this study, which was MRI. And for the Lachman, the anterior drawer, and the lever, they reported on sensitivities and specificities. And then they went ahead and they gave you a positive predictive value and a negative predictive value. So what we saw is the probably best test here overall is the Lachman. The Lachman had a fairly good sensitivity at about 89% and a specificity of about 98 to 99%. So if you get a positive test with the Lachman, it's really good at ruling in high specificity and pretty good sensitivity. A negative test, we're sitting at almost 90%. So the positive predictive value with that positive test is 97%. And the negative predictive value with that negative test is 94%. So pretty good tests there, the Lachman. Next with the anterior drawer, a little worse sensitivity than the Lachman. So sensitivity was down to about 62% for the anterior drawer. Specificity was very similar as the Lachman, about 98 to 99%. And the positive predictive value is up to 97%. And the negative predictive value is about 82%. So then the kind of least impressive test of the 3 here was a lever test. So the sensitivity for this test was 44%, and the specificity was 88%. That left a positive predictive value of about 69% and a negative predictive value of about 73%. And then this study didn't include the pivot shift. So it was those 3 that they were looking at. But I think important to note this next table, table 3 here, they're talking about what if we cluster these tests together. So what if you have a triple positive? You have a positive Lachman, a positive anterior drawer, and a positive lever. And they were saying that they had 14 patients in this study with a positive test on all three of those maneuvers. And the physician, they had 14, all 14 were diagnosed with an ACL tear by the examiner. And then the MRI confirmed that all 14% had an ACL tear. So in this study, if you have a triple positive, there was a 14 out of 14 success rate. I think it's important to note that the physician who was the examiner was very experienced clinician. So I think the examiner's hands probably matter somewhat, but keep that in mind. Now, if you have a double positive, so 14 patients were also presenting positive with a Lachman and anterior drawer. Those are two pretty good tests. So 14 patients there. And with that double positive, 14 were diagnosed with an ACL tear by the examiner, and all 14 also had a tear under MRI. If it was just the anterior drawer and the lever, if it was the Lachman and the lever, only 3 patients had positive for just those two with a negative anterior drawer. So, I think the theme here, I won't go through every single one of the combinations, but the more tests that are positive, if you have all 3 with this smaller sample size of 14 patients and a very experienced examiner, we had a pretty high confidence that they had a tear, and then the MRI confirmed that. So I think, like most of our special tests, if we can cluster, we're feeling more confident that this person probably has an ACL tear. And then we're going to let the MRI be the ultimate arbiter there. So what do you think, Dan? Are they special or no?
Super special. This is good. I think they provide a lot of good information for us, right? I think it's always tough, right? Because the patient comes in, they had this, kind of catastrophic traumatic event. It's very scary. Oftentimes these patients are very guarded. And I think one of the things that's tough is that you do these tests and you're not sure if the patient's just really guarding and you're getting accurate information from the tests. So it's good to see that they have decent specificity, sensitivities. Kind of nice to know the Lachman is kind of number 1, which is really cool. Stinks to know the anterior drawer is not very sensitive. Same thing with the lever. So one of the things that's a little bit challenging is that I wish we had better sensitive tests, because as clinicians, we're trying to make people feel good, right? And just rule these things out. So if you get negative tests, we want to make sure they have a high sensitivity, because if it was closer to 100%, if there's negative, we're like, oh, good, you're fine. But we don't have a lot of sensitive tests. It's the opposite. We have more specific tests. So we can basically give people the bad news if they're positive. But if they're negative, we're kind of like, I'm not sure. You got to go see the doctor. But I guess if we lump them together, we've got a bunch of these that are negative, it just increases our accuracy. And like you said, it probably does have a lot to do with the practitioner experience. I'm throwing my wife under the bus here, but she's a family physician. And then sometimes she does try some of these tests on her patients. And she's always like, I have no idea. I don't know if I'm doing these right. You know what I mean? And when you have a new kind of green physical therapist that has never seen a patient after what seems like an ACL tear, kind of the same deal. You're not really sure. You're not sure if you're doing the test right. Someone who just injured their knee, that knee feels a lot different than your classmates that are healthy. You do it on in class. So I think you're right. Probably has to do with the experience of the clinician. I know that in Champion, we often have a lot of people feel the knee, right? Ends up being this whole like situation, like, oh, you feel this knee over here? Let me know what you think, right? Which I think is good, but probably freaks out the patient a little bit.
Yeah. Well, one thing I'll say quick, I did skip this part, but to your point about sensitivity and if we cluster them, in this study, 69 patients tested negative with the Lachman anterior drawer and lever, so negative for all 3. All 69 were diagnosed by the physician as having an intact ACL, so they thought they didn't have a tear. And there were only 2 that ended up having a tear. So 97% they were right on 97%. There were 2 that did have a tear. So, it is important to keep in mind that isn't perfect, but it is pretty good. I think if we use it in combination with all the other objective exam findings and with all the other subjective reports, maybe we can paint that picture and get even a little bit better. But that is pretty good. I think we could hopefully, if we run those 3 tests at a high level of implementation, we do them right, that we could be fairly confident they don't have one. But yeah, none of the tests in isolation seem to be amazing at ruling out. Okay, so putting it all together, we have another study here that I think is good, because this study is talking about combining what we see in the subjective examination with what we're seeing in the objective examination. So that last study was really just looking at objective clinical tests. So this is a prospective diagnostic study. The title was Clinical Diagnosis of Partial or Complete ACL Tears Using Patient History Elements and Physical Exam Tests. The individuals were over 18 years old, and they were seeking help for knee problems. And like I said, the objective was to combine patient history with the physical exam and see if they could predict who has an ACL tear versus another knee issue. So, okay, the table's a little bit small here, but I do think this is totally worth pulling up if you do have the video playing, or if you could check out the study, because this is more real world where we're combining all the information. So the variables that they were looking at with a partial or complete ACL tear, the variables in the patient's subjective history were an absence of a fall, or an absence of like a physical trauma, like they fell and they hit their knee. So I think we're thinking more a little bit non-contact. So in the patients who had an ACL tear, that was one finding. One is a history of pivoting on the knee that caused the initial trauma. We did talk about this a little bit, but reporting a popping sensation was a variable that was pretty consistent with an ACL tear. And no or only monthly knee pain. So a lot of times I'd say this is true in the clinic, is these people have the injury, and then a lot of times the pain goes away relatively quickly. Like they're not in a ton of pain if you have a complete ACL tear. It's more a feeling of instability. And in these folks, that also the physical exam findings were a Lachman test that was positive and a pivot shift test that were positive. So they were combining all these elements. The variables that were associated with a complete ACL tear only, so not a partial tear, was 3 to 4 weeks of pain at the time of the consultation, an absence of a fall on the knee at initial trauma, so same as the partial or complete tear, a history of pivoting on the knee with initial trauma. They can't pursue their normal activities anymore. They report like, I can't play soccer anymore. I can't do my sport. They have immediate swelling in the knee after the trauma too. So I think sometimes when we don't see swelling, maybe that's someone with a partial or an incomplete tear. But if we do see swelling, maybe that's someone with more of that complete tear. And they also have a positive Lachman and a positive pivot shift. So then looking at the table below here, what the authors were doing is they're chunking the sensitivities, the specificities, the negative likelihood ratios, and the positive likelihood ratios. And if they're looking at kind of pivoting traumatic mechanism, so someone who has a pivot twist type injury, they're seeing a sensitivity of that in isolation of 79%. That's in a partial or complete tear, but a complete only, the specificity, the sensitivity is a lot higher, 95%. If we look at the specificity now, so ruling that in, a partial or complete with a pivoting twist mechanism has a specificity of 84. All right. And then, Dan, let's go to the next slide, because they kind of chunk all these things together. So I won't go through these tables too in depth. I think it's totally worth pulling up the study and kind of looking at these. But if we put it all together, what this study showed that I think is really useful is that if we have a combination of subjective findings that don't have a popping or a pivoting mechanism, and we're getting some negative tests, we have even more confidence that they don't have this ACL tear. Conversely, if we are getting some of these positive tests and they're in combination with swelling or feeling like a pop or pivot sensation, then we're getting pretty confident that they might have an ACL tear. So I think, we get some pretty good tests at ruling in. And if it combines with a positive history, we feel pretty confident. And then we don't have the best test at ruling out, but I think if we put the whole picture together, I think what this study kind of showed is a combination of subjective findings and negative testing. We feel a little bit more confident that they don't have it. And at the end of the day, you might just try some rehab anyway before they go to a doctor while they're awaiting their MRI. And then that's kind of, like we talked about earlier, we can be fairly confident in the results of the MRI for kind of ultimately ruling this thing in or ruling this thing out. So I think that's a pretty good study. And I think these tables are pretty useful. So if you go to the study and check them out, I think it's worth looking at.
Cool. Yeah. And just to summarize, it kind of seems like just with our special test based on the other study, we're pretty specific. So if we have a positive test, we're like, probably an ACL, or we cluster them together even more so. And then for the sensitivities, the Lachman's pretty dang good. It was like 88%. The other one's not quite as good. So we may miss some of these. But based on the other study that you just mentioned, if we have some of these negative subjective complaints, so no pop, plus we also have negative special tests, pretty dang sensitive. And I think at the end of the day, if I have a patient that comes in that's got a history of a pop, and they have swelling, and they have some positive tests either for the ACL or some of the other ligaments, right? Like maybe a PCL, LCL, maybe some meniscus pathology, I'm just going to send them to the doctor anyway, because we want to make sure we're not missing something. And you didn't mention this too much, but sometimes like an ACL kind of behaves a little bit like a meniscus or vice versa. So if you're thinking that it's something within the tibial femoral joint, they're swelling, some traumatic mechanism, probably going to send back to the doctor anyway. But like you said, you're going to start with physical therapy. It's not like you're going to hurt them by starting physical therapy. You don't have to stop in the tracks and send them and not come back until, you get some answers. But we can get a better idea of what's going on, and we can kind of get them started regardless. All right. Your patient has an ACL injury. Do they need surgery? Next, we'll talk about conservative care versus ACL reconstruction. In today's video, we're going over surgery versus physical therapy for ACL tears. All right, so let's summarize what we're going to go over today. First point, we're going to talk about, can ACL tears heal? This has been kind of a interesting thing that's been poking around the internet recently with some more recent research about the cross bracing strategy, which we'll go over in a bit. The next piece is, do you even need an ACL? Because for a long time, we kind of had knowledge about copers versus non-copers. And all that means that some folks do really well without an ACL, and then some don't, right? And this actually might be related to the folks that actually heal, which is kind of interesting. Next, we're going to go over surgery outcomes versus non-surgical outcomes. This is going to make up the large majority of what we're going over today. So we'll talk about overall knee health, joint stability and function, whether or not you develop osteoarthritis with surgery versus not, and also patient activity levels. One of the big issues after ACL reconstruction or ACL injury in general is that folks don't go back to their normal activity level. And this is a problem because that leads to things like sedentary behavior, worse health, so on and so forth. So we're really concerned about returning these folks back to their sports and activities. And that is important. But another big problem is these folks aren't getting back to activity. They're getting less healthy, and that's not great, right? Next, we'll talk about return to sport rates, and we'll talk about pivoting sports versus non-pivoting sports. We'll also talk about what are the most pivoting sports, the highest level of pivoting versus moderate versus low, and how it influences return to sport rates. And lastly, should your patients undergo surgery? And I think at the end of the day, you want to make sure you have a really good surgeon that you can refer your patients to make sure they're getting the best decision and they're making the best decision. But I think the other part is that I think PTs should know about this research. We can help to guide patients as well. And the other piece is that every once in a while, you're kind of saving patients from a bad decision from a surgeon that's maybe not abreast of the literature or is pushing a new strategy or something along those lines. So that's it. What do you think? Is that going to be a good one today, Kevin?
It's going to be good, man. I think the big question that I would have, and that I know others would have, is that, if we do avoid surgery and try to do this conservatively, is what's going to be the long-term risks of that, So I'm excited to see what you found.
Ooh, okay. All right. So when we're talking about physical therapy or conservative management, what does this mean? Because we know that you can do all different types of rehab protocols. The quality of physical therapy is going to go up or down based on the practitioner, provider, location, so on and so forth. So that's a problem, and it's hard to control in some of these studies. But at least in one of the main studies we're talking about today, conservative management is defined as progressive physical therapy. And obviously that's going to vary from study to study, where patients are educated on how to prevent instability after they have an injury. They also use a hinged knee brace. And we'll talk about this a little bit later. But if you want to see a very in-depth rehab protocol after someone has an ACL injury and didn't have surgery, right? So a conservative rehab protocol, You can check out the article on cross bracing because they have the exact protocol that you can follow and see what they prescribed to get these same return to sport rates, outcomes, so on and so forth. So I wanted to kind of go through a lot of that, but this is already a really big lesson. And as I was going through this rehab protocol, I was like, this is an entirely different podcast episode. We can't get too crazy, but if you want to check that out, link in the show notes, right? First question we want to try to answer is, do ACL tears heal? In common wisdom, and this is kind of what I was taught in school, is that ACL tears generally do not heal well due to limited blood supply. Did you learn that, Kevin?
Yeah, that's exactly what I learned.
Yeah. And here's the thing. We have research about whether or not these ACL tears are healing. And essentially, they're looking at ligament continuity. So what that means is they MRI someone's knee after they've had a ligament injury, and they just look and see if the fibers are continuous, right? And that ends up being a point of contention, just because when you have fibers are continuous, doesn't necessarily mean that that's a strong ligament. I think that's one of the reasons why a lot of folks are very skeptical of this newer research coming out showing that ACLs do actually heal, right? But here's the thing. If you just take individuals and put them through a rehab program after having ACL tear, only 30% of those folks will show ligament continuity at the 2-year mark via an MRI. This is based on the Canon trial. And what's funny is that we kind of knew that around 30% of folks are copers, meaning that after you have an ACL tear, complete tear, around 30% of those folks do okay. What we're finding is about 30% of those folks have an intact ACL, or they have continuity, right, via MRI. So the folks that are having their ACL heal somewhat, maybe that's the reason why they're copers, right? We're not really sure if that's kind of the point, but that was interesting to me when I read it. And here's the thing. There's something called a cross bracing protocol. It's gotten really popular recently from research from Stephanie Filbay. And essentially what happens is you tear your ACL, and as opposed to getting surgery, they just brace you at 90 degrees of knee flexion. The idea is that when you flex the knee to 90 or greater, it will slack the ACL and allow the ACL points to come together, right? So if you tear the ACL in the middle, when you bend the knee, it brings them back together so they're touching, so it can allow it to heal, right? What they found is about 90% of the folks in that study, so 72 out of 80 with complete tears, showed MRI continuity at the 3-month mark, which is pretty wild. So at 3 months, nearly 100% of those folks have continuity. And here's what's also pretty interesting and very promising, I think. So more healing on MRI correlated with better self-reported knee function and knee-related quality of life, higher return to sport rates, and reduced knee laxity. And this is pretty marked. We'll talk about that in a minute. But before we move on, any thoughts about this, Kevin?
Yeah, that's interesting. So just to summarize, the 30% was showing that that's unrelated to the cross bracing trial, right? Like that's 30% of people that do physical therapy or whatever before surgery. 30% will have some continuity of the ligament.
You got it. Yep.
Okay. Yeah. I mean, so yeah, that could be, like you said, are those just the 30% copers that are getting to that point? But that is a huge difference. 60% improvement with that cross bracing technique.
Yeah, and what I thought was really interesting is this kind of goes for a lot of other tendons in our body. If you have an injury to like the extensor tendons in your finger, if you just splint the finger straight for a while, it does actually heal back. And when I was kind of under the impression that the ACL, you can't do that, but it looks like 90% or so at 3-month mark, if you do that, it is something that's potentially allowing the ACL to heal down a bit better, right? So that's pretty cool.
Yeah, and like you said, I think the thing that we care about most is what's the function like, right? Other than just how it looks on the MRI, but that also looks interesting. It seems like there's a relationship there.
All right, so talking a little bit more about this cross bracing protocol. So like I said, these individuals had a complete ACL tear, and then they were put in this brace, mobilized at 90 for 4 weeks after the injury, and then they didn't get rid of the brace right away. I think this was something that was important for me to understand. So they're braced at 90 degrees initially to shorten the ACL and allow it to heal. And then they had a slow incremental increase in extension range of motion after that. And essentially, they continued to do that until the 12-week mark when they completely got rid of the brace. But folks are able to do more and more after the 4-week mark. At 10 weeks, they were having unrestricted range of motion with physical therapy. So they were doing things like gait training and then also strength training. So they're going through that full range of motion with these patients at the 10-week mark, even though they were wearing a brace a little bit in their off hours from PT. And then 12 weeks, they completely got rid of the brace, right? So it was 90 degrees, 4 weeks, then slowly increasing the amount of extension, slowly increasing physical therapy. And at the 12-week mark, they got rid of it 100%, right? And they actually had a pretty good physical therapy rehab protocol, at least in my book, right? And I will leave a link in the show notes if you guys want to check that out. Physical therapy consisted of lower limb neuromuscular control, muscle strengthening and power, and functional training to enable return to sport and recreational activities. What I will say, and I was surprised by this, but the rehab protocol actually pretty closely resembled an ACL reconstruction protocol in terms of timelines. So around the 3 to 4 month mark, they're incorporating some plyometrics, hopping, agility. The protocol was pretty in depth, right? What I will say is they're returning to sport activities a little bit earlier than maybe your standard ACL reconstruction, but overall it was actually pretty dang close, right? And I think one of the appealing things with the non-op, rehab from ACL would be hopefully get back a little bit sooner. But I think time will kind of tell, right? In terms of like, is that actually appropriate or not, right? It's in the infancy of figuring these things out, right? Any thoughts before we move on, Kevin?
Do you happen to remember when those patients could start either like open chain strengthening or closed chain strengthening and that type of thing? Or was that kind of, I would imagine there's a period of non-weight bearing immobilization where they really can't do much, maybe for the first 4 weeks or so. But do you remember anything about that?
You'd have to go back and fact check me, but I think it was at around the 4-week mark they started physical therapy, and at that point they were able to do some strength training. But I wonder if they were kind of limited in terms of their range of motion early on, and they were allowed more over the course of time. You'd have to go back and check that out. We probably just need to do an entire podcast on it. It's just so much. Yeah.
But kind of similar to other surgeries. So, a little bit conservative early on, but then you could start doing more in PT, but you're still braced at home and that kind of thing.
Yeah, I was surprised just by how close it kind of mimicked the regular ACL reconstruction protocol, because I thought it would be very different, and we'd have to kind of like talk about the nuances, but it's pretty dang close. So I thought that was interesting and probably good, because you probably want to see similar rehab protocols, the non-op versus operative, just to kind of control things a little bit better. And I think they did a decent job of that. All right, so some more data about this cross bracing strategy. So somewhere between 5 and 18 months afterwards, it was variable, I guess, based on the individual. There was around a 14% ACL re-injury rate. And we'll talk a little bit more about re-injury rates, but they're as high as like 40 to 50% in some sports, right? So 14% isn't too bad. But then again, if you have certain populations that don't play sports, it's probably lower than that. So hopefully we'll have more data over the course of time comparing a cross bracing strategy versus just regular ACL reconstruction, bone, patellar tendon, bone as the gold standard to kind of see. Another thing I thought was interesting is that there were some DVTs, right? So one of the problems by bracing someone at 90 for a month and they're not moving at all is potential DVT. And that was interesting because as soon as I heard about that cross bracing strategy, I was like, I wonder if there's any blood clots. And well, there were 2. So that's something to be on the lookout for. Obviously, there are blood clots with other surgeries as well. So I don't know if it's more or less generally than other ACL reconstruction. That seems a little high to me, but obviously I'm not sure. So the other thing that was interesting, and we are noted towards this, but ligament continuity correlated with better ACL OA scores. And this is an MRI injury scoring system. I had to look into this a little bit. So they're trying to grade the health of the ligament based on the findings from an MRI standpoint. And what was interesting is that if there was continuity of the ligament, that had much better outcomes. So if you had ligament continuity, had a 92% return to sport rate versus 64% without continuity. Normal knee laxity was 100%. in the folks that had continuity and 40% in the folks that didn't. And then knee functioning and quality of life, well, those are both better with continuity. So if it did heal, people tended to do better, right? And the last thing I will say is that you may not need an intact ACL to successfully rehabilitate, right? We kind of know that from prior studies, copers versus non-copers. But what might be happening is that the copers are actually having some ACL healing, and we just didn't know that at the time. Any thoughts with that, Kevin?
Yeah. You may have said this, but do you remember is there like an age range for the patients that were used in this study, or an activity level?
Yeah, I don't want to misspeak. I want to say like 25 to 35, but then again, like I'm not even sure if that's right. I looked through so much research recently. You have to
Yeah.
go back and fact check me. What we probably
Yeah.
need to do is get her on the podcast at some point, hopefully. Yeah, it's a good study. It's very interesting.
Yeah. And I would say that, just keeping that in mind, I guess, like you said, it really depends on the sport, because certain sports, the re-tear rates are so high, especially in certain populations, like an adolescent female. But 14% re-tear or re-injury rate is really not that high in the ACL research world. So, depending on what they're doing, that is fairly good.
Yeah, I think they had a large variety of sports too. And I
Mhm.
imagine like the level of activity is probably important, right? And then the specific sport, obviously, we know is important too. We can talk about that a little bit later as well. But yeah, just more research needs to be done. But overall, this was pretty interesting. I can see why people are very pumped about these studies coming out. All right. So, what about surgery? What the heck is surgery for the ACL? So, if you've treated patients in the past for ACL issues, you obviously will know this. But essentially, the most common surgery for a torn ACL is going to be reconstruction of the torn ACL. So, it's not a repair, although we will talk about repairs in the future. So, what they do is they try to reconstruct an ACL, and this is with a graft, right? And they can take the graft from a variety of different places. So you can take the graft from the person, right? So the person had the ACL surgery. You can take the graft from that person. This can come from the patellar tendon. It can come from the hamstring tendon. They'll often combine the hamstring tendon with the gracilis, right? I'll call that a double bundle. So essentially, they combine the hamstring with the gracilis, semitendinosus, and gracilis to make the graft. And the new kid on the block is going to be the quadriceps tendon. And what's also interesting is that you can have, let's say, a patellar graft. What's interesting about patellar tendon is that it attaches bone to bone, side to side, and there's essentially not a lot of space between the tibial tuberosity and patella. So they can harvest that, and they can put that right inside of the knee. And you have two bony blocks, and the thought is that those bony blocks actually heal down better than if you just put the tendon into the bone, right? So you can do the same thing with the quadriceps, but what you'll also see is are completely soft tissue grafts. So you can have basically a chunk of bone from the patella followed by the quad tendon that they harvest, or they could take 100% soft tissue, which I think is more common. It's definitely what we see more of. I was talking to Lenny at Champion, who's one of my coworkers. He's like a ton of ACLs, but I think the majority of surgeons, when you hear about a quad tendon graft, it's all soft tissue. It's not actually taking that bony block. Get ahead of myself, but one of the thoughts was that the bony blocks heal a bit better, but more subsequent research has shown that there's really not much difference between having the bony block and not. There is some subtle differences, but I think that has changed over the course of time with our understanding. You can also have a graft from a cadaver, and we'll talk more about this, but the cadaver graft can come from a whole bunch of different places in the body, which is interesting. And if we are going to be looking at the studies in the next few slides, which we are, I don't know which, if we, I don't know why I said if, we're definitely going to look at them. So looking through these upcoming studies, when they're comparing surgery versus conservative care, they're looking at reconstruction for the large part. They're not comparing against repairs or this bridge enhanced ACL repair, which we'll talk about as well, right? The other pieces that you may see these pop up here and there, not very common, but you can repair the ACL. And we'll talk about this in the next podcast. And another new kid on the block, and this is actually occurring mostly in Boston, which is interesting, is the bridge enhanced ACL repair, where they will repair the ACL, but they'll also put a scaffold in there to try to get the ACL to heal, which is very interesting, which seems promising so far. But we're not talking about this surgery, okay? We're talking about ACL reconstruction versus non-op folks, right? That making sense over there, Kevin? You hanging in there?
Totally. Yeah, makes tons of sense. And I think, like you had said, that's the majority of what folks are going to see. The bear seems to be gaining some traction. But in my 6 years of being a PT, I haven't seen any repairs, primary repairs, but I have seen a couple bears. But like you said, we're in Boston, and I know that's kind of where it was originated. And we're still seeing the large majority being reconstructions, but that repair is something else that I think people are seeing a little bit more of, specifically the bear.
Yeah, and I also say I'm not sure why there's a doc at HSS that likes to repair, right? And for the right candidate, I think it'd be a decent idea. I'm not trying to say it's bad or anything like that. I think Lenny has seen one patient with a repair, but very uncommon. And we've seen a couple now at the bear. I want to say 2 or 3, something like that, but still pretty uncommon mostly. So just a little background on ACL injury types. So when you have a sprain injury, you can have a grade 1 sprain, or you can have a grade 3 sprain. Obviously, it's grade 2 as well. So essentially, if you have just a grade 1 sprain of the ACL, you treat this conservatively, right? The grade 1 sprain of the ACL is defined as the ligament is stretched slightly, but the stability of the knee joint is not affected. Grade 2 is also generally treated conservatively. This will encompass partial tears as well. But a grade 2 is described as a stretch of ligament to the point that it becomes loose. This is also referred to as a partial tear, as I mentioned previously. In grade 3, this is generally treated surgically, and this is the ligament being completely torn into 2 pieces. The knee joint is no longer stable, and this is actually the most common type of ACL injury, and it's what we're talking about today. So if you have a grade 1 or a grade 2, is this a problem? Will you see these from time to time? Yeah. But these are usually not the folks where we're really concerned about, are they going to get surgery or not? So if I have a grade 3, one of my first thoughts is like, we need to go to the surgeon. We got to figure this out, right? I'm not thinking like conservative treatment right away. We're trying to figure this out. Anecdotally, I treat very few to no patients that have had a complete ACL tear, and we've made the decision to treat them conservatively. Have you treated any of these folks completely conservatively, Kevin?
No, just pre-op, but not with the hopes of avoiding surgery. But I have a feeling if you ever tore your ACL, you'd be recommending non-operatively.
Yeah. I've accidentally treated a few folks that had a complete tear of their ACL. Some older individuals who were having some pain, were treating them, didn't think anything was going on. They go back in, get an MRI. That ACL has been gone for years, right? They had no idea. And a few athletes, too, that have retorn, and they just didn't know and kind of rehabbed a little bit on their own. Think of one individual champion right now who plays at a very high level, tore his ACL a couple years back and is still playing at a professional level in sport, which is pretty cool, too. He definitely has issues that he's dealing with on a regular basis, but I'm not seeing patients wanting to go conservatively, usually after a complete ACL tear. So interesting. Who knows? The future will kind of show more, but it's not something I'm seeing.
I would say that's right. I can think of, now that you say that, a couple older folks who maybe had an allograft when they were younger, and I don't know if it's higher in allografts or anything like that, but then they will have a subsequent MRI just because they're having knee pain as they got older, and they'll find that their ACL is torn or gone or whatever. So yeah, those folks seem to be, having maybe different types of knee pain unrelated to that, but they tend to be pretty surprised to learn they don't have an ACL, which is kind of interesting.
Yeah, it's like, well, what do you want to do at this point, Because they pretty much got on with life for years and they've been okay. So
right, exactly.
Do you want to go for it or not? So we're going to be going over this study here, and it's called Conservative versus Surgical Treatment of Anterior Cruciate Ligament Rupture, a Systematic Review. So this is pretty cool because it's in 2024, and they went over a lot of different studies to try to figure out, basically, should you get surgery? Should you not? Should non-surgical management even be a thing, right? And here's one of the big takeaways from this study before we get into the details. I just took this quote directly from the study. Current literature does not conclude whether operating on patients with an ACL injury is more beneficial than not operating, In addition, there's no clear consensus on whether surgery benefits certain patient groups more than others. Clear evidence-based guidelines must be introduced to avoid unnecessary surgeries. Crazy statement. Another statement here, this literature review evaluates whether surgical management of ACL injury is superior to non-surgical treatment. You ready to dive in, Kevin?
Let's do it, man.
Let's do it. Okay, so this study was looking at 5 different papers, total of 462 patients. They were greater than 15 years old. One of the issues is that you had mentioned this previously. It's important to know the population, just because some of the studies contain younger folks and some of the studies contain older folks, and that's going to give you a different outcome, right, based on the individual. They're looking at ACL tears that were complete, so no sprains in this study. And they're looking at ACL reconstruction or conservative management, which we defined what conservative management was previously. Obviously, it's going to be a lot of variation from paper to paper, individual to individual, where they're going to physical therapy, so on and so forth. They're looking at autografts and allografts, which ends up being a bit of an issue because we know there's a difference between autograft and allograft outcomes, right? So that muddies the water some. Essentially, PT group received PT education about instability, reduction, I think the hinge brace as well. In terms of outcome measures, we're looking at overall knee health, joint stability and function, development of osteoarthritis, which is important because after you have an ACL injury, regardless of what you do, usually those folks tend to have more osteoarthritis moving forward in the future. And also patient activity level. Like I said previously, this is a big problem we're starting to find out more and more. After you have an ACL tear, your activity levels go down. Health goes down. It's not a good thing, right? So if we have a surgery, is that going to be better than if we don't have surgery for long-term activity levels? All right. We also looked at return to sport timelines in this study. So differences in patient outcomes for surgical conservative management between professional athletes and regular individuals. The exclusion criteria were multi-ligament knee injuries and also having a history of previous ACL injury. And then from an outcome measure perspective, they're looking at the IKDC, the Tegner-Lysholm Knee Scoring Scale, and the KOOS, right? So we had a variety of different outcome measures, and they're looking at a whole bunch of good stuff in these studies. So Sukas et al. Was a prospective cohort study, and they had all males, no females, which is kind of a problem, 32 total patients. The average age was 32. And the follow-up period on average was 10 years. Kessler et al. Was looking at 68 males and 41 females, average age of 30.7, and the follow-up period was 11 years. So it's quite a bit of time to expire. Frobel et al. Randomized controlled trial, 32 females and 89 males. Average age was 26. And the follow-up period was 5 years. And then Sandberg et al. Another randomized prospective study, 200 patients, average age was 28, and that follow-up period was 33 months. So I think that follow-up period is particularly important just because you need time to develop osteoarthritis. And I think the other thing that's important is that these folks are actually pretty young, so it takes time to develop. And I think age is a big variable with folks that have or are going to get osteoarthritis. So we probably need a lot of time to expire to see whether or not these folks are gaining osteoarthritis or not. I think some of these studies were decent, but I would love to see 20 or 30 years out. When you're a young individual, so if you're 20 years old and you have an ACL injury, it's still going to take quite a bit of time to develop osteoarthritis. And these studies were looking at that somewhat, which I think was good. But obviously, we want to follow these folks out longer to see if there is a major difference. All right. So, Kevin, do you think there were differences between the groups?
I'm going to say there were maybe some small differences.
There were a few. Let's go through a couple of them. So the Sukas study and the Kessler study, they showed that surgery had a higher IKDC score. The Sandberg study showed no difference between the Tegner and the Lysholm scores. Conservative patients reported more giving way versus no giving way in the surgical group. For Frobel, these individuals were older, I believe. There's no difference in the KOOS. So for pain, symptoms, function, quality of life, or sports, might be because they're older, who knows? And then from a knee stability standpoint, the Frobel study, the conservative group, 33% had normal Lachman and 40% had normal pivot shift. So it makes sense. They have no ACL anymore. They're probably going to have positive special tests. In the operated group, 76 had a normal Lachman test and 76% had a normal pivot shift. It's kind of wild. About 25% of those folks still have positive special tests even after ACL reconstruction. But yeah, it seems largely that outcomes are similar between the groups, which is pretty interesting. And then the group that doesn't have an ACL, they seem to have a little bit more laxity. That's kind of what I found overall. Is that surprising to you, Kevin?
Yeah, I think that, one thing that pops out there is on that last one is that, like you had said, that still means about a quarter of them potentially had a subsequent injury to their ACL, maybe without noticing or maybe with noticing. But, that does kind of line up. You see anywhere from 10 to 25% of reconstructions fail or you re-tear at some point. The other thing I think is that the study is obviously trying to answer some important questions. And like you said, one of the merits of it is that it looks a little bit longer term when we might see, obviously right after surgery, those folks are probably going to be doing pretty well, like 2 and 3 years out. But what does it look like as we get a little bit longer out of that surgical timeline? But I think this study, like a lot of other studies, if it does pile together groups of different individuals, with different goals and activity levels, it does make it hard to still parse out what the best option is, right? Because, I think it was over 15 years old was the criteria, right? And then there were maybe one of the exclusion criteria was a multi-ligament injury, but, it didn't mention if there was a meniscus injury or anything like that, right? So it's just the more specific the studies can be, the better we can apply to your specific patient, right? So the 17-year-old female going back to senior year in high school or going to play college sports, I think, finding those specific studies to look at that person. But I think this still, really gets the gears turning about questioning what we've always thought, that we need to do surgery because some of these outcomes, are pretty decent non-surgically. I think we just need to continue to get better studies over the course of time that make it more specific, because that's what I would envision, right? There's going to be best practices for each individual. And if you can match them to a study cohort, I think you can help that person as much as possible.
Yeah, without getting too crazy, there's so many variables influence things like re-tear. And then if they're not being controlled in future studies, when you're trying to compare conservative versus surgical, it's a little tough. It's pretty challenging. Maybe now that we have this knowledge, though, ACL is interesting to me because there's a crazy amount of research. Like when we were doing our deep dives, our literature reviews, we're like, oh my God, this is crazy how much research is coming out. And it's good. That's a good thing. And now that you have the cross bracing protocol coming out, I know that Phil Bay, that their group, they're doing lots of additional research, which is really cool, right? So hopefully this, research will continue at the same rate, and we'll get more of these questions answered because it's important, right?
Yeah, I actually tell that to a lot of my ACL patients is like, I'm so sorry this happened. It's such a bummer. But one of the bright lights of it is that there's so much research for this condition that, it allows us to know what to do better to help you. It's not one of those very obscure things that is never really studied. It's one of the probably most studied, I would say the most studied sports injury that I've come across. And it has to be one of the most studied musculoskeletal injuries. So, there is a lot of information out there, and parsing through it all is definitely challenging.
Yeah, it's not like Pez answering pain where there's one study on physical therapy, and physical therapy consists of ultrasound with no control group,
Yeah.
All right. So from the Tegner activity scale standpoint, the Tegner activity scale, if you listen to our meniscus podcast, is essentially what level of work or sports activity you engage in. So a really high Tegner activity scale would be you're getting back to professional sports. And then a really low would be like you're sedentary with a lot of disability going into the surgery, right? So Sukas in 2016 found a slight drop in the conservative group. So essentially, conservative group was not able to return back to the same level of activity. Kessler in 2008 found no difference. Frobel found a significant benefit in the surgical group at 2 years, but no difference at 5 years. Then Sandberg found a significantly greater return to sport timeline for the surgical group. So a little bit mixed, a little bit all over the place. So kind of interesting. And then laxity testing. So this is important. We learned about KT 1000 testing back in school. I find that not a lot of folks know this coming out of school anymore. Did you learn about this, Kevin?
I did. Yeah, I remember learning about this.
Yeah, so just use a machine to assess the amount of laxity within the knee joint, right? To see like anterior translation and see if there's a difference, in norms or on the contralateral side. And there was significant increase in laxity in the conservative groups overall. And I think a big takeaway with a lot of this research is that the conservative group tends to perform similarly to the surgical group in a lot of areas, but not laxity. Seems like these folks still present with significant objective and subjective laxity. So they feel the laxity, and then it's also being picked up when they measure it. From a physical activity standpoint, Suka, Sandberg, and Kessler all found that non-operative patient satisfaction with their ability to participate in physical activities decreased more with time than the operated group. Next, osteoarthritis. This one's particularly interesting to me just because one of the main reasons I would consider surgery versus not would be the long-term health of my knee. Am I going to have more osteoarthritis if I don't get an ACL reconstruction? I mean, logically, it makes sense. If you don't have an ACL, you're not going to be able to control motion within the knee joint as much, causing meniscus pathology, causing more osteoarthritis, right? Is this what the research is showing? So Nebulung et al. Showed increased risk of high-level athletes with definitive unstable knee developing cartilage lesions over 20 years. And then Sherman et al. And Naret et al. Reported that chronic knee instability leads to cartilage degeneration. Newman et al. Found osteoarthritis in 51% of men and 41% of women with ACL injury after 12 to 14 years. So as I said previously, we know that when you have an ACL injury, and this is going to be with ACL reconstruction as well as non-op, right? You're going to have an increased risk of osteoarthritis. We know that. And that's unfortunately a side effect of having an ACL injury that we would love to be able to correct, right? But here's what's interesting. Despite the evidence supporting the importance of an intact ACL in decreasing the risk of cartilage degeneration, the literature does not prove that reconstruction reduces the risk. So essentially, you tear your ACL, probably going to have more osteoarthritis, but getting the reconstruction doesn't seem to change that. Sukas in 2016 showed no significant difference in osteoarthritis between the groups, and this was going to be radiological arthritis as well as symptomatic arthritis via the KOOS. Kessler in 2008 showed significantly more osteoarthritis in the surgical group, which is very interesting. You'll find some studies where the ACL reconstruction creates more osteoarthritis than the non-op group. And Frobel in 2013 showed no difference between the groups, and there was an insignificant trend towards more osteoarthritis in the surgical group. So this is super interesting, Kevin. What are your thoughts on some of this data?
Yeah, I was actually talking to our PT student at Champion yesterday, Gavin, about this.
Go, Gavin.
Shout out to Gavin. He's doing great. I love Gavin, but he had ACL reconstruction himself, so he's really interested in this stuff and trying to figure out that long-term risk of arthritis. And I think some of the things you said there just make me wonder if there are different mechanisms for arthritis in those two different groups, right? Because the group that has more instability, those folks maybe being managed conservatively with that instability over time might lead to more arthritis. But then surgically, I think depending on the type of graft, I wonder if, just totally wondering here, if allografts have a little bit less arthritis because you're not drilling into the bone as much and harvesting other tissue and, the portal holes that occur with the grafts during a reconstruction, that, that's going to create a lot of trauma in the knee. And then you have that period of months of swelling and pain. And, is that cascade that's causing arthritis a little different than the instability over time? So, it is interesting. And you wonder if with a good rehab program, conservatively, you can reduce some of that instability, but it does seem like you're going to have it in, I guess, which one's going to lead to more arthritis over time is the question. So either way, it doesn't seem phenomenal for the long-term health of your knee.
Yeah, and we'll talk about that a little bit too, because that is one of the potential benefits of the repair or the
Hmm.
bear procedure too. And we do have some preliminary research in animals showing there's less osteoarthritis than a reconstruction. So that is pretty interesting. The other thing that goes through my mind, and this is kind of coming from the OptiKnee paper from Whitaker, I know she talks about this, but you're more prone to sedentary behavior after you have an ACL tear, and that's going to be surgical and non-surgical, and that's a problem. And we know that having higher body weight is a big problem for knee osteoarthritis. It's one of those big risk factors. So maybe it has something to do with their lifestyle, what happens after the injury, and not necessarily that they're not able to control motion within the joint. It might be that accumulation of body fat, the pro-inflammatory nature of body fat, creating more arthritis over the course of time. Who knows? Just a thought, right? Obviously, the injury by itself creates trauma in the joint. Surgery also creates trauma as well. So maybe it has something to do with that. Hopefully, time will tell. We can figure these things out a little bit better, get some better long-term outcomes for our patients. All right. So just a couple of concluding remarks. Frobel concluded that there's no difference generally between surgery and non-surgery. And this goes for symptoms, knee-related quality of life, general physical or mental health status, daily activity function, function sports, return to pre-injury activity level, radiographic osteoarthritis. In this study, and this is important, athletes were excluded, right? So largely, if you're a non-athlete, then maybe there's no difference. But the other really important thing that I found in this study, which I thought was funny, 51% of non-op group patients went over to get a future surgery. It's kind of like, all right, well, is this really a great option if more than half of folks are getting additional surgeries? And I don't think it was all folks going on to get ACL reconstruction in the future. It was other surgeries as well. So things like meniscectomy, repair, potentially that type of thing. But yeah, I just thought that was an interesting thing to note. Fink in 2001 said conservative patients that return to sport had increased osteoarthritis and may benefit from earlier ACL reconstruction. So there is still that thought that if you want to get back to sport, and we'll talk about this a little bit later, ACL reconstruction may be the way to go. And that's kind of the way it goes now. From my experience, if you want to get back to a pivoting sport, docs are going to say, yeah, get the reconstruction. That's kind of the way to go, generally speaking. Okay. A couple important limitations of this study, just because right now there's a lot of hope, I'd say, in terms of conservative management of patients that have a complete ACL tear. And I think that's warranted, but there are some major limitations of this study. So when you see these really nice outcomes in terms of very similar return to sport rates and satisfaction and outcome measures, you have to keep in mind that these studies aren't perfect. So there are different lengths of follow-up in each study. Like I said, there's like between 2.5 years and 11 years. Maybe that changes over the course of time. There are different ways of measuring these outcomes used in each study. Despite that, some common ways between some studies were used, right? So different outcome measures in general. Can't always say that one outcome, saying the outcome measures are good in one study and they're using a completely different outcome measure in another study. They might be dissimilar from that reason. Different surgical techniques and different surgical teams with experience levels not specified were used in these studies. Like I said, there's autografts, there's allografts. We know that those have different outcomes. They weren't controlled for. Rehab protocols were not specified. That's a problem because rehabs can be very different across the board. Only 5 papers were eligible, and I thought this was crazy, right? And they included only one randomized controlled trial, which we need more of those. I think one of the reasons why they didn't have more trials was because the search results were restricted to only open access articles, which when I heard that, I was like, how relevant is this entire article, right? And that's a big problem, I think, for researchers right now, is that we have to have more access to papers. This is stupid, right? There's a giant paywall out there that's keeping us from being able to figure out things that we need to figure out, which is kind of crazy, right? And the muscle strength and pre-injury activity level of patients in some studies were not specified and were not accounted for. This can affect outcomes and recovery. And all papers had a mean age between 25 and 35 years old, but Sandberg et al. Included patients up to 61 years old, which possibly affects the comparability of the results. If you have a bunch of 61-year-olds, do they need their ACL? Maybe not as much as the 20-year-old, right? But you're comparing these results across all these studies, and it's like comparing apples to oranges in some ways. Any thoughts quickly before we move on there, Kevin?
Yeah, I think those are important to keep in mind because, I remember when the cross bracing paper kind of came out, you see on social media, people either love it or hate it without really considering all the nuances of the paper and the limitations and those types of things. So I think it requires a deeper dive to try to get these answers rather than just looking at the abstract, right? And figuring out, always asking how this information applies to the person in front of you and trying to see if the studies that you're looking at match that, the patient that you're working with. So, overall, I think it's interesting information and things that we need to consider and be on the lookout for as more and more research emerges. But keeping the pros of the paper and some of the limitations of the paper in mind are always important.
All right, let's go over return to sport. So these numbers are coming from Keys et al. In 2022. A little history before we talk about that. Return to sport rates after ACL reconstruction are generally poor, so less than 50% in some studies. That's some studies, right? That's a pretty bad number, but generally they can be quite poor. ACL reconstruction versus non-operative management are generally similar, which is kind of crazy at the 1 year mark. So this study had 101 papers with ACL deficiency. They had 56 patients in the ACL reconstruction group, and they followed up 9 years after the surgery. They had 45 patients in the non-op group, following up at 11 years afterwards. And their question they want to answer was, are long-term follow-up results same as short-term follow-up results? So basically at the 1 year mark, or looking at the short-term outcomes, does that stay the same after 10 years, right? Because maybe if you have ACL reconstruction at the 10 year mark, that outperforms, let's say, conservative care, but at the 1 year mark, it looks exactly the same. I'm going to give you a bunch of numbers here. And the first number is going to be the reconstruction group. And the second number is going to be the non-reconstructed group. And these are all return to sport rates. So reconstruction group, 96% versus 93%. And the non-reconstruction group continue to play sports. So they get the 10 years, and then the large majority are still playing sports. So 4% versus 7% did not return to sport. 8% versus 17% return to safer sports. So safer sports generally means things like weightlifting and running, right? 13 and 12% return to running. 20% versus 26% return to sports involving twisting. 12% versus 24% return to recreational pivoting sports. 43% versus 14% return to competitive pivoting sports. And I tell you what, that's a pretty big discrepancy there. And the authors found the only significant difference was return to competitive pivoting sports. And the folks that had the reconstruction had 3 times the rate of returning to these competitive pivoting sports compared to the non-surgical management group. After hearing those stats, Kevin, any thoughts pop up out in your head there?
Yeah, I think that just is kind of in line with what we've been saying a little bit throughout, is that the specific cohort matters. And perhaps it's that group that's playing more competitive sports that might be a better candidate for a reconstruction. And those are the people that I think doctors are probably telling that they should have a reconstruction instead of managing it conservatively. So yeah, I think that's not surprising. And that's probably why you see such a big difference there, is the reconstruction for the group of people playing sports like that, competitive sports, is still the gold standard.
All right. So my next question, and I think this is actually really relevant for physical therapists, is that what is a pivoting sport, right? There's a lot of sports out there, and some sports probably pivot more than others. And if you start to break down these return to sport rates based on the amount of pivoting, does that change things a little bit? And I was able to find a little bit of research to help out from that standpoint to see what the return to sport rates are for different types of pivoting sports. And what was kind of cool is they broke down pivoting into different levels. So level 1 had the most amount of pivoting. This would be sports like soccer, handball, floorball, and basketball. I don't know what floorball is, and I have an idea of what handball might be, but soccer and basketball at least makes sense to me, right? Level 2 pivoting sports were racket sports, so things like tennis, alpine skiing, snowboarding, gymnastics, and aerobics. And what I thought was very interesting is that racket sports and skiing were level 2 pivoting sports. compared to soccer, which is a level 1, which we'll talk about the relevance in a second. But they're basically saying that racket sports are less pivoting than something like soccer. Level 3, these are supposed to be non-pivoting. And at least a study we're going to talk about in a second, they didn't study these folks. This would be running and lifting, right? A study by Grindam in 2014 showed non-op return to sport level 2 and 3 was greater than the operative group. So this is interesting. If you take patients and you don't do ACL reconstruction, right, their return to sport rates are actually greater for level 2 and level 3 sports. And that includes racket sports, skiing, snowboarding, gymnastics, aerobics, running, and weightlifting, which kind of blew my mind because the main reason why we see, I don't know, one of the major populations we see ACL reconstruction is skiing, right? So the first thing that popped into my mind was, wow, these folks actually do pretty well non-operatively. And alpine skiing is a different sport, which I honestly don't know all the nuances about, but I was surprised to hear that the return to sport rates were similar, if not even better, in the conservative group. And overall, there was no difference in return to sport rates in ACL reconstruction versus the non-op group. However, in the non-op group, the return to sport rate for level 1 sports was 55%, and the level 2 sports, it was 89%, right? The interesting part about this is that the level 1 sports, prior to deciding whether or not they're going to get surgery, they were told not to return to sport if they wanted to get back to a level 1 activity. So one of the problems with a lot of these studies is they actively dissuade patients from returning back to sport if they want to get back to a pivoting sport, and or if a patient wants to get back to pivoting sports, they're telling them to get an ACL reconstruction. So that's a little bit of a problem from a study design standpoint because you're naturally excluding patients from certain things from what the surgeon ends up telling them from the get-go, right? But I thought this was very interesting in that these level 1 pivoting sports don't do as well, but the level 2, level 3 do pretty decent. And this is a total anecdote, and I was talking to my wife about this the other day, but she worked at Breckenridge as a physician for a little bit, and they just see like ACL injury after ACL injury after ACL injury all day long from folks tearing their ACLs. And what's interesting is you see a lot of folks that don't get their ACL reconstructed, and they get back to higher level skiing, right? And there's quite a bit of them just because injury prevalence is so high in skiing, and some folks just get on quite well. But what's also funny is that I think we even have some on our schedule right now. Like we see a ton of patients that have ACL reconstruction because they want to get back to skiing, right? But this research is kind of showing the opposite. And I'm not saying this is the best study in the world, but it's showing that folks are able to get back to skiing at a pretty decent rate. So I thought that was pretty interesting. What are your thoughts there, Kevin?
Yeah, I guess the question that pops into my head is that the study was looking at 1 year out, right? So you wonder if the people who underwent reconstruction maybe weren't hitting their return to sport tests yet at 1 year. So they were delayed in returning versus the non-operative group. It makes me wonder if they're being as closely monitored in clearing return to sport testing before going back to something like a pivoting sport, like a level 1 pivoting sport. So those are just questions that pop in my head about that. But I think the other thing is that just looking at ACL studies in general, I think it is important that the papers are kind of grouping people by these return to sport categories in type of pivoting sport, because, you know, like I said, they didn't include running in this or weightlifting, but, you know, those folks are going to be able to get back way sooner generally than a year, you would think, right? So when you do see these ACL papers, I think that's something good to look for, because a lot of times they do break them up by those types of groups, like a level 1 pivoting sport versus a level 2 versus a level 3. So, you know, that's something important to look out for, because you don't want to just go by the recommendation of the average return to sport rate is 9 to 12 plus months. When you do have a weightlifter or a runner, I mean, that's going to be a lot sooner, which is good.
All right. Next question. Does a complete ACL tear increase your risk of meniscus injuries? So, Kevin, did you learn that if you have an ACL tear, complete tear, and you don't get surgery, you're going to have more meniscus pathology over the course of time?
It's a great question. I'm not sure if I learned that, but it's something that I definitely think about. And vice versa. I wonder if you have a meniscus injury that's non-op, if you have a higher rate of ACL injury. But what did you find here?
Yeah, it's this one was interesting to me, right? And like, if you look at the definition of osteoarthritis in the knee, depends on how you're grading it, but just that having a chronic or degenerative meniscus tear does classify as osteoarthritis. You know what I mean? So some of these studies were showing no difference in osteoarthritis. So thought is like, are these folks actually getting more meniscus tears? At least that's something that was going in my head. And there is prior research showing that if you have a complete ACL tear, that increase your risk of meniscus injury. I've definitely read through some of that research, right? But this was interesting because this is more recent research. It's a study from 2023, and they're just looking at delayed ACL reconstruction versus immediate ACL reconstruction. I want to say it was at the 2-year mark. The folks had the delayed ACL reconstruction, right? And what they found is that there's no difference in meniscus pathology over a 2-year follow-up period, right? So essentially, the folks that got the ACL reconstruction versus the groups that didn't, 2 years later, there's no difference in meniscus pathology, right? So their conclusion was that the ACL reconstruction can be delayed without increased risk of meniscus pathology, right? Which I thought was pretty interesting because it kind of goes against what I had learned, right? I want to say I was listening to, again, Stephanie Philbay as well as Whitaker talk about some of this data. And they were asked this same question: does a complete ACL tear risk increase your risk of meniscus injury? And they said, at least one of the individual authors said this, I don't remember who it was, I think it was Whitaker, said it doesn't increase your risk of meniscus injury. And I thought that was interesting. So the first thing I did was I went back and tried to read the study and see, right? And yeah, that's what they show. But here's the thing that was a limitation, big limitation in my mind. So do patients return to their prior activity level after having the injury, right? And one of the big limitations that activity levels following injury were not reported in this study or prior studies showing increased meniscus injury risk. And lower activity levels may reduce injury risk. So if I have a complete tear in my ACL and I go out there and I play soccer, right, I might have an increased risk of meniscal injuries potentially. But if I tear my ACL and I don't do jack because my surgeon tells me not to engage in level 1 pivoting, which happens all the time, right? Don't do a whole bunch of athletic activities until we get this reconstructed. I think this is a little misleading as a study. And at the end of the day, we have to kind of control for activity levels after the injury because it makes no sense at all to me. You can conclude that going back to all of your activities is 100% safe when they don't even report that, right? And two things, right? As long as you're not going crazy with your activity levels after you have an ACL injury, it's probably decent advice to tell folks that it's okay to delay this, right? But if you go back to something like soccer, maybe that changes your risk. It's just that we don't know that yet. Do you have any thoughts on this, Kevin? I thought this was pretty interesting. It was kind of went against what I had learned previously.
Yeah, I think what you concluded there is kind of a theme of a lot of these studies is that they're trying to answer complicated questions, and thinking about the results after you read them is important, like you did, right? So it's important to think a little bit deeper and think about what are the limitations of the study, because yeah, if you're reducing activity level, we would expect reduced pathology after that. So that's something to consider is you can't just look at the abstract and say, oh, it doesn't matter if you get that repaired or not, or whatever. You might not increase your risk of arthritis, but you have to think a little bit. What are the next? Think a little bit level deeper and what could be contributing to that. Perhaps it's that they're reducing activity, which we don't want to advocate for. And that doesn't necessarily make it a bad study, but it's a piece of the puzzle that can fit into your decision making.
Mm-hmm. Yeah. I don't think you can give someone the blanket advice that it's 100% fine afterwards. But like I said previously, meniscus pathology kind of qualifies as osteoarthritis.
Mm-hmm.
So they're showing very similar outcomes in longer term osteoarthritis. So at 10 years, 11 years. So at least in my mind, that's a really good sign. Yeah. So it's not like you don't get this reconstructed and you're destined for more meniscus pathology and osteoarthritis. That doesn't seem to be the case. But you're probably having people kind of self-select in terms of what activities are okay. because they have the ACL injury, right? And if you're feeling some instability within that knee, probably not going to go skiing. You know what I mean? So my thought too is that if you don't get your ACL reconstructed, I think about this all the time. Like if I had a prior injury, I'm going to take it a little bit easier in activities in the future that might be a little bit riskier to that area, right? So that might be going on. People might be self-selecting. And obviously that's something that's a little bit harder to control, right? Unless you force people to return back to soccer after they have like conservative management just to see how it goes, you know, which probably wouldn't be ethical.
Yeah, and I would say anecdotally, I definitely have some slightly older patients, so that cohort that's out of college that maybe tore their ACL playing flag football, and they tell me like after this recovery, I'm never playing flag football again.
Yeah.
And so they're reducing their activity level with that type of activity, and that's very common. I would say I see people that say that to me.
Yeah. Or if they're like a hardcore skier, like I need to get back to skiing, but they're going to take it easier. You know what I mean? They're just not going to go nutso when they get back to that given activity. It's a very common thing you'll see. And lastly, it kind of brings us to the final point. Should your patient have ACL surgery or not? And I'm taking some information from a 2024 paper called ACL Tear, Individualized Indications for Non-Operative Management. And essentially, they stated currently both operative and non-operative management are acceptable methods for treating ACL injuries. Factors favoring surgery are return to pivoting sports and also the very high level of pivoting. So like your basketball, your soccer, and non-copers that can't return to sport or activities should probably end up getting surgery. So if you just find you can't return back to your activities and you've delayed surgery, probably good indication to get that. Patients with subjective and objective laxity. So this would be with patients saying they're having instability within the knee, which is really freaky. And the patients I've had without an ACL, right, they'll tell you, like, it feels like my knee's like sliding around in there, doesn't feel good, right? So those patients are the ones that have objective laxity via KT1000, maybe better candidates for surgery. Folks with concomitant injury. So if you have a reparable meniscus, probably want to go in there, reconstruct the ACL along with the meniscus. Age may or may not be a factor in surgery. So advanced age used to be an indication for non-op management. That's no longer the case. I certainly have some family friends in their 70s, late 70s, early 80s now that love to ski, and they tore their ACL and they got ACL reconstruction at like 78 years old, right? And they're back out there skiing again. So I would say that age might be a factor just because it's going to dictate your activity level, but it might not. So if you're still a very active 7-year-old, you might want to think about getting your ACL reconstructed, just like the 25-year-olds. Any final thoughts here, Kevin?
No, I think that was a good summary there. I think those criteria are something you should keep in mind, and I'm sure things your surgeon are thinking about as well.
So if we use the cross bracing protocol, can we heal our patients' ACLs without surgery? Well, maybe, but this is a nuanced talk. This next lesson, we'll talk about the cross bracing procedure and all the latest research on it. What is the clinical problem that we're going to be solving today? So ACL injuries are common in sports and recreationally active individuals. ACL reconstruction is considered the gold standard, particularly those with return to pivoting sports. But our question is, can the ACL heal on its own, or do we need an ACL reconstruction? And the other piece is that, can conservatively treated patients return to sport? So you have an individual that heals conservatively, no surgery. Are they able to get back to sport? Are the outcomes and re-injury rates similar, worse, or better than ACL reconstruction? And lastly, what are the long-term outcomes of ACL reconstruction versus conservative treatment? We know that ACL reconstruction in some studies increases rates of osteoarthritis versus conservative care. So if we use a cross bracing protocol, does that help things out, right? A couple good things we're going to answer today. This question was submitted by a few folks from the inside of Fitness Pain Free Insider, so thank you. This is a question I really wanted to dive into more myself, so I'm pumped to go into what I found. Let's get rolling. So what are we covering today? Can the ACL heal on its own? We're going to be breaking down 2 recent cross-bracing studies, and we talk a little bit about whether or not these patients are able to return to sport after the cross-bracing study procedure. What are the outcomes or re-injury rates like? And lastly, what are going to be the practical takeaways for clinicians? So the first study was from Philbay et al. In 2023 in BJSM. And this was essentially an uncontrolled, unblinded case series with 80 consecutive patients with a mean age of 26 plus or minus 10 years. And only 39% of those were female, which is going to be important later on when we talk about some of these re-injury rates. And they're injured in many cases during a sport, but the exact sport patients want to return back to was not clear, which again is also going to be important because certain sports with more pivoting are going to have higher rates of injury when athletes return back after ACL reconstruction. So we need to know what sports these folks are returning to, which we didn't have this information, right? The other piece is that within 4 weeks of the ACL rupture at a median 5 days, patients went into this cross bracing protocol procedure. We'll talk about what that is in a minute. They're all managed non-surgically with the cross bracing protocol. And notably, 49% of those folks had concomitant meniscal injuries. So a lot of meniscus injuries with the ACL rupture. The cross bracing protocol involves from week 0 to 4, having knee immobilization in a brace locked at 90 degrees. And then at 4 to 12 weeks, you have progressive range of motion increases. So essentially, you just have more and more knee extension over the course of time. Week 12, you have a brace removal. So the brace is taken away. And then you have physiotherapy throughout the course of rehabilitation. And return to sport was allowed no earlier than 9 months, on average, somewhere between 9 and 12. And patients had to pass return to sport criteria, which is a good thing. And why the heck would you utilize the cross bracing protocol? So essentially, patients are put in a brace that brace their knee at 90 degrees. And at 90 degrees of flexion, the femoral and tibial ACL footprints, essentially where the ACL attaches to on the femur and the tibia, are closest together. And theoretically, this allows the torn fibers to heal back together, right? So they're able to reapproximate. And if you don't undergo a cross bracing protocol after you've torn your ACL, then there's a chance that you don't reheal just because those torn ends don't come back together. All right. And that's why the cross bracing protocol needed to be studied. We wanted to see whether or not people could heal if you put them inside of this brace and allowed those ends to kind of heal back together. And this is pretty cool. At the 3-month mark, 90%, so 72 out of 80 participants had MRI evidence of ACL healing, right? Or ligament continuity. So if you look at the MRI, essentially it looks like the ligament healed back together, right? And this is important. 50% of those folks had an ACL OAS grade of 1, which is a really high grade, which means there's a little thickened or high signal, but there's continuity of the ligament. Only 40% of those folks had an ACL OAS grade of 2, which is not quite as good. So essentially the ligament is more thinned or elongated, but it's still continuous, right? And then ACL OAS grade 3, only 10% of those folks meant they had complete discontinuity. So 10% of these folks, unfortunately, still had a completely torn ACL. They didn't heal whatsoever, right? We'll talk about this a little bit later, but folks that had the grade 1 had better outcomes than grade 2, and obviously grade 3 would not be as good. So grade 1 healing led to better outcomes. What were those outcome measures? The lysome score, ACL quality of life score, and then on the Lachman's, and then also returning to pre-injury sport. So the grade 1 folks, 92% of those actually returned back to sport. The other grades, only 64% of folks who returned back, right? So folks did better when they had better healing via MRI. 14% of folks, so 11 patients out of 80, re-injured their ACL within the follow-up period, which is at a median of 12 months. And I think what's important is that rehab took at least 9 months, and they're looking at 12 months as a follow-up period. And then 14% of those folks had an injury. But it's not a whole lot of time to see if more people got injured. And this is going to be relevant when we talk about the second article from Porter. So the authors acknowledge that longer-term follow-up and clinical trials are needed to inform clinical practice, but pretty good results, right? About 90% of those folks had a healed ACL, which is ultimately the goal, right? What are some limitations of this study? Well, there was no control group. There was no surgical comparator. It's not like they were looking at ACL reconstruction, which was considered the gold standard versus the cross-bracing protocol. They only had a 12-month follow-up. And the reason why this is highlighted is simply because the next study had a 2-year follow-up and actually showed a lot happened in the second year, right? The diagnosis and healing assessment relied solely on MRI, which is not necessarily validated for grading ACL healing. Would have liked to see something like a KT1000 to see how much laxity there was in the ligament, right? Instead, they just used a Lachman test and the pivot shift as well as the MRI, right? The other piece of the study was unblinded. Obviously, this is not good from the standpoint of having a really good study. Let's talk about study number 2. This was Porter and Shadfield, Shadbolt, not Shadfield. Not sure why I said that. From 2026, CJSM came out, I believe, in February. So pretty hot off the presses. Pretty cool to see this. This was a prospective observational cohort study with a 2-year follow-up, which is different than the field-based study, which is only a 1-year follow-up. And they were comparing 40 patients who chose surgical stabilization in Group A versus 40 who chose the cross bracing protocol, same as in the field-based group. And they started the cross bracing protocol, which seems to be identical to the protocol used in the field-based study, before 6 weeks. But one of the problems and one of the criticisms about these two studies is that the median was not reported in terms of when people got into the cross bracing protocol. Did most of those folks start at 4 weeks, 5 weeks, right? Because in the field-based study, it was pretty quickly after the injury. The median was 5 days, right? But for the Porter and Shadbolt study, they just didn't report that. So maybe it was similar, maybe not. But I got to imagine if you brace someone right after they have the rupture, probably going to heal a little bit better than waiting for 6 weeks, right? Because at that point, you might not heal at all just because you waited too long, right? The other thing that's important is that they had 60% females versus 39% females in the field-based study. We know females are often more at risk. So when we're comparing the results at the end of these two studies, the results can be a little bit skewed just because there are more females in the study, right? They also had skeletally mature patients, which is important, ages 16 to 40, right? They had acute non-contact isolated ACL ruptures confirmed on both clinical exam with a grade 3 Lachman and a positive pivot shift, as well as MRI confirmation this was a full ACL rupture. These participants were going to compete in pivoting sports, and they intended to return to sport. And unlike the field-based study, they told you exactly which sports these individuals are trying to return back to. So the cross-bracing group, 20 of those folks played rugby, 9 soccer, 7 touch football, and 4 netball players. In the surgical group, you had 23 rugby players, 12 soccer, 2 touch football, and 3 netball players. So largely, you had pivoting sports in all of the patients here, and pretty similar from the cross-bracing group and the surgical group, right? Patients with ACL OAS grade 3 injuries, which is MRI confirmation there's an absent ligament and complete discontinuity, as well as folks that had meniscus tears, were excluded from the study. Now, this is important because in the Porter study, they're actually a little bit more picky in terms of which folks were allowed to be included within the study. So in the field-based study, there were a whole lot of meniscus tears, which were allowed to be in the study, right? As well as the ACL OAS grade 3 individuals were included in the field-based study, but not in the Porter study, which would mean that you would think that in the Porter study, you'd have more folks heal. So even less discontinuity at 3 months in the Porter group because you got rid of those ACL OAS grade 3 injuries, right? More on the results in a minute. The groups were well matched on age, so around 22 years old, the BMI around 21, gender, knee, dominance, posterior tibial slope, and pre-injury Tegner scores were very similar between the two groups. So the surgical group as well as cross-bracing group in the Porter study. And these individuals received supervised physical therapy with return to sport no sooner than 9 months, very similar to the field-based study with full functional recovery. I went back and looked into what full functional recovery meant. Essentially, that means that they had some sort of return to sport testing, right? So how much strength did they have side to side within 90% plus? The physical therapist looked at their strength, looked at some testing to make sure they were ready to return to sport, right? Would it be nice to have the same exact return to sport testing as in the field-based study? Probably yes. Honestly, I'm not sure if they were identical, but what's important is at least they passed some sort of criteria-based test and went through the entire protocol before they were allowed to get back, right? In terms of surgical group details in the Porter study, they used hamstring autograft ACL reconstruction with aperture fixation, which is interesting because they didn't use what we would kind of consider the gold standard, which is a bone patellar bone autograft, because we know there is a slightly higher re-injury risk with the hamstring, but that's what they went with. And 5 of 40 also received a modified IT band tenodesis, MIT-BT, for residual So essentially, if you have a surgeon that does an ACL reconstruction while the person is under anesthesia, and it seems like they still have instability when they're performing a pivot shift on that patient that's asleep, they may perform a tenodesis of the IT band to improve the stability of the knee joint, right? So in this study, they did that. And here's what they found. And this is specifically for the Porter study. This is not comparing to the field-based study. So in the Porter study, 70% of patients in the cross-bracing protocol group had recurrent instability at 2 years, which essentially means that 70% of folks retore and they had a ton of instability within their knee, right? Not good results. Versus only 2.5% of patients that had the ACL reconstruction group had recurrent instability at the 2-year mark, right? That's a 28-fold difference in recurrent instability. What that means is, at least when you're getting back to pivoting sports, the ACL reconstruction group did way better, way better. And I think this is really important to note. Here's something else that was kind of crazy. When reporting medial meniscus tears at 2 years, so essentially they follow up with the patients at the 2-year mark and see how many of those patients had a new meniscus tear within those 2 years. 54% of patients in the cross bracing protocol had a new medial meniscus tear versus only 2.5% of folks had a new medial meniscus tear in the surgical group. Obviously, that's no bueno, right? Here's the other piece. All PROMS, all outcome measures were significantly worse in the cross bracing protocol group. So Tegner scores, IKDC scores, KOOS scores, KOOS quality of life scores, as well as the Lysholm score was all significantly worse in the cross bracing protocol group, right? Surgery group did way better on all of those. In the cross bracing group, the instability was progressive in nature, meaning that there's only 20% instability at the 1-year mark, which was around 14% in the field-based study, if you recall. However, by year 2, 70% had recurrent instability, which means the large majority of folks acquired recurrent instability somewhere in year 2, right? Which field-based didn't even report that data whatsoever, right? And all 28 failures required delayed surgical stabilization. So 70% of these folks, after they've gone through 2 years of rehab plus trying to get back to sport, ended up just getting ACL reconstruction anyway, right? Which is going to be really important because you have a patient that just tore their ACL and they're considering the cross bracing. There's a potentially 70% likelihood that you're going to need surgery at the 2-year mark, right? Which you waste a lot of time and effort doing that. So the ACL reconstruction obviously was better. And this is going to be very, very relevant because in the field-based study, which looked very positive, they didn't report on the 1 to 2 year data, which the Porter study did, right? Some additional findings from the Porter study: 22 of 40 cross bracing patients had a pivot shift at least 1 grade worse than baseline at 2 years, suggesting progressive instability. And you actually see a lot of this in the conservative ligament rehab world. So not just the ACL, but the PCL, MCL, LCL. One of the problems with these is after rehab, once these athletes start to return back to sport, they get more progressive instability, meaning that over the course of time, it just seems that ligament gets more and more stretched over the course of time, which you saw in the results in the prior slide. 2 patients in the cross bracing protocol group developed a DVT, which is obviously not great, and 4 had significant stiffness. So what that means is that if you put someone in a brace for 4 to 6 weeks, don't let them move whatsoever, it increases the likelihood that they get a DVT, right? Which is obviously not good. And then 4 patients had significant stiffness as a result of being in that brace for a period of time, which means that if you brace someone for a long period of time, they get very stiff, and it's actually very tough to get that range of motion back in a small segment of these patients, right? But there are some significant findings that we have to be aware of for patients. Not like you put them in a brace, everything went extremely well when they came out. Some folks actually had DVTs and a lot of stiffness. More limitations: they were not randomized. Patients chose the treatment, which is good. I think if patients want to choose a treatment, I don't know if that'd be very fair if they non-blinded someone and they didn't tell them if they got surgery or not. But some of those studies have been performed in the past. It was a single surgeon practice. It was a relatively small sample, right? So only 40 people in each group. and there was a potential selection bias. All those things can kind of cloud these studies, make them a little bit worse, right? Now let's compare the two studies, Filbay versus Porter, going head to head. So study type for Filbay, uncontrolled case series. For Porter, prospective cohort, which was controlled, a bit better. Sample size, 80 patients in Filbay versus 40 cross bracing and 40 surgical with Porter. Follow-up was 12 months, which is very significant for the Filbay study versus Porter, 2 years. Control group, there was none in the Filbay. Control group was a surgical group, which is what we needed for the Porter, right? Percent female was 39 in Filbay, which is important because with female athletes, they're more likely to tear their ACL compared to males, right? So in the Filbay study, they had more males, which may be one of the reasons why they had a lower re-injury rate compared to the Porter study, which had more females, right? In terms of age, the median was 26, whereas in the Porter, the age median was 22. Younger athletes may be more likely to get an ACL tear. That's going to skew the results again. And then in the Filbay study, meniscal tears were included, right? But the Porter study, they were excluded, which is kind of interesting because when folks have an associated meniscus tear, there's a chance it might actually help with healing, or it potentially may make things worse, right? It's kind of tough to utilize that data and draw any definitive conclusions from it, just because if you have a meniscus tear, it actually increases some of the blood flow to the area, which maybe that actually helps with ACL tear healing, right? It's kind of interesting. Who knows? We haven't studied that yet. In terms of sport type, there was a little bit unclear in terms of which sports the Filbay group was returning to, which obviously is going to skew things a little bit, because if you're trying to get back to, let's say, competitive cycling as a post-injury ACL treated conservatively, you might actually do extremely well and return to sport and not have a re-injury compared to returning back to something like soccer that has a lot of pivoting and cutting, right? In the Porter study, every single athlete included was trying to get back to a pivoting sport. And that's going to be super relevant because you would expect more of those folks to have a re-injury compared to athletes getting back to something that's more in line, doesn't require a lot of pivoting, change of direction, so on and so forth, right? So the Filbay group, return to sport, looked pretty dang nice compared to the Porter group, and that potentially could be explained by the sports that folks are trying to get back to. In terms of MRI healing rate, there was a 90% continuity via MRI at the 3-month mark in the Filbay study. In the Porter study, there's not a primary endpoint. So it's not like they looked at the 3-month mark via MRI to see if these ACLs are healing at the same rate as in the Filbay study, which would have been kind of nice, right? In terms of a re-injury rate or failure rate, there's a 14% failure rate at the 12-month mark. In the Porter study, there was a 20% failure rate at the 1-year mark, and then a 70%, which is pretty dang big, failure rate at the 2-year mark, right? What's interesting is that if they followed out the Filbay patients at the 2-year mark, my assumption is they'll probably find a much higher failure rate, right? Which would be kind of cool if the Filbay study patient population is followed up for another few years to see if they do end up having that, right? So they can compare that to the Porter study and see. In terms of recurrent instability, for the Filbay study, that wasn't really reported, although in the Porter study, that was reported, 70%. But when the Porter study is saying recurrent instability, that means that the ligament is now torn and there's a positive Lachman, and a positive pivot shift, right? Which is essentially what is probably occurring in the Filbay study when there's a lack of continuity, right? Again, in terms of medial meniscus tears, this was not reported in the Filbay study if there were more injuries at the 12-month mark. And the Porter study, there was a 54% rate of medial meniscus injury at the 2-year mark, right? Versus only 2% in the surgical group. In terms of surgical comparator, there's none in the Filbay study, and there was in the Porter group, which was great. And in terms of the final outcome, in the Filbay study, there were promising MRI results, but the conclusion in the Porter study was that basically there's an unacceptably high failure rate by utilizing the cross bracing protocol, which I think that's obviously true. However, there is some nuance we can discuss in a minute, meaning that maybe we don't want to throw the baby out with the bathwater. Maybe there is a still benefit of the cross bracing protocol, but maybe not for pivoting sports specifically, right? So looking at MRI healing versus functional stability, MRI healing at 90% basically shows ligament continuity is visible in imaging. In some cases, there was thickening or high signal, but you could see that continuity, and that showed that there was promising biological signal. That does not equal clinical success. So the MRI does not equal functional stability. So it doesn't mean that because you have a continuous ligament via MRI, that the ligament has the ability to withstand rotational forces, has a good pivot shift and or Lachman, or that the individual can return to pivoting sport demands. And at least in the Porter study, in folks that had potential continuity, 70% of them had a failure rate at the 2-year mark, right? So one of those big takeaways is that MRI continuity does not equal functional stability, at least at the 2-year mark in athletes returning back to pivoting sports, right? So what are the clinical takeaways for your practice? So the cross bracing protocol concept is biologically interesting, but clinically unproven for pivoting sport athletes. And essentially, it's kind of proven to not really work particularly well, right? At least in this one study, obviously small sample size, one study, maybe future studies will show better. MRI healing does not guarantee functional stability, always correlate with clinical exam, right? Got to make sure that we're not just looking at MRI. We already know this. For patients intending to return to pivoting or cutting sports, surgical reconstruction remains the evidence-based standard until we see more promising research. I would say that this study does not look very promising for future studies, right? And in fact, we might not see many future studies just because, 70% re-injury rate doesn't bode well for folks trying to return back to sports. Telling these folks that they should try a cross-bracing protocol, I think would be a little unethical, okay? Delayed surgery after failed non-operative management carries the added risk of meniscal damage and progressive instability. So a lot of these folks are going to acquire a new meniscus tear, and what may happen is that ligament gets more and more lax over the course of time. Who knows? Maybe in 3, 5, 10 years, it gets even worse, right? Patient selection matters. Some lower demand patients, i.e. copers, may do well without surgery, but this is a small subset. We already know that some folks actually do pretty well with conservative management of an ACL tear, right? Obviously, grade 1, grade 2, but even some grade 3s. These folks are known as copers. Around 30% of folks who have a complete rupture of the ACL do pretty dang well. We know that this happens, right? So maybe a smaller subset of these folks do well. I mean, around 30% of folks didn't have recurrent instability after the cross-bracing protocol, right? So maybe those are the copers that do pretty well. Now, lastly, shared decision-making is essential. Patients must understand the risk profile of each approach, okay? So clinical pro number 1, do not equate MRI healing with clinical success. A continuous appearing ligament on MRI does not mean it can withstand the rotational forces of pivoting sports, right? The cross-bracing protocol is not ready for prime time in pivoting sport athletes. The 70% failure rate at 2 years in the Porter study, combined with a 54% medial meniscus tear rate, represents an unacceptable risk for this population. That's directly from the authors. Makes sense based on the results. Beware the MRI-only diagnosis trap. Both studies highlight significant false positive rates for MRI diagnosis of ACL rupture, reinforcing the need for clinical correlation. We didn't talk about this yet, but what was interesting is that there were false positive rates on the MRI. And when they went in arthroscopically, they actually saw something different than what they saw via the MRI. So when you see these positive results on the MRI, you actually might be looking at something that's not continuous at all. And I've actually had a few surgeons tell me this in the past. One of my friends, Dr. Rocket, has said this before, where he's looked at someone's knee that looks like they have a continuous MRI, and then essentially the clinical evaluation seems very unstable. And when they go in arthroscopically, there is actually a tear there, right? So beware of this continuity of the ACL via MRI only, because that's not always true. And in this study, around 20% of folks had a false reading, okay? Clinical pro number 4, time is not on the side of the ACL deficient knee. Progressive instability and meniscal damage accumulate over time, and this is consistent with findings of other conservative care after ACL rupture from Canon, Compare, and SNAP trials, right? Found the same thing in this study. Clinical pro number 5, patient counseling must include the full risk profile. Patients attracted to the idea of avoiding surgery need to understand that the cross-bracing protocol carries significant risk of DVT from prolonged bracing, as well as stiffness, and then followed up later on by progressive instability, meniscal damage, and a high likelihood of eventually needing surgery anyway, potentially with a worse knee, right? Which this is not phenomenal to tell patients, but at least you got to let them know if they are considering the cross bracing protocol, this may occur over the course of time. And again, this may be years of wasted time left with a more damaged knee at the end of 2 years of a lot of, I don't know, what seems like probably unworth risk and time trying to rehab this thing. Clinical pearl number 6, there may still be a role for non-operative management, but likely in carefully selected lower demand patients or those with partial tears, not competitive pivoting sport athletes. What I would be pretty interested in seeing is if you have folks that perform conservative management via the cross bracing protocol, and then you don't have these folks return to pivoting sports, and you see long-term if they have less osteoarthritis than patients that undergo surgical reconstruction, right? That'd be pretty cool to see. I'd also like to see the cross bracing protocol go head to head with conservative rehab. So folks that get physical therapy, but don't have the cross bracing protocol versus folks that get the cross bracing followed up by physical therapy. Which group is going to be superior, right? In folks that aren't trying to get back to sport or folks that aren't trying to get back to some sort of pivoting sport. That'd be very interesting to see because we know that when you get the surgical reconstruction, the surgery by itself kind of digging those holes into the bone, trying to pull out part of the hamstring, part of the patellar tendon or the quad tendon, causes some damage to the knee, which may lead to longer-term osteoarthritis. If we just do a cross bracing and treat it conservatively and don't have these patients return back to sport, are they going to be good candidates, right? That'd be really cool to see. This is what I'm talking about with trying not to throw the baby out with the bathwater. When you see the results of this Porter study, you might think like cross bracing is absolutely terrible, but maybe for the right patient, it's decent, right? Who knows? I would love to see those studies be performed over the course of time. And maybe certain sports actually do pretty dang well. Who knows, right? Clinical pearl number 7, tear types matter probably, right? So in the field-based study, they talked a little bit about this. If you have certain types of tears, they tend to do a little bit better. So if you have a proximal tear on the femoral side, if you have a younger patient, and if the stump integrity is intact, it's probably going to heal a little bit better. If you throw everyone that has an ACL tear into a study, you're probably going to have different outcomes simply because the tear type matters. The reason why I say probably is because we don't have great research to show this, but it does make sense. And we do have some studies suggest that the tear and the healing does matter. It's just that we don't have great research to show that if you have a proximal tear, you return to sport at a higher rate, and you have less likelihood of re-injury over the course of time, right? You would assume that might be the case, but we don't have a ton of research to parse this out, okay? So what is the bottom line? The field-based study generated excitement, but lacked a control group, used MRI-only endpoints, and had only 12-month follow-up, 14% versus 20% failure rates at the 1-year mark. The Porter study provides the first controlled comparison and showed a 70% failure rate for the cross-bracing protocol in pivoting sport athletes at 2 years versus the ACL reconstruction, considered the gold standard, where folks did very well as expected. Until RCT data are available, recommending the cross-bracing protocol as a primary treatment for athletes in pivoting sports is premature. The ACL may show MRI continuity, but functional stability for a sport demands more than imaging appearance. Numbers don't lie. 28 times greater recurrent instability with the cross-bracing protocol versus surgical reconstruction, 70% versus 2.5%. That's a 28-fold difference. That is crazy, right? The evidence-based standard for patients intending to return to pivoting and cutting sports, surgical reconstruction remains the evidence-based standard, right? And I'll briefly go over the cross-bracing protocol potential advantages. You avoid surgical risks. You have biologically interesting rationale, 90% MRI healing, non-invasive approach, right? However, the ACL reconstruction has the advantage of a much lower recurrent instability rate, superior PROMs, right? Sorry, I can't even read what I've gotten written down right here. So the outcome measures are a lot better. It is the evidence-based standard for pivoting sport athletes and prevents progressive meniscal damage. Some potential considerations: there's always a surgical risk anytime you undergo surgery. There's a longer initial recovery, potentially, right? There is a graft failure possibility, right? And requires maybe more rehabilitation, but both of these groups are going to need that, okay? Patient selection probably matters. There are some lower demand patients or copers may do well without surgery. This is a small subset. We haven't really parsed this out, right? So shared decision making is essential. Patient, surgeon, physical therapist. The patient must understand the risk profile of each approach, right? What are the key takeaways? What we covered today? So essentially, the ACL can show MRI healing, but MRI continuity does not equal functional stability. The Phil-based study showed 90% MRI healing, but lacked a control group and only had 12-month follow-up. The Porter study showed a 70% failure rate and 28-fold difference in instability for the cross-bracing protocol versus surgery at the 2-year mark. The surgical reconstruction remains the standard for pivoting sport athletes. Patient selection, shared decision-making, and clinical correlation remain essential. And then the tear type, so is a proximal or femoral side tear, age, and stump integrity likely matter, although this is not completely parsed out. Okay, your patient is going to get surgery for the ACL tear. Which surgery is going to be best? Which graft should they choose? Next, we'll talk about how to make that decision. In today's video, we're going over what is the best surgery after an ACL injury. So, our lesson goals for today is I want to expose everyone to the different types of surgeries you can get after you've had an ACL injury. And this is going to be with complete tears, so it has to be a grade 3, completely tore the ligament. You'll see some folks that are like 90% torn, they get surgery as well. But largely, it's a complete tear of the ACL. The biggest one you'll see is going to be the ACL reconstruction. And this is going to be basically creating a graft, usually an autograft. That's from the person. And this could be coming from the patella tendon. This could be coming from the quad tendon. It could be coming from the hamstring tendon. It could also be an allograft, which is going to be a cadaver graft, right? It can come from different parts of the body. We'll talk about that a little bit later. There's also an ACL repair that you can get, much less common. So we'll actually try to suture together the ACL or pin the ACL back down. There's a few different techniques. We'll talk about the new kid on the block, the bridge enhanced ACL repair. So it is a repair surgery, not a reconstruction, although they'll use this bridge, extracellular matrix bridge, to help to repair the ACL. We'll talk about the pros and cons of each surgery. So the return to sport timeframes, return to sport at similar rates of play, as well as we'll go through outcome measures and just see which surgery is potentially best. There's pros and cons of each. We'll talk about best candidates. So if you have a 60-year-old female that is more sedentary, you probably will have a different surgery than let's say a 18-year-old female that wants to get back to soccer, right? And then we'll talk about some patient guidance. So essentially, you want to be able to give your patient good information about their next course of action after an ACL tear. We have direct access in the state of Massachusetts, oftentimes where that first point of contact, athlete tears or ACL, they go to their physical therapist. They're going to get advice from us. We want to make sure that we do two things. So guide them appropriately, but also have some good recommendations from a physician standpoint, surgeon standpoint, to refer to that doctor so that they can make a really good decision, utilizing the patient's goals, as well as input from the physical therapist and the surgeon, right? What do you think? Is that good stuff, Kevin?
That's pretty comprehensive. I think we'll have a good idea of the best surgical option for patients with ACL after this.
All right, let's get it going. So what is ACL reconstruction? So ACL reconstruction is not a repair, right? And I used to say this wrong all the time. So essentially, they don't go in there and tie the ACL back together. They're reconstructing it. And they're reconstructing that native ACL as best as they possibly can via a graft. And like I said, this can be an autograft from the person's own body or an allograft, which is coming from a cadaver, to make the new ACL, right? And the goal is to replicate that native ACL as much as possible. From a surgical perspective, surgeons are always trying to restore the anatomy as similar as possible to what it was previously, right? And that's actually a pretty big consideration when they're trying to decide on the graft. And the goal is to restore anterior and posterior stability, as well as rotary stability. And this is something I've talked to Lenny about. Lenny's interesting. He's a coworker of mine at Champion, and he treats almost entirely ACLs. I think he schedules 80 or 85% ACLs right now, which is kind of funny. But he's also worked pretty closely with a lot of knee surgeons. And as I understand it, surgeons are constantly trying to restore rotary stability in the knee. and they will actually do a pivot shift during the surgery to see if they've restored that stability. And if they haven't, they'll do additional surgery like an LET. We'll talk that in a minute to try to restore that as much as possible. So that's one of the big things on the surgeon's minds when they are doing this reconstruction, right? So restore that anterior posterior stability as well as a rotary stability. And they want to match the qualities of the native ACL as much as possible. And this does become important from a graft selection standpoint. So you're trying to have a graft that has the same length, the same cross-sectional area, the same level of tissue stiffness, the same tissue makeup, et cetera, et cetera. And every different graft has different qualities. So basically, the physician is trying to match the native ACL as much as possible. And we'll talk about some of these specifics. One study in particular, which we'll note in a minute, they go in painstaking depth in terms of the actual tissue qualities of each graft and basically the decision-making process of why you would choose one graft over another. We're going to have like a superficial glance over that stuff. I felt like it wasn't as relevant for us as physical therapists. If you wanted to read that, you certainly can. I found it pretty interesting. All right, so a couple stats overall about ACL reconstruction in general. So the revision surgery rates are somewhere between 2 and 10%. So revision surgery rates aren't the same as re-tear rates because some folks will re-tear and they don't have surgery, right? So re-tear rates may be higher than that. But in some studies, you may have revision surgery rates as high as 42%, particularly in pivoting sports, right? So you get back to a lot of pivoting, there's a chance that you re-tear. And the amount of re-tear that you get from study to study is going to vary based on the age, activity level, alignment influence, post-operative outcomes, and failure rates. So basically, the reason why the graft choice in the surgery is important is because that is going to influence the re-tear rate, right? And the outcome. So we need to make sure that we're choosing the right surgery, the right graft for the right person. Any thoughts there before we move on, Kevin? I'm just rolling.
Yeah, no, that's good. I think that is an important differentiator to keep in mind because you'll see higher numbers out there for re-tear rates. But as you said, that's not the same as a revision. So yeah, the revision is when they've had a re-tear and then they go in and get it surgically reconstructed again or repaired that second time. So yeah, that's just an important differentiator I think that you hit on.
Okay, ACL reconstruction. What's your favorite graft choice, Kevin, before we move on here?
It's a good question. I'm not sure. I think there are pros and cons to each one. You know, as Lenny being my mentor for this and, you know, learning a lot of what I know about ACLs through him is he's a big fan of the bone, patellar tendon bone choice. And I think it does, you know, as you'll talk about some of the pros of it, I think something to keep in mind is I see these folks get a lot of anterior knee pain as we progress in rehab. And, you know, essentially they all develop a patellar tendinopathy is that's what it is. It's a symptomatic patellar tendinopathy for months. And it depends on the person, how quickly that goes away. So unfortunately, there is no one that I just think is amazing. Like they all have pros and cons. And I know you're going to talk about the bear. I think that's where the bear is so attractive and hopefully it pans out well over time because when you don't have to harvest tissue from somebody, they feel so much better. And I see allografts that I actually like treating allografts a lot because they feel great and they do well in PT. It's just that it's not the most stable graft choice. And you'll talk about this stuff, but you know, I'd say I like treating allografts the best. I think it's they feel the best.
Yeah, I kind of agree with you. It's really nice when your patient comes in, you're like, how are things going? They're like, great, I feel awesome, right? As opposed to like, my knee is really sore today. Yeah. All right, so we got a lot of graft choices. From an autograft perspective, you have the hamstring tendon. And this is actually the most common surgery worldwide, which I thought was interesting because I don't see it as frequently, right? I guess it really depends on the surgeon as well, but still the most common worldwide. Then you have Lenny's favorite, the patellar tendon graft. And this is a bone patellar tendon bone graft. So essentially you take some bone on either end, and then you have the patellar tendon in the middle. And this is historically considered the gold standard. The newer kid on the block, which we're seeing a lot of recently, is a quadriceps tendon. And what I found was interesting, and one of the reasons why folks like the quadricep tendon, there's a lot of reasons, but it most closely resembles the size of the native ACL footprint. So they've got good return to sport rates and low failure rates as well, which we'll talk about in a minute. But I also thought it was kind of interesting because it does match what the ACL actually is supposed to look like fairly well. So from a surgical standpoint, it kind of checks off that mark, right? Looks a lot like an ACL. Then you have your allografts, which are cadaver grafts. And I thought this was pretty interesting, but you can have an all soft tissue graft. So you can use a hamstring tendon, tibialis anterior or posterior tendon, peroneal tendon, or an IT band graft, which is kind of cool. You can take the graft from a variety of different places. And you can also have bone tendon grafts. So you can have a bone patellar tendon bone graft from a cadaver. You can have a bone quad graft. So you can take a plug of the bone with the tendon of the quad. And you can also do the same thing at the Achilles. So take a chunk out of the calcaneus and have the Achilles as well. So largely you can take a graft from all different parts of the body. That was something I thought was interesting too, because I initially thought it was just like, all right, you just take a cadaver ACL, and just put it right back in. But it looks like that's not the case. Or they're using a graft from a cadaver in different parts of the body. So this is a question you had the other day, Kevin. What is the load to failure of different graft choices? So if you take a graft and you pull it from both ends, how much load can it take before it fails? That's probably important because we're trying to have a super strong ACL reconstruction choice. We just want to make sure that we're choosing the best and strongest graft, right? So largely heart et al. Found there's no difference in load to failure in autograft types. I think one of the questions you had was, is the graft as strong as a native ACL? And yes, it is. In a lot of cases, it's much stronger too. But the other thing I found is that there's a large variety of ways to create a graft too. For example, the hamstring tendon, the amount of times they double it over. Also, they'll often add a part of the gracilis to it as well. All these things will influence the failure rates too. So the failure rates in the study, I forget what they were, but it was kind of like a lower number and a super high number, depending on how much they add to that tendon to make it stronger and more robust. For allografts, so essentially if you have a cadaver graft, the preservation and cleaning process is actually very important because it influences failure rates. So if you have increased irradiation to that allograft, it's going to reduce the load to failure. If you have glycerolization, lyophilization, or preservation with chloroform methanol extraction, that reduces the load to failure. So when I was a newer physical therapist out in Colorado, there was a group of physicians that all loved doing cadaver grafts for professional soccer players. And I reached out to them to figure out why. And they said they thought the allograft was a good choice because they're getting athletes back to football, soccer faster, right? And they thought that the retear rates, which, spoiler alert, the graft choice, allograft, cadaver grafts fail at a higher rate, was due to this poor preservation or cleaning process. And now that they've come up with better preservation processes, that the failure rates are better. Spoiler alert, that's not the truth, right? But that was what these surgeons were telling me as a reason why they use that, right? Largely, the fresh, frozen way of preserving these grafts is going to be best. And when they utilize that method of preservation, they have similar biomechanical factors as an ACL. So pretty dang strong, good graft choice on paper, right? Any thoughts on that before we move on, Kevin? Kind of interesting that different surgeons like what they like.
Totally. Yeah. I think that's what it gives us a lens into is how are surgeons determining which type of graft to use. And I know Lenny will talk about it depends a lot who they trained under and what the person they trained under like to do and how they find that they get the best outcomes with their patients. And I think a funny thing you'll hear is a lot of surgeons. I had a lady who has an allograft, and one of the local surgeons was telling her that, kind of boasting that he has the best grafts. He gets the best graft types, and took a lot of pride in that. So like you said, whether that bears out in the research or not is a question that we can look at and see if there's a good answer for. But I know that it's something surgeons give a lot of thought into is, where are they getting these graft types, specifically for the cadavers. And some think theirs are better than others, and maybe they are. And we just need more research to show that. But I think that's something you'll talk about. But it's interesting because it's not like you had said, and I've talked to one of our PT students about this, is why don't we just use for cadavers someone else's ACL? But that's not what they do. And it must be because it's not as strong as these other locations that they'll take it from, like the Achilles tendon or the IT band or something like that. That must be a little bit more robust than the native ACL that they take from somebody. So there's a lot of consideration about where to take it from.
Yeah, that's interesting. I don't know the answer to that. Hopefully we could maybe talk to someone at some point to kind of get that answered. But it does bring us back to this is like a theme, I think, from a lot of our podcast episodes, is that we're always trying to protect our patients, right? Because sometimes you will have surgeons, and I'm not trying to throw surgeons on the bus. There's a lot of great surgeons out there, but some just have these wonky ideas. They just hold on to this thought that like, this is the best thing, even though more research comes out that's like, it's not, but they still believe in that strongly. And I think that's a bit of a problem. And sometimes I find myself steering my patients away from some of those docs for that reason, because it doesn't make sense. I mean, we used to have, out in Colorado, we'd have athletes, cadaver grafts, professional soccer athletes return to sport 4 months after cadaver graft because they feel good. And that's the main reason why. And these docs felt like the re-tear rates were okay, so they kept doing it. But we know that's probably not a smart move, right? And I had some patients, unfortunately, had multiple re-tears, young athletic patients, and that stinks, right? It stinks to go through that process multiple times when maybe some of that could have been prevented if they got an autograft from the get-go. So unfortunate, but does happen. We're always trying to protect our patients, right? All right, good old ligamentization. So another interesting part about an ACL reconstruction is that when you put in a new graft, it goes through the process of ligamentization, which is a process where the graft takes on new characteristics to match the prior ACL. And this can take anywhere between 6 months and 4 total years. And what is also interesting is that as this process is occurring, the ligament, the graft, gets weaker for a period of time. So when it first goes in, it's quite strong. And then somewhere between around 8 to 10 weeks or so, depends on the graft, as we'll talk in a minute, it actually gets quite a bit weaker. And then it gets stronger and stronger and stronger over the course of the next several months to years, right? And this is a consideration that changes from graft to graft. So essentially, the bone, patellar tendon bone, ligamentizes fully somewhere between 6 and 12 months. The hamstring takes somewhere between 12 and 24 months. The quad tendon generally ligamentizes faster than the hamstring. And the allograft has a slower graft maturation process overall compared to the autograft. And what I will say is that a lot of this evidence is mixed, and the ligamentization process doesn't always correlate with laxity clinically. And that's kind of like, this thing is freaking strong in the beginning, and then towards the middle, not quite as strong. But when it's not quite as strong, doesn't mean that you're going to be unstable necessarily. But this is one of the thought process we go through. We're trying to determine return to sport, right? So an athlete may move extremely well at month 4, month 6, whatever it is, but that graft hasn't gone through this ligamentization process, which is a bit of an issue, with some studies showing it takes up to 4 years for this to occur fully. That's an entire high school sport career. If you have a freshman that tears their ACL, you're like, all right, well, you can play college sports, but not high school sports, right? So there's got to be some sort of happy intermediate, which I'm sure you'll talk about in the next few podcast episodes of when to return athletes back. But just keep in mind, this process takes a while and is different from graft to graft, and is also a consideration with your individual athletes. I know that we both work closely with Dr. Ramappa, and when he has an allograft patient, he wants to make sure they're waiting longer to return to activity. And this is tough for those folks. So we just talked about, they feel good early on, but we're also telling them to wait for an entire year until they return back to skiing, which patients hate, right? But that's the reason why, because we're trying to use our brain. These patients feel pretty good, but that ligament isn't really healed yet. Any thoughts on that quickly before we move on, Kevin?
Yeah, I think that's one of the coolest processes that occurs, is that tendon tends to become more like a ligament. And, it's just kind of amazing that the body does that. And it must just be either the forces that it's getting or the blood supply that it's getting. But that process does take time. And like you said, there's a happy medium between when are you physiologically ready versus when does the timeline want you to be ready, and when do you want to be ready? So all that's a big consideration, but it's important to keep that in mind, because there is a point early in rehab where people kind of progress from that early post-op phase and they're feeling better and they want to do more, but they might, that's where you had said perhaps their graft is at the weakest point, and we have to continue to protect them and make sure that they don't do anything crazy in that period. And all of it is a big education process that, hopefully begins pre-op, and then, the surgeons hopefully giving them some of this information, and we're giving them some of this information just to set realistic expectations. So they're not thinking, I feel amazing, why can't I ski with this allograft at 7 months? And this is where we can help educate them that we might want to wait a little bit longer because of the immaturity of the graft.
Good points as always, Kevin. All right. So are there differences between the different types of grafts in patient-reported outcome measures? We're looking at quad tendon versus bone patellar bone versus hamstring. And here's the thing. There's no difference in outcomes generally. There's usually lower morbidity in the quadriceps tendon. What the heck does that mean? So just having some sort of complication from the harvesting of the graft, right? So if they're taking the quad tendon, seems like that tends to create less pain right around that incision area or other complications, right? The double bundle hamstring technique improves functionality and complication rates versus a single bundle. So what that means is you take the semitendinosus, the hamstring tendon, combine it with part of the gracilis tendon, so you have two grafts, put them in together, that improves your outcomes as well. So some of the studies I was reading, including this one that we just have pasted right here to the right, if you're watching the video portion of this, if you bundle the two together, better outcomes. So that's one of the reasons why you'll see this from surgeons, because it seems to improve the stability of the joint, right? And then if you look at autografts versus allografts, so from yourself or versus a cadaver, older research reported worse outcomes in the allografts. What's interesting is that newer research is showing no difference, right? And I don't know if that's just because of the way we're now preserving these. Now they're more fresh frozen. Are we getting more benefit from those? I don't really know, but that's one of the things that we're seeing trend-wise from a outcome perspective. All right. And here's the thing that we're all very much concerned with as physical therapists. What are the graft failure rates? We already learned that graft failure is relatively high in ACL reconstruction, and that's a problem. So we want to choose the best graft that reduces failure rates as much as possible. Here's what you'll find. Quad tendon and bone patellar bone has similar failure rates. And this is somewhere between 1.4 to 7.5% in the quad tendon group versus 2.0 to 5.1% in the bone patellar tendon bone. And then there was no difference from a statistical significant standpoint between those two groups, right? However, the hamstring has a slightly higher re-tear rate. So one study had 47,613 patients, so very high powered, and they found the percentage of tears was 2.8 in the bone patellar tendon bone graft versus 2.84 in the hamstring. So that's a very, very small increase, but that was statistically significant because it was such high-powered studies, so 47,000 participants, right? However, in other studies, there's up to a 2 times higher re-tear rate, right? So in some studies, you'll find the hamstring tears 2 times more likely compared to the bone patellar bone graft, right? And this is going to be more pronounced in younger athletic patients. So if you have a younger athletic patient, you probably want to consider the bone patellar tendon bone or the quad tendon over the hamstring. I just thought it was interesting. The hamstring is still the most common procedure. And one of the ways that surgeons will try to bolster the hamstring is through adding the gracilis as well as an LET procedure, which we'll talk about a little bit later, right? That's actually relatively common that we see from time to time. If you look at allografts versus autografts, there are higher rupture and reoperation rates in the allograft, right? And that's one of the problems with using a cadaver graft. And they're up to 6 times more likely to re-tear, particularly in young athletic patients. This is one of the reasons why I wanted to call the surgeons out in Colorado that were liking to use cadaver grafts, because I was reading this research, didn't make a lot of sense to me, right? Again, I think it's one of those instances where I feel like I was right, humble brag here, but you're trying to protect your patients. And one of the reasons I called a particular surgeon is because I had a patient that tore twice. He had an ACL reconstruction, cadaver tore it. And very interesting. And I couldn't find much research about this, but first time he retore it was hyperextension injury. Second time he retore it, he tore his meniscus. And when they did an MRI, the body just ate the graft. So what's interesting is that in some cases, and you don't really see this much in the research, is that your body, it's not your own body they're putting into you, it's cadaver graft. And your body sometimes dissolves that, eats that, right? So that's another interesting kind of thing that does happen, phenomenon, right? And I do feel later on, he actually, his third study had an autograft and he's done fine to this day. It's actually been over a decade. But yeah, that was one of the things that concerned me. And you will see that. You will see some docs still doing the cadaver grafts, but yeah, they have a higher re-tear rate. What's interesting about these is they have substantially lower re-tear rates in older and less athletic patients, right? And this is what we tend to see a lot clinically. If you're over the age of 40 and you want to get back to, let's say, skiing, some of the docs we like, they will prescribe the cadaver graft. And there's no difference between different types of allografts. So if you use the Achilles, the tibialis anterior, posterior, etc., seems like they all have the same graft failure rates, right? And the last thing I did find from another study is that if you use bioabsorbable screws versus metal screws, that reduces failure rates as well. I personally don't know what type of screws the surgeons I work with utilize, right? But I just thought that was interesting and maybe something to look at. Hopefully your docs are using those things. Any thoughts before we move on there, Kevin? I know this is kind of like probably the biggest part of this lesson today.
Yeah, I think when you were talking about surgeons changing their minds, I think, we're all guilty of that. Every profession is guilty of that, is we get used to doing the same things over and over, and we're resistant to changing a little bit with newer evidence coming out that challenges the way that we've normally done things. So I think in this situation, it's good to recommend to your patient to maybe just get a couple different opinions from different surgeons. Go and meet with a couple and see what they're recommending, and hopefully we can play a role in educating them as well. If they're going with a surgeon like your patient was, who was going to do an allograft in a young active person, we just want to present our case to the patient and let them know, hey, this is what some of the research is saying. Why don't you go get a second opinion from another surgeon and just consider what they say? And then you can use all that information to kind of help make a decision. And it takes some nuance, because you don't want to badmouth surgeons, and you don't want to act like we know everything and they know nothing, because they know a lot of things we don't know. But it's also trying to protect your patient. So it's, introducing it in a friendly way where that patient can maybe get a second opinion from a surgeon that you trust in the area. And, after you educate the patient and give them things to think about, ultimately, at the end of the day, it's still their decision. And if they want to go with the allograft, that's up to them. But it's our job to help educate them and let them know what the potential risks are. So definitely something important to keep in mind.
Yeah, and I don't want to go too in depth into the story just because we got a lot to cover, but it was a mess. So I was concerned the entire time, and it wasn't just the concern that the patient had a cadaver. It's just that the patient was also encouraged to return back to sport around the 4 to 5 month mark, right? Which is super fast. And that was very scary to me. And the other part that was frustrating to both me and the patient's father too, is that I was trying to reach out to the surgeon for a long time, and I really wasn't able to reach the surgeon. And that's another big problem that I think a lot of physical therapists face. So then you have the physical therapist, me, saying, I'll reach out to the surgeon, we'll try to figure this out. And then essentially the patient is getting frustrated because there's a lack of communication. Surgeon's busy. They might not be able to return phone calls. Eventually we did get a chance to chat. We kind of talked through a lot of this stuff. And I already kind of spoke about how that went. But yeah, I just kind of retore a few times. Unfortunately, returned probably too soon with the wrong graft. And my communication probably just, or lack thereof, probably just frustrated the patient, further. So it was a crappy situation, but I mean, the reason why you do want to try to protect your patients as much as possible. So yeah, good times. Yeah. All right. So how about from a strength perspective? Is there a difference between the different types of grafts? In terms of knee extensor strength, the hamstring tends to outperform the bone patellar tendon bone graft, which tends to outperform the quad tendon. And this is at the 5 to 8 month mark, and it may normalize somewhere between 9 and 15 months. There's a few studies that kind of support this. So essentially long term, most folks do get more symmetry back, right? At least between the graft types. Well, you'll probably talk about this later. It's hard to get that quad strength back over the course of time. But largely the different graft types will normalize after a given period of time. It just takes quite a bit of time. But especially between that 5 and 8 month mark, you may find more weakness in the quad tendon group in particular, followed by the patellar tendon. And lastly, hamstring tends to do the best, right? And then it flips from knee flexor strength. So essentially the hamstring strength is reduced substantially up to 2 years following surgery, whereas the quad tendon is pretty much equal to the bone patellar tendon bone grafts. And this is also a problem. It's tough because the quad is super important, right? We know this, but so is the hamstring. Hamstring strength is super important because it helps to counter the quadriceps pulling the tibia anteriorly and putting strain on the ACL. So it's almost like pick your poison, right? We know that they're both extremely important. We want to ensure that we're doing the best thing for the patient, but at the end of the day, there's pros and cons of both. The one thing that surprised me is that it seems like the knee flexor strength takes a lot longer to return than the quad strength. And I think as physical therapists, we don't see people at the 2-year mark generally. We're seeing people, if we're lucky, up to around 9 months or so, right? And measuring at that point before we send them back to their sports. And the quad has a better chance, based on these studies, of returning compared to the hamstring, at least from a graft standpoint. So pros and cons of both. All right. How about return to sport rates? So essentially, if we choose a specific graft type, it's just going to influence the ability for the patient to get back to sport. So overall, about an 82% return to sport rate for athletes after ACL reconstruction. What's really unfortunate is that only about 63% of these folks are returning to sport at the same level, right? So folks are getting back, but not the same rate. That's not really great. And there's generally no difference between graft types. There is mixed evidence on the quad tendon. Quad tendon is new kid on the block. You see some smaller studies popping out showing better return to sport rates. There's a few that show like 100% return to sport rate after quad tendon, although keep in mind that is mixed. There are similar return to sport rates for allografts also, but just keep in mind the autograft is potentially better from a failure standpoint. So you still want to consider the failure rates and not just say return to sport rates are the same. Go ahead and get that allograft, right? Any thoughts before we move on here, Kevin?
Yeah, just to reiterate what you said on the previous slide about the strength and when it comes back, that's definitely in line with what I see and why I feel like it's a big challenge to work with patellar and quad tendon, just because we put so much emphasis on quad strengthening that these folks tend to get symmetrical hamstring strength really quickly. I think generally in the first 3 to 5 months, but the quad strengthening for them is often delayed with pain. But exactly on the flip side with the hamstring, oftentimes we're still working on the quads a lot because of the knee effusion early on, and they start to get weak in the quad, but they do get that back a little sooner than the other two. But that hamstring strength can lag a lot. And that matters a lot for sprinting sports. And that's definitely something that's an issue, is getting that back. It seems like those folks have less pain in the hamstring than the quad and patellar tendon have in the anterior knee. But getting that strength back takes quite a long time and is something that is a persistent challenge. So they both, or all three of them, have pros and cons, I guess. But yeah, I think what you said was exactly right.
So putting on my clinician hat a little bit here, if you have someone that has anterior knee pain, right, and they have quad weakness, that makes rehab extremely hard. So I think one of the reasons and one of the things you'll see now, I think in the social media world, is that physical therapists are like, why do surgeons like the quad tendon so much? They're so hard to deal with, right? And this is not the case for everybody. Some people have a quad tendon and they move beautifully. They have minimal pain. They look great, right? Because we'll see a lot that are very stubborn, a lot of anterior knee pain, very weak. And the thing is, we're trying to get people to move well. So being able to descend into deeper degrees of knee flexion, be able to translate that knee forward is such a huge goal from a physical therapy standpoint. These folks just have a lot of trouble doing that. So pain, weakness, it just seems to delay physical therapy, rehab so much. And I think it ends up being a situation where the surgeons are like, these guys are doing great. You know, look at these return to sport rates. Everything is looking really good. And physical therapists are saying like, these things seem to have some major problems, because I think that physical therapy just relies so greatly on folks not having anterior knee pain, not being weak in the quads in particular. So I think that's one of the reasons for the discrepancies. Obviously, the stats show the quad tendon does well, but I think from a physical therapy standpoint, it's just a little harder for us. You know, I'm not sure if you notice the same thing, Kevin, but
yeah, the other thing I'll say quick is just the strength is one thing, but then the movement quality is a whole nother thing. And I think it really takes an expert clinician and coach to try to train them to load their knee, because they're going to choose, this goes hand in hand with gaining strength, but they're going to choose a movement strategy that unloads their knee. So they're going to choose a hip dominant strategy, and they're going to start doing a bunch of different things to try to create force without loading the knee joint. So we have to find ways to reduce their knee pain with loading and get them to load in a good way where they're getting their knee involved so they can get stronger. And that will help their knee pain long term. But the longer that you let them feed into these compensations, it becomes so difficult 6-7 months out to change someone's movement strategy that they've really hammered home those first few months as they're avoiding pain. So there's a lot that goes into it, and you really have to pay attention to those things.
Yeah, for sure. And I might be misremembering, but generally speaking, I want to say that the quad tendon is worse than the bone patellar tendon bone, but the rate of force development is also worse in these folks. And I think that becomes really problematic when you're trying to jump with somebody. So doing something like a single-legged squat when a weak, painful knee is tough, but then try jumping and landing with that thing, right? So it delays that whole rehab process. Now, all of a sudden, I'm like, I don't know if we should be jumping. And we're at the 4-month mark. Then we're at the 5-month mark or the 6-month mark. And they're approaching that 9-month return to sport period. And we're like, things still don't look good, right? I think in our minds, we just start thinking like, this quad tendon, I don't know if I like this as much. I know Lenny just had, I don't know, he gets all fired up about these things too, but he sees a lot of ACLs. One of our coworkers, I've mentioned a few times now, but he sees a lot of ACLs, a lot of quad tendons getting more and more popular. And one of those trends is like, man, they just don't look great from like a rehab standpoint. But long-term research is showing they're good. So I'm not trying to hate on them too much, but I think that's the reason why we think they don't do as well. It's because they don't seem like they do as well from rehab perspective. All right, let's talk a little about donor site morbidity and complications. So essentially the donor site means you have to harvest a graft from, let's say, the hamstring or the quad tendon or the patella. You can have pain as a result of harvesting that, right? We just talked a little bit about that. If you take the quad tendon, it tends to create some anterior knee pain. Same thing goes with the patellar tendon. And generally speaking, bone, patellar tendon, bone has more anterior knee pain as well as kneeling pain compared to the hamstring graft and the quad tendon graft. So the bone, patellar tendon, bone had more anterior knee pain than the quad tendon pain. Or quad tendon graft. So I just made this big stink about the quad tendon being problematic. You have the same thing that goes for the patellar tendon. And if you look at the percentages of folks that have anterior knee pain, the bone patellar bone graft, 72% of these folks end up with anterior knee pain versus 44% in the hamstring graft group versus about 9% in the quad tendon graft group. So, I just made this stink about anterior knee pain. The quad tendon in these studies actually had the least amount of pain in the front, right? The other thing I did find is that if you use a quad tendon soft tissue graft, ends up with significantly more anterior knee pain than if you take a bone plug so basically if you use a quad tendon patellar bone graft. So if you take a chunk of that bone, you're 2.7 times more likely or less likely, excuse me, to have anterior knee pain than if you just use a soft tissue graft, right? Hopefully that made sense. Essentially, the soft tissue graft is more knee pain than if you take the bone plug with it, right? The hamstring tendon graft has a higher risk of infection. So it's 5 to 8 times more likely to create an infection than the bone patellar tendon bone. And the quad tendon actually has even less risk. So you can see based on all these stats, that quad tendon is looking pretty good, pretty juicy right now for a surgeon. The allograft has a higher risk of infection versus the autograft, so even worse than the hamstring. And the allograft has no donor site morbidity. You already alluded to this. So essentially, these folks tend to feel a lot better after surgery just because they didn't have their hamstring harvested, their quad tendon harvested, their patellar tendon harvested, right? They tend to feel quite a bit better. And you just got to keep in mind, those folks actually ligamentization process, whatever the word is, a little bit more slowly, despite feeling better, right? So that's a little bit of a problem there. Any thoughts before we move on? Because we're about to kind of shotgun between some of the pros and cons of these graft types.
Yeah, like you said, I think on paper, the quad tendon looks pretty good with some of those statistics. It's interesting. I would have thought it would have had more higher rates of anterior knee pain, especially pain with kneeling. But I guess it's a little bit superior to where the stress would be on your knee with kneeling. And then I definitely would want to know why hamstrings have such a higher rate of infection. That's interesting. Whether it's like the back of your knee gets a little more sweaty or something. But
I don't know. I didn't look into that, but that is interesting.
That's a huge, I mean, that's a big rate compared to the other one. So
yeah.
Pros and
Yeah. I
cons.
wonder what the initial risk percentage is. And then like, obviously it was like 68 times, whatever it was. That's quite a bit more, you know. I wonder if it's like a still an issue from like a absolute risk perspective. The relative risk is high, but the absolute risk may be like minuscule. I don't really know, but
Good point.
just
Right.
kind of like you had said, you know.
Yeah.
All right. So let me make this big so we can kind of see this a little bit better. So we're going to go through the different graft types. We'll talk about the optimal patient, and we'll talk about the advantages, the pros, and disadvantages, the cons. So first graft type we're going to talk about is the quad tendon. And who is the optimal patient? Usually it's someone who is younger than 35 years old. They want to get back to a higher level pivoting sport and or high physical demand, like work or an activity or sport that requires kneeling. These are going to be optimal in skeletally immature patients as well. Some of the advantages of the quad tendon: they have comparable graft rupture rates of the bone patellar tendon bone, which is the gold standard, lowest rupture rates. They have a lower donor site morbidity than bone patellar bone, but comparable to the hamstring tendon. There's a possibility of a single site bone block harvest. So if you need it, you can take some bone with it. There's a possibility of individualized graft size by harvesting partial or full thickness graft. So one of the things you're trying to do is to mimic the same size in the cross-sectional area of the native ACL, and you can have some variability in the way you do the surgery to match that a bit if need be. And you have less flexion strength loss compared to hamstring tendons. Some disadvantages are that there's no longer-term outcomes quite yet. So essentially, we don't know how well they do 10, 20, 30 years down the line, just because it hasn't been studied as much yet. There's going to be decreased extensor strength, particularly in the short term, and that's compared to the bone patellar tendon bone as well as the hamstring. There's also a risk of patellar fracture or quadriceps tendon rupture. It's very low risk of quadriceps tendon rupture and fracture, but obviously when this does happen, this is a very bad thing to occur. Let's move on to the bone patellar tendon bone graft. The optimal patient is going to be less than 35 years old. The optimal patient is going to be participating in higher level pivoting sports or high physical demand. Some advantages is that you have bone to bone healing. So essentially you have bone on both sides of the graft, which potentially heals a little bit better. So you can potentially perform more aggressive rehabilitation just because that bone may potentially be healing faster early on. There are low graft rupture rates comparable to quadriceps tendon. They have high return to sport rates. The disadvantages are the highest rate of donor site morbidity and anterior knee pain. So these folks tend to have more pain in the front side of the knee during rehab. They have higher rates of osteoarthritis progression. There are some studies that show that. We talked a little bit about that in the last episode. They have a risk of patellar fracture or patellar tendon rupture. Very low risk, but there is a risk for that. There's no option for skeletally immature patients, meaning that they have to take some bone and it might not be appropriate or isn't appropriate for younger skeletally immature patients. There's a possible higher risk of contralateral ACL rupture in some studies and decreased extensor strength. Let's move on to the hamstring tendon graft. The optimal patient is going to be moderate sport and or activity level. If there's a smaller ACL footprint, the hamstring may match that a little bit better. If they have a desire to return to work or activities or sports require kneeling, just because not harvesting from the patellar tendon area, it takes stress while kneeling. It is appropriate for skeletally immature patients. The advantages are lower donor site morbidity compared to bone, patellar tendon, bone. There's a possibility of individualized graft size by additional gracilis tendon harvest, different graft configurations. So they can optimize the graft via adding on the gracilis or modifying the hamstring tendon itself. There's no risk for patellar fracture or extensor mechanism rupture. These are very low risk side effects, but they can occur, and they're definitely not good when they do occur. And there's lower osteoarthritis progression compared to bone, patellar tendon, bone. The disadvantages are higher graft rupture rates compared to quad tendon and patellar tendon, especially in younger and active patients. That's why it's a little odd that a lot of docs still will do hamstring grafts in younger athletic females, right? There's increased anterior tibial translation after hamstring ACL reconstruction, possibly due to reduction in hamstring force. My apologies for messing up there. I'm just trying to read this straight off here. ATT is anterior tibial translation. So there's a little bit more laxity for these folks compared to the bone, patellar tendon, bone. There's a tendency towards higher surgical site infection rates, as Kevin was fearful of in the past slide. And there's decreased flexion strength. A lot of different things going on here. What are your thoughts, Kevin?
Yeah, good summary. I think it's kind of just weighing the advantages and disadvantages of each one for the person in front of you and for their long-term goals and the particular surgeon's preference. So I think it's important to keep all of those in mind and help educate the patient on those things. Like you said, I think the patellar fracture is rare. I haven't seen that. I've heard of it, but I've never seen it. But yeah, I mean, there are pros and cons to each one, and just important to keep in mind throughout the rehab process is how can we mitigate those disadvantages as best as possible.
Well said, Kevin. All right, and just to round things off, we'll talk about the allograft. So the optimal patient for allograft is going to be greater than 40 years old. That's definitely what we see clinically. Generally speaking, they have a low activity level and or physical demand. We tend not to see that always. I will say that the cadaver grafts we see are usually folks over the age of 40 that still want to return to higher level athletics like skiing. Skiing tends to be the big one. And they may be appropriate for multi-ligament knee injuries. Some advantages of the allograft: there's no donor site morbidity. What I will say is, from a physical therapy standpoint, like you said, Kevin, these guys are great to work with. They tend to progress really, really well, minimal pain. It's good stuff. The surgery itself has a faster operation time, which is good. There's a more predictable graft size, which is really nice because you're taking the cadaver, you know what you're dealing with, right? As opposed to going in and trying to harvest someone's own, let's say, hamstring tendon and finding like, okay, this is not the right size and having to make modifications, so on and so forth. Some disadvantages: they have a higher graft rupture rate compared to quad tendon and bone, patellar tendon, bone, especially in young and active patients. They have slower rehabilitation speed due to delayed graft maturation and incorporation. I will say that's misleading because they tend to feel like they're doing better, right? They may get to 8-10 weeks and they're like, oh, I'm feeling phenomenal, right? It's like, all right, well, we have to be careful because that graft is actually not doing phenomenal right now. It is ligamentizing. I don't even know if that's a word, but I've said it like 10 times in the past hour and a half. And we have to be cautious because as these folks are starting to progress and they feel really good, the ligament's not quite at 100% here. So we have to go a little slower with them. The last piece, there are increased costs to using cadaver grafts. So that's something that we potentially have to keep in mind there. All right, moving on. So if you've worked with enough patients that have had ACL reconstruction, you may have seen an LET procedure. That's a lateral extra-articular tenodesis. Oftentimes, it's done in conjunction with an ACL reconstruction. And if you are watching the video portion of this, you can actually see an image of the procedure. What they're doing is they're detaching a part of the IT band proximally. They're transferring that underneath of the ACL, and then they're fixing that to the femur. And like I said, it's performed in conjunction with the ACL reconstruction. I guess apparently, historically, back in the day, sometimes they didn't reconstruct the ACL. They would do just this procedure to try to restore stability of the knee. Now they do it in conjunction with the ACL reconstruction, and it does tend to improve rotational stability. It does also tend to improve return to sport rates with some studies. So Green et al. In 2023 showing a 100% return to sport rate. It was a smaller study size too, but that's much better, obviously, than some of the prior rates we've seen. And it can be used with the quad 10, or at least in that study, excuse me, the 100% return to sport rate was a quad tendon graft with the LET, right? And lastly, they also have decreased re-tear rates. So 11% in the non-LET group versus 4% in a hamstring autograft plus LET group. I know you have a patient right now that has an LET. Any thoughts on this procedure before we move on, Kevin?
Yeah, I think we're seeing it more often in at least the Boston area with patients who are deemed to be a higher risk of re-tearing. So perhaps that adolescent female specifically is they're usually just doing it to prevent a subsequent tear. And like you said, with that study, we are seeing a reduced risk of re-tearing, which is awesome. The other time that we're really seeing it is in folks who have torn already and they're having a second reconstruction. They tend to do that again with the idea that you're reducing risk of re-tearing. So it seems like a good choice, and I think more surgeons are looking at that as a preventative measure. And it doesn't seem to really change the rehab process. It doesn't seem to increase pain a lot in these folks. So be on the lookout for that, because we're seeing that more and more, and it is promising, which is great.
Yeah, and I know that Lenny kind of said this, but when the surgeons are doing the ACL reconstruction, after they reconstruct the joint, they may actually do a pivot shift, and if they're noticing there's still not the same rotary stability that they want, they may do the LET then as well, right? And then we'll talk about some indications now. All right, and Kevin already alluded to this, but what patients are going to be appropriate for adding this LET to ACL reconstruction? And generally speaking, these are going to be folks that are high risk to have a re-tear, right? So that would be female population, soccer athletes, elite athletes, so basically folks that are going to perform at a national or international level. If they have inherent ligamentous laxity, they have an increased posterior tibial slope, they have a high-grade pivot shift. So this might be also in surgery if they're noticing that they still have, well, prior to the surgery, the high-grade pivot shift, or after the reconstruction, they're still not happy with the pivot shift, they may decide to do that LET. If a patient had a prior revision, or excuse me, if this is a revision ACL surgery, if they had a prior tear, which is repaired, if you're a patient that had a associated meniscal root tear or subtotal meniscectomies, they may consider the LET. Or if they have a chronic ACL tear, when they go in there, they may do the LET as well. All right, the good old regular ACL repair. So this is interesting, but you can actually just repair the ACL. You don't actually have to reconstruct it. And I found a meta-analysis in 2019 from Dr. Wachuku, who's at HSS, and he's actually referred a few patients to us. So I just thought that was kind of interesting. And they did a meta-analysis of studies on ACL repair just to see the outcomes. Essentially, ACL repair used to be more popular back in the day. It's kind of had a little resurgence in popularity. And I think these authors were basically trying to figure out, is this actually a good idea? Should we be doing more of these or not, right? Just because repair strategies have improved over the course of time. So ACL repair is exactly what it sounds like. They repair the torn ACL. They don't reconstruct it. And essentially, the proximal end of the ligament is fixed back to its femoral insertion with anchor sutures. and that's going to be the best strategy for proximal tears, although there are multiple repair strategies. And this really depends on where that tear is. Is the tear more proximal? Is it kind of mid-substance, right? Which may be relevant in the future when we talk about the Bair procedure. Now, why would you consider an ACL repair over reconstruction? And you already noted this, but there's potentially less damage to the knee joint, so via bone portals as well as the graft site. So it doesn't cause as much damage to the knee. And this may potentially create less longer-term osteoarthritis. So repair might be more beneficial from that standpoint, although that's yet to be seen. We need to have more research to see if that actually occurs. And generally, the outcome from this study with Wachuku was that the ACL reconstruction generally outperforms the repair, even in these future studies with better surgical techniques, so on and so forth. And this goes for functional outcomes, as well as patient satisfaction and re-tear rates, with some authors even going as far as saying the repair should be contraindicated in younger athletic patients. And then Hugeslag et al. In 2022, and this was the most up-to-date article I could find, actually found similar outcome measures in the repair versus the ACL reconstruction, but they also said have caution when prescribing to younger athletic patients, just because of the repair rates may be higher in the repair versus the reconstruction. Have you seen any repairs at all, Kevin?
I have not. No, outside of the Bair, I haven't seen any primary repairs, so I don't have a whole lot of experience with that.
I want to say there are some surgeons out of HSS in New York City that will still do the repair. And Dr. Ramappa, who we get a lot of patients from, he spoke recently at the Sports Academy meeting for the APTA. He was saying that some patients are appropriate for the same reasons we just talked about. It is kind of interesting just because the procedure by itself is not as invasive. And for the right patient, older, maybe not getting back to very much, might be the best long-term outcome, right? So not really sure at this point, but I just thought that was interesting. All right. The new kid on the block, the local kid on the block in the Boston area, the Bridge Enhanced ACL Repair, otherwise known as the Bair. Very interesting surgery. So essentially, you have tunnels drilled through the tibia and the femur, similar to the ACL reconstruction, although they end up doing a suture repair, and this has to be with a mid-substance tear. So if you have a tear of the ACL that occurs more proximally, more towards the femur, they probably can't do this form of repair. It has to be a tear kind of the mid-substance of the ACL, right? Otherwise, the surgery is not going to work. And what they do is they suture the repair together, and then they place a bioactive scaffold to the repair site, and they add 10 milliliters of whole blood. The blood gets absorbed into the bioactive scaffold. The idea is that helps with healing. And the scaffold itself contains extracellular matrix proteins, including collagen. They're obtained from bovine tissue, so from moo cows. And that allows the ACL to heal over the course of time, as opposed to trying to reconstruct it, right? So they're basically putting the scaffold over top of the sutured ACL, which hopefully allows it to heal better than doing nothing, right? And one little stat from one of these studies here showed that pigs treated with the Bair procedure had less osteoarthritis over the course of time compared to the ACL reconstruction. So to your earlier point, Kevin, so these repair strategies like the Bair may lend to less longer-term osteoarthritis. At this point, we don't have those longer-term studies, which we'll go over the studies we do have in a moment, but we don't really know if the Bair is going to have less osteoarthritis over the course of time. That's one of the thoughts. Like if we're doing less damage with the surgery, maybe that ends up having a better longer-term outcome, right? Do you have any Bair patients right now, Kevin?
I do. Unfortunately, he retore his ACL. I know that's anecdotal. It's just one case, but he was pretty far out. I believe he was about 7 or 8 months out, and he was doing some single leg hopping at the gym and kind of knee buckled, really strong. I mean, he had incredible strength. I think what we talked about, some of the advantages of a repair in general, is that you don't have the other issues that you see when you harvest a tissue. So he felt really good. And I do think that the Bair protocol is slow and conservative for a reason. I think part of it is that it's still relatively new, so they don't want to be too aggressive early on. And I just wonder if this particular case, he was pushing the limits a little bit too early. But, we'll learn more as we go. So he's actually getting it repaired with another Bear procedure. And he's about 3 weeks out now. And we'll talk about the rehab, I guess, but the early post-op is a lot slower. There's no passive range of motion allowed in this particular case for, I believe, the first 12 weeks, no passive motion from the physical therapist. So part of it,
flexion
into flexion. Yeah. Extension's fine. Into flexion. He can actively move into flexion, and he's encouraged to do that, but there is no passive motion from the therapist. And I don't know if that's just this particular motion surgeon's protocol or the Bear in general is opting for that, but it is slower from that standpoint. But again, he feels good, and I think it's because there's no tissue harvested from other places. So, part of it is we have to keep an open mind, and we can't be too upset about the fact that there's no long-term data on it yet. But it's promising that if it has a lot of potential advantages. I think we just have to see what these disadvantages are over the course of time, but it is attractive on paper.
Yeah, it's kind of like the cadaver graft.
Mm-hmm.
No donor site morbidity. Patient feels good, progresses fast, right? Just probably need more research. We're going to go over the research we have so far. So what are the outcomes of the Bear procedure versus ACL reconstruction? There's one study right now. There's a meta-analysis of just 2 studies, which was called Bridge Enhanced ACL Repair versus ACL Reconstruction for ACL tears, systematic review and meta-analysis of comparative studies. This is in 2023, so relatively recent. The problem, only 2 studies at this point, right? And I went in, I looked at those individual studies. It wasn't that hard to do it, just 2 of them. And essentially, the first study, let's say the earlier study, I believe, was all autografts of the hamstring, right? Versus the Bear procedure. It's 20 participants, 10 Bears, 10 ACL reconstruction with the hamstring. I know Lenny's criticism of this study was that they're all hamstrings because he's such a bone patellar bone guy, right? But there's a more recent study that was looking at autografts of both hamstring and bone patellar bone. I tried to look and see how many hamstrings versus bone patellar tendon bone. They didn't note on that in the study, but it was 100 participants. There was 65 Bears and 35 ACL reconstructions, which were mixed between patellar and hamstring in that study, right? And they looked at a variety of outcomes. So essentially the IKDC score and the KOOS. And the Bear had better short-term outcomes, similar to what you were kind of finding potentially, and had a similar long-term outcome. That makes sense. Maybe it's that donor site morbidity with the reconstruction. And after a while, essentially the reconstruction kind of catches up. So if you look at failure rates, there's no difference between groups, which I think is nice, right? Like you said, N of 1 anecdote, you saw a tear. I mean, if you work with ACLs for long enough, you're going to see tears. It's going to happen, right? Sure, the Bear is no difference from what we're seeing. But that was interesting to me. The re-tear rates were about the same. And then anterior posterior laxity. So looking at that KT1000 testing, no difference in laxity at all time points, which I think is, good stuff. In terms of strength, looking at strength of the hamstring, the quadriceps, and hip abduction, the Bear outperformed the ACL reconstruction for hamstring strength only. And this is because probably majority of the folks in this meta-analysis were hamstring autografts. So that makes sense. We know they're going to be a little bit weaker. When you look at hop tests, the Bear produced a better 6-meter distance hop, which, to be honest, I don't even know what that test is. But imagine you're set up 6 meters and have patients hop, and as many hops as it takes to get 6 meters. I'm not even sure what that is. But they used other hop tests, and the results were the same between groups. In terms of return to sport clearance, and I didn't really like that they used return to sport clearance, but essentially they were trying to figure out at what time point were folks cleared to return to sport. It wasn't their return to sport rate, and it wasn't return to sport at what level, like we're used to seeing. So that was, I'm not sure why that authors wanted to look at that. I mean, in the study, they said that that's a gap in our literature, which they wanted to basically figure out what these were. But I would have been much more, wanting to see the actual return to sport rates and at what level play, but they didn't report that at all. So here's what they found. By the 1 year mark, an estimated 88% of the Bear group and 76% of the ACL reconstruction group had been cleared to return to sport. And it was similar at the 2 year mark. But this was most likely explained by hamstring weakness. Because the ACL reconstruction group was weaker in the hamstring, they weren't given clearance to return to sport as much. And that was the main deficit, right? So at the end of the day, I don't know how much this tells me, besides the fact that, the hamstring group is weaker, which we already kind of knew, and the Bear seems to do better a little bit faster. And then maybe the hamstring kind of catches up, which we already know that happens over the course of time. We definitely need to know these return to sport rates and the return to sport rate at the same level. That's going to be very, very important. I think that's, once we get some of that data and then maybe some of the longer term osteoarthritis, then I might start to say like, okay, this Bear really does seem like it's going to be a good option. Plus, if you look at the study sample size, it's pretty dang small, right? I mean, we've got studies, ACL reconstruction of like 50,000 ACL reconstructed knees to look at these re-tear rates. Like this is a total of 120 total patients, right, across all groups. So that would be my major complaint, and reservation. I think the Bear seems like a really cool procedure, but, we still got to pump the brakes and make sure that, we don't jump the gun here with this procedure. Any thoughts there, Kevin?
Yeah, I think that you want to help your patient understand what's known about the current procedure that they might do. So I feel like if I had a younger athlete who's really trying to return to a higher level sport, we have long-term data and we can feel confident that they can get back with something like a patellar tendon bone graft or a hamstring or quad tendon graft. For someone in that position, I don't know if I would yet recommend they do the Bear, just because I would tell them that, it could totally work. We just don't know yet. We need more long-term data, and it's up to the patient and their comfort level of being kind of an early experimenter. But I do feel like for me, if I tore my ACL, I think I would consider the Bear because I run. I don't do pivoting cutting sports. And not that it's not going to be good for that. We just don't know. But I would be okay accepting risk of doing something that's slightly unknown just because of what I like to do in my activity level. It's not cutting, pivoting sports at this point in my life. It's running in a straight line, working, being in the gym. And I think it would be cool to do the Bear. And it's attractive to me that they're not drilling into your tissue. And I feel like common sense would tell me that over time we would see less rates of arthritis. And I know you had mentioned some animal studies show that. And I know that's how they market the Bear. Like if you look on the website of surgeons that do the Bear procedure, one of the first things they tell their patients for education is that you're likely having less risk of arthritis. So for me, in my point in life, I would consider doing the Bear, or I would consider doing non-op rehab and see how it goes. But that's just my own opinion on myself. I think it would be fun to figure that out. But you want to let your patient know that if you want to get back to higher level activity, we have more data on these reconstruction options. So maybe that's better for you if you don't want to take the risk of being kind of a guinea pig.
Yeah, I kind of agree with you. It's almost like you want to, we're physical therapists, right? We do this for a living. We're very interested in it. It's almost like I would want to try it just for the experience,
Totally.
I don't know that I would counsel my patients to do it, but just because it's an interesting idea and I like the idea of it, and I'd like the experience. It's almost like visiting the Amazon or something. Like I love, seeing capybaras. I have no idea there's capybaras in the Amazon, but like, just because you want that experience, you're like so into it. Just the whole rehab, the nature of it just seems interesting. Right.
Yeah.
But yeah, I do think that at the end of the day, just because it's interesting doesn't mean it's always the best, but it is kind of cool. And I like the idea as well, just like you had said. All right. The surgery date is scheduled. However, we do need to do some pre-op physical therapy. Here's what to do to improve your outcomes after surgery.
All right. So yeah, what does the evidence say? I'm going to talk about a couple different studies. This first one was a systematic review it included 3 randomized controlled trials. So it was from 2020, and it was titled The Effectiveness of Pre-Op Rehab Programs on Post-Op Outcomes Following ACL Reconstruction. So we're talking about reconstructions and looking at a couple of these randomized controlled trials. So awesome. So just a little bit of background. So this systematic review included 3 studies that were randomized controlled trials that the authors concluded had a high risk of bias. So just in the study design, that's kind of what they were finding. All studies included variations of strengthening, control, neuromuscular control drills, balance, and perturbation training. So there was a little bit of variation within the study, but they all included something along those lines. And the frequency of the PT prior to surgery varied from 10 to 24 sessions, and that was spread over the span of 3 to 6 weeks. And their findings were that there were statistically significant differences at 3 months after ACL surgery for improvements in quad strength and single leg hop scores in the prehab versus the control groups. So they did find that there was some benefit, and specifically in the quad strength and the single leg hop. There were no statistically significant difference between groups for pain and for self-reported function, and that was at 3 months post-op. So in this kind of study here, this systematic review, they did find some benefit to prehab, which I thought was awesome.
Dang, dude, freaking hop testing 3 months post ACL reconstruction.
I know, isn't that crazy?
Hardcore, dude.
Yep. No, I don't know if there were any re-tears. They didn't say, but that would be a bummer. So this is from the author's conclusion. They concluded that there's very low quality evidence suggesting that prehab offers a small benefit for improvements in quad strength and single leg hop scores 3 months after ACL reconstruction compared to no prehab. There is no consensus on the optimum prehab program content, frequency, or length of time. So, I wanted to start out this episode by talking about, I think, the highest quality study we have, at least in terms of including randomized controlled trials. I think surprisingly to me, there weren't a lot of studies with randomized controlled trials for this particular topic, but there are a lot of cohort studies. So kind of prospective and then retrospective studies that I'll talk about coming up. But this was a good one to start off with, I think. So kind of diving into the next study that I thought was a really, really good study. This was published in BJSM in 2014. And this is with a research group that you kind of see come up time and again in the ACL world. And the study title was, How Does a Combined Pre-Op and Post-Op Rehab Program Influence the Outcome of ACL Reconstruction 2 years after surgery? A comparison between patients in the Delaware Oslo ACL cohort and the Norwegian Knee Ligament Registry. So they're comparing these 2 different groups and how do they do with a structured pre-op and post-op program compared to kind of your standard of care. So can talk a little bit about that on the next slide. A little background on the study, just about the Delaware Oslo group. So this is the University of Delaware has been conducting a lot of really good, high quality research on ACL, ACL surgeries, ACL pre-op, ACL post-op, and they work in conjunction with this hospital and team in Norway, in Oslo, I guess. So you'll see that in the research, that group that is working together. And if you're looking at the slide, the left side of the screen kind of talks about what patients are in the Norwegian cohort of the Oslo study. And then on the right side is how they're comparing groups. But they're comparing knee function pre-op and 2 years post ACL reconstruction in patients undergoing progressive pre-op and post-op rehab versus what they're deeming as usual care. So they compared the outcomes of 2 groups. The first group is what I'll call the NAR group, and that's the Norwegian Research Center for Active Rehab. That is the University of Delaware's cohort in this study. That's the control group. And they're comparing that to the experimental group, which is the Norwegian Knee Ligament Registry group. And this is where any patient in Norway undergoing ACL surgery gives their information. They kind of take all the information about the patient, what type of graft they're having, how long after surgery they're getting how long after their injury they're getting surgery, if they're doing prehab or not. All that information goes into this registry. So they're looking at this control group versus the registry of patients. The NAR group, so the control group, underwent at least 5 weeks of pre-op PT before ACL reconstruction. And I thought what was nice about the study here is that they created some criteria that they were shooting for before letting these patients go into surgery. So what they were asking is they were trying to get at least greater than or equal to 90% muscle strength. And that's in terms of quad strength and hamstring strength, and hopping ability on the injured leg compared to the uninjured leg prior to surgery. This group of researchers previously showed a significant short-term improvement in knee function and a low rate of adverse events with this approach. So that's a study that I will talk about in a little bit. They used their protocol from this previous study. And the outcome of interest at 2 time points is what they were looking at. So preoperatively was time point 1, and then 2 years post-op was the second one. And what they were using as their outcome of interest was the KOOS, so the knee injury and osteoarthritis outcome score. The inclusion criteria to be in that Delaware group, the control group, the NAR group, was a unilateral ACL rupture in the last 3 months. So we're looking at more acute injuries. The age range for their study, their cohort, was 13 to 60 years old. And they had to be participating at least 2 times a week or more in a pivoting sport. So these are people who are at least doing some high level of activity. They're not sedentary folks. The exclusion criteria was that they had a bilateral knee injury. They had MRI, which showed other grade 3 ligament injuries. So they were allowed to have some, irritation or damage to the ligament, but not a grade 3 ligament injury, so a full tear. They were excluded if they had a fracture or they had articular cartilage injuries. Meniscus injuries were only excluded if they had symptoms during the prehab program, and that was during the plyometrics. And a couple people did, which I'll talk about, and their symptoms did not resolve at 3 months from the injury. And then, so that was for the control group, the general inclusion criteria and exclusion criteria to be part of the study. But what they looked at for comparison with the Norwegian Knee Ligament Registry, the NKLR group, was that both groups, they wanted the patients to be between the ages of 16 and 40. They had a primary ACL reconstruction, and then the exclusion was similar things. So they didn't want to include anyone that had a concomitant cartilage surgery or surgery to any other knee ligament, which included a PCL or LCL or an injury to the posterior lateral corner. They couldn't be included if they had a previous cruciate ligament injury to the contralateral knee or previous surgery to the knee, the index knee, the knee that they were doing in this study. So I thought that was good. They tried to group together similar patients. That's obviously a big issue when we have a lot of diversity. Some patients have all these other concomitant injuries. Some patients are 16 years old and some patients are 60. So they did try to group them together a little bit into similar characteristics, which obviously makes our study more reliable. So I think pretty good job there by the authors. Okay, so getting into the study, what did they actually do? What did the prehab group look like? So they did a 5-week preoperative rehab program, which I'll talk a little bit more about in a future slide. And that goal for them was to their aim was of achieving greater than or equal to 90% muscle strength, as well as quality performance on hop testing. And I thought this was interesting because I think myself and other therapists I've talked to, we get a little bit nervous before surgery of doing anything to further damage the ligament or something else in the knee. But I think with their program, what we were seeing is that, they were saying it's okay to do some plyometric training pre-op. It's okay to do some aggressive strengthening. We obviously want to monitor pain and swelling, but if we can get patients to this, and this is what we'll talk about, why prehab is important, they definitely show that patients who hit this criteria before surgery do better after surgery. So their rehab program consisted of heavy resistance training, plyometric training, and neuromuscular exercises. Again, I'll talk a little bit more about that study coming up. And they initiated it as soon as joint effusion and range of motion deficits were resolved. So that's something important to keep in mind, is they weren't having these folks do plyometric training with a bunch of swelling and limited range of motion. They were thinking of this in a phased approach. So, let's phase one, get down your pain, and let's get down your swelling and improve your range of motion. And then when that stuff's resolved, perhaps not going right into surgery, let's try to get these other metrics hit, greater than 90% strength compared to the other side, decent performance on the hop tests, and then initiate surgery. So their findings were that there were large differences in the KOOS sports and the quality of life subscales favoring the NAR cohort. So that group that did the prehab. Compared to usual care, they had superior pre-op patient-reported knee function, and they still exhibited superior function 2 years after surgery, with 86 to 94% of patients scoring within the normative range in the different KOOS subscales. So a big win for prehab in this particular study when they're comparing it to the usual care in Norway, at least. But I think that's probably pretty good proxy for usual care everywhere.
Yeah, that sounds awesome. I love to hear it. That's pretty cool. One of the things I will say, and just like the length of time, basically from the injury to surgery and the ability to do plyometrics and more aggressive strength training, I've had this happen with some patients where they're like, do I need surgery? Right? It's like they're hopping, right? They're lifting heavy. They're doing a lot of stuff that's sometimes more than what they normally do. And the thought process becomes, crap, now I'm going to get surgery. I have to do this all over again. So, yeah, really good to see that this prehab is helpful, but also frustrating for patients because they get to the point where they're feeling pretty good, range of motion resolved, quads coming back, strength is getting back there. They're hopping, they're jumping, and maybe even more than what they're used to doing in the past. And then now we're going to go back and get a surgery and start all over again. Mm-hmm. But good to see that it helps, right? Definitely good to see that it helps.
Yeah. So just a summary statement from the authors of this particular paper is they said, it is likely that the patient education, the psychological strategies utilized by the doctors and the physical therapists treating the NAR group differ from usual care. So, they're saying that it's probable that these patients were getting better care than our standard of care or what we usually see. So that's a consideration. And they believe that these patients benefited from more comprehensive follow-ups in a clearer goal setting than usual care. So they were really good about hitting their kind of preoperative goals. And I think, whether it's showing that this exact protocol is the best, or they're kind of saying that it's the attention to detail, perhaps, that you get when you do this type of pre-op strategy versus the usual care. There's probably so many factors of why these patients do better. But they wanted to just make note of that it might not be the exact protocol, but it's kind of everything put together that you don't get when you go a traditional route where you maybe don't do prehab and you just do your surgery and, that kind of thing. I think what's really good about this group of researchers is it's almost like as they design their research studies, they have a long-term plan in mind. So this study that I'm about to talk about came before the study I just talked about. This is where they designed their prehab program. And then they said, okay, now we have a good prehab program. Let's put that into the study I was just talking about and see how these folks do with our combined prehab and post-op program. But this is their initial study that they did in 2010 that's titled A Progressive 5-Week Exercise Therapy Program Leads to Significant Improvement in Knee Function Early After ACL Ligament Injury. And this is where they were trying to validate their 5-week pre-op program and see how it does before surgery and post-operatively. So we'll get into the details a little bit more here. So a little bit of background. This is a prospective cohort study. So there were 100 patients which were included in a 5-week progressive exercise program, and that had to start within 3 months after the initial injury. Knee function was evaluated using isokinetic testing. So they were testing both the quadriceps and the hamstrings, as well as the 4 different single leg hop tests that you see in a return to sport type setting. And then they used 2 different self-assessment questionnaires and a global rating of knee function scale. So they had a lot of kind of good data in here together to conduct this study. And their findings were that a progressive 5-week exercise therapy program led to significant improvements in knee function from pre to post test. The observed improvements in muscle strength and single leg performance were moderate to strong, indicating the observed improvements to be clinically relevant. So this is how they validated their pre-op program, and they found that doing pre-op physical therapy, which included strengthening, neuromuscular training, perturbation training, balance training, plyometric training, led to better outcomes in kind of all the markers that we would care about. So it's pretty good. And further continuing with this study, they noted the rationale for the study draws on previous data. So the 5-week progressive program includes strength, plyometrics, general exercises for balance and stability, and perturbation training. So what they use to justify adding these things, why these things? So for quad strengthening, they were looking at other studies that showed that individuals with pre-op quad strength deficits above 20%, so less than 80% symmetry before surgery, they had persistent, significantly larger deficits 2 years after surgery. So, a lot goes into that. Is it just because they couldn't hit these numbers pre-op? Probably not. But, maybe that means a more significant injury. Maybe that means that they're not at a place where they're getting good quality rehab, but it's a good marker and something that we want to shoot for preoperatively. So we know if your quad's very, very weak before surgery, we can see deficits up to 2 years after surgery, which is pretty crazy. Now, when I think of this type of prehab, I'm definitely thinking of strength. But one thing I was reading that I thought was interesting, and I mentioned to Dan this week, was Lynn Snyder-Mackler, one of the researchers here from Delaware, conducted a study focused on perturbation training. And what they did, she had a whole protocol, and that study's referenced in the references page that you could go look at for the specific protocol in their progressions. I thought it'd be too much to add to the episode, but it's worth looking at. They had a perturbation training and strength training group versus just strength training alone. And the study showed that a combination of perturbation and strength training pre-op led to more symmetrical gait at 6 months post-op, as measured by knee excursions compared to just strength training alone. So doing that preoperatively seems to be more helpful for normalizing gait post-op at 6 months, which I think is pretty wild. And what they talk about when they're looking at knee excursions is that when you think about like your jumping and landing mechanics, or they're looking at gait specifically, but healthier knees tend to have a little bit more movement in play. It's that person who's not doing so well that when they're walking, their knee is so stiff, they're not getting that terminal knee extension in part of the gait cycle. And it looks like they keep, 15 degrees of knee flexion throughout the entire gait cycle. And those are perhaps folks who, if they did some perturbation training pre-op, could have a little bit better gait quality later down the road. So I think that's an important thing to think about. And, I don't want to do a disservice to her protocol and every single progression they had, but very generally, it's kind of like they're on a rocker board and they're doing kind of different, double leg, tilting forward and backward, tilting side to side, progressing to single leg. And, it's when they're on a surface that's unstable. So unstable surface training is really what they were doing. And they were progressing throughout from double leg to single leg and then increasing distraction. So kind of doing things with their upper extremities and just they were progressively making it harder. And that's the type of exercise that they were incorporating with that.
Yeah, good stuff. I was just the perturbations, so they just kind of like manually giving perturbations as they're moving, perturbing the rocker board, that kind of thing.
So in this study, I think in her protocol, it was more the rocker board was providing the perturbations for them. But you could easily get creative with that. And I know kind of one of the godfathers of physical therapy, Kevin Wilk, he's always posting content like this. And I know he's very creative with his perturbation training. So you could always check out some of the stuff he's putting up there. But I think that type of thing, you can make the challenge almost infinitely hard by perturbating the person or perturbating the board that they're on. But just starting, I think for her protocol, it was mostly going from double leg to single leg to different, anterior to posterior is a little easier, I guess, than medial to lateral. So kind of starting that way and then progressing. But I think we could definitely make it harder too by, working on hitting the person and that type of thing.
All right, makes sense.
Yep. And then just their justification for adding these other things is there are some studies that show for plyometric training, it enhances muscular strength and athletic performance. That's well studied just for performance in general, not just for rehab. But one thing that they did note is that because they did include patients with meniscus tears in the study, some of those patients with plyometric training specifically had a flare-up in their knee. So 3.9% of people in the 5-week program had an adverse reaction, and the adverse reaction was with plyometrics. So these patients were just getting more swelling, and they had criteria for, are you able to continue doing this or not? And for them, it was, if you're having an increase in swelling that doesn't return back to baseline within 24 hours, we have to go down a level in your pre-op program. So for these folks, they found that these particular people, when they went in surgically, the surgeons were seeing evidence of a meniscus tear. And the authors, they did note in the study, they didn't think the tear was from the plyometric training. They didn't think the mechanism was substantial enough to create a meniscus tear. But I think that's something to keep in mind. I think for me, if there's one group of training that I'm probably going to be cautious with pre-op, it would be plyometric training. But I also think that what they showed here is with the, vast majority of these 100 patients, only 3.9% of them had an adverse reaction. So most of them didn't. And we can be confident and feel safe doing some plyometric training before surgery. It's probably a good thing to do. And then their justification for neuromuscular exercises was that exercises for proprioception and balance may improve dynamic knee stability and thus functional ability in patients. And they kind of grabbed that from a study on neuromuscular training. So they were searching for justification for using these things in their pre-op program. And I think it was pretty valid stuff.
Yeah, that's cool. Seems like one of the takeaways is that you work pretty hard with these patients pre-op. One of my thoughts is, and I posted this stat recently, I forget the author, but something like only 30% of folks after ACL reconstruction, so after they get surgery, even do plyometrics, right? And they're advocating for plyometrics prior to surgery. The majority of folks don't do pre-op. So it seems like you're doing a very robust job. It's not like you're returning back to sport prior to surgery, right? You're not doing that level of degree of skills, plyometrics, running, so on and so forth, but you're getting pretty dang close. It sounds like you probably want to be nice and robust with your training. Because my takeaway is, generally speaking, in the past, I haven't done any plyometric training with my pre-op ACLs, but I think I'm going to start doing it now, Kevin.
Me too. I mean, that's definitely something I'm guilty of, is get nervous and even like heavy strengthening. I think I've been more apt to do blood flow restriction training. But I do think, like you had said, there are a lot of patients in this cohort that the week before surgery, they're like, wow, I feel so good. Like, do I even need the surgery? And that's probably the point you want to get them to, because we know how quickly much muscle atrophy occurs and how quickly, not even just muscle atrophy and strength, but probably the fast twitch muscle fibers and like how quickly people move, that kind of agility and speed. People lose that so quickly that if you're able to hold on to that as long as possible before surgery, I think that's good. And I was surprised that I think we tend to see in our area, doctors are good about wanting people to wait a little bit for surgery. They definitely want to achieve that quiet knee. And I think it shows that if they're doing at least 5 weeks of pre-op in this study, we don't have to rush surgery necessarily. Let's take our time and make sure that we're in a good spot before, because it can really lead to better outcomes after. And, I think this study was pretty good at showing that.
Yeah. I know that, if we rush this process and get them to surgery too fast, that may lead to problems as well, right? And I think the other part is that basically from our last show, we talked a little bit about how delaying doesn't necessarily cause problems as long as you're not doing anything crazy, right? You can delay even for years, 2 years. I think the one study we're talking about, and not have any adverse event from a meniscal standpoint, anything along those lines. So I think the main thing is that it's going to be a planning issue. So you're going to have some patients want to get back to sport. So when you get the surgery, kind of dictates how long it takes afterwards. Obviously, there comes a planning issue depending on when your athlete wants to get back. But if your individual athlete doesn't have a schedule, right, and they can get back whenever they want to and have a longer runway, maybe we just do a better job early on, and that can lead to better outcomes, right? And it's not like you save time per se. If you do 6 weeks of rehab at the start, doesn't mean you can return back at 6 months, right? You still have to wait until 9 months, whatever it is. But at that 9 month, you'll probably be better off if you do the work beforehand. That's what it seems to be.
All right. So just putting it all together here, it does seem like kind of a summary slide that prehab prior to ACL has been shown to improve preoperative strength, hop testing, and function in cohort studies. There are only a few randomized controlled trials that I found. There might be more out there which have replicated these findings, but in the studies we have bias is high and more studies are definitely needed. This is always challenging though, because if you do feel like pre-op is really helpful, it's hard to create a study where you're not giving your patient that, right? You kind of know you're doing harm in some sense. So you wonder if that's why there's not a lot of studies looking at that. But maybe we'll see more over time. I don't know. And then the best available evidence we have right now suggests that first, most important thing is that we restore range of motion and abolish swelling. So they talk about getting swelling to a 1 on the scale that we tend to use for swelling. So that would be where you can kind of milk and sweep away a little bit of the swelling, and then it doesn't come back on its own unless you push it there. If someone just has constant pouch swelling in the knee that you can't get rid of, you probably want to get that down a little bit before surgery. Progressively loading everything, but especially the quad and the hamstring in open and closed chain is safe and something we should do before surgery. We should include some perturbation training and neuromuscular training in a progressive fashion. And I think there are some pretty good protocols out there. One of them is the Lynn Snyder-Mackler study that is in the show notes. And then include plyometric training if it is well tolerated and safe to do so. And just be sure to monitor pain and swelling. And if you are having an increase in swelling, take a step back in the rehab program and go to where you knew you were having success. You don't have to hammer plyometric training. I think if they're not tolerating it well, that's okay. Don't do that. But if it's safe to do so and they're doing okay with it, don't be afraid to add it. I think that's kind of a good takeaway here. So hope that helps and you start doing a little bit better rehab here, or prehab, I should say.
Prehab for sure. Kevin, I don't know if you came across this at all, but in terms of strength, so basically 80% LSI is what we're looking for prior to surgery.
Yeah, I think their goal was close to 90. They didn't exclude people from surgery if they didn't get that. They didn't say you got to keep training, but that was their goal. And I do think at least 80% is definitely some criteria they were advocating for.
Okay, yeah, that makes sense. So it does, and this has kind of scared me a little bit too, but safe to handheld dynamometry test these guys as well, right?
Definitely.
Kind of freaked out, and especially when I remember a patient when I was in my first or second year, something like that. It was my very first pre-op ACL, and I was like, holy God. Like, initially, it's real swollen, very painful. This was just a particularly painful patient, right? Like, you definitely see those folks a tear. You're like, did you really have a tear, right? But this patient was very sore, very scared, very fearful, and I was just faking it. I was like, it's okay. You'll be all right. And I just exercised with her, and I just trust like some of the research, but it was freaky. I'm like, am I going to cause a cartilage injury, a meniscus injury? Is your joint stable at all? Can I do these things? And I think the answer is yes. Obviously, be smart in the early stages. You're trying to get swelling down, trying to get range of motion back. Don't do jumping or aggressive strengthening when they're still very swollen. Like you said, you're trying to achieve that quiet knee first, but we definitely want to get that quad back on board. To me, my rehab is very similar to early post-op ACL reconstruction. So I'm using things like NMES. I'm using things like blood flow restriction training. We're using ice. We're doing a lot of frequent range of motion throughout the course of the day. We're being gentle at the start. And then as they progress, you don't have to be fearful. Like, we can do squats, lunges, single-legged deadlifts. We can do some hop training. Just treat it like you would, let's say, patellofemoral pain or non-op meniscus tear, something along those lines. It's a pretty similar rehab, but just we know that we're eventually going to go get surgery if the person decides, or maybe if they're happy enough, they won't. Who knows, right?
Yep. Yeah. And one thing I'll say there is what I've been tending to do recently for the pre-op patients is, maybe their first time in physical therapy during the eval, if the injury wasn't that long ago and they're still really painful, is get strength numbers for the non-operative side first. And then, I always will do a manual muscle test in the position that I'm going to do the dynamometer testing and see if it's painful. Like, if day one, they're swollen and it feels terrible, you don't have to test that day. If the surgery date is not for a month or so, test before the surgery and let the knee calm down. Do a lot of the exercises you were just talking about. Get them in that test where I'll manual muscle test again. And then they're like, hey, this doesn't hurt. It feels fine. Then I'll take them and strength test them with the dynamometer. So, you can be a little strategic about it. You don't have to test them day one if their knee's really painful. They might be afraid that you don't know what you're doing because why are you having them push through this pain? So just be smart about that. And you want to get those numbers if you can, but don't go crazy at the expense of making the patient hurt and not trust you. You could test later. You can always test a little bit later before surgery.
Yeah, it makes total sense. And the other thing that we're constantly battling, and this is, alluding towards the next episode, but when we're trying to rehab folks after ACL reconstruction, the problem is that the surgical side is getting stronger, but then the non-op side is getting stronger and stronger and stronger and stronger, even faster sometimes. And we know this. There's studies that show that the uninvolved side is getting stronger, and it's getting stronger than it was prior to surgery, right? So if you can have a fresh ACL tear and test that contralateral side, you actually get a more true baseline, because as you progress them through strength training, if you're doing a really good job with your strength conditioning and that patient is not used to strength conditioning, they're going to get much, much stronger on that contralateral leg too. It ends up being a little bit frustrating. It's a problem we'll talk about how to solve probably in the next episode. But if you get that test number prior to them getting the ACL reconstruction, especially if it's close to the initial injury, the contralateral side, that's actually a decent measure of where they kind of ultimately need to be, or obviously where they started beforehand. So ACL reconstruction rehab is one of the toughest rehabs a physical therapist can go through. In this section, we'll talk you through this complicated process and make it practical and simple. Today's video, we're going over 12 keys to successful post-op ACL reconstruction rehabilitation.
All right. So there are so many ways I felt like we could have taken this episode and how to distill the information out there. But I think these two articles included a lot of good information. And although a bunch of other articles are included, I think these did a good job of covering the basics and everything that I think we should be thinking about. And I'm sure there's things I've left out. I tried to be pretty comprehensive with this. So the two articles, the first one, if you're looking at the slides on the top left, was published in Sports Health in 2021. And this is from Lynn Snyder-Mackler and colleagues. So that research group that does a great job and puts out a lot of good quality information, I think. ACL Reconstruction Rehabilitation, clinical data, biological healing, and criterion-based milestones to inform a return to sport guideline. So that was one study that I included here. And then the other one is from Kevin Wilk, great researcher, has put on a lot of good stuff. And this was in Clinical Sports Medicine in 2017. Rehabilitation principles of the ACL reconstructed knee, 12 steps for successful progression and return to play. So I landed on 12 keys. He has the 12 steps. I did group some of his steps together and included a couple other things, but that's kind of where I got the idea. I think this paper was really good. And even though it's a few years old at this point, I think it's worth going back and looking at for folks because he does a great job with these kind of clinical commentary papers. So I think it's worth looking at for people and checking out.
I'm excited to see the 12 steps.
Okay, so key number one, we talked about this in a previous episode, and I think it's worth going back and just checking that out. But I think the first key is successful pre-op rehab. If you have the time with the patient, if you have the ability to train them pre-op, we know it leads to better outcomes post-op. And some of the studies that we talked about last episode. So we want to achieve a quiet knee. That's kind of the first big thing physically. We want to get that. So what does that mean? You see that in the research a lot is first we want to reduce swelling to a 0 or trace. And that's kind of what I was talking about on the previous episode, where if we're doing the sweep test, which is a good test to look at swelling, 0 means there's nothing going on. We're not seeing anything. With trace, you do your little sweep and then you provide a down sweep on the lateral knee. And then back on the medial side, you may see just a tiny bit of swelling. We kind of want to get our patients to that point. We want to reduce pain as much as possible so they can train before surgery. We want to get full range of motion compared to the contralateral side. We want to try to normalize gait. And we want to test these people. We want to know before surgery, what is their strength? We know they're going to lose strength on both the good side and the bad side before surgery. So we want to know what their baseline is. And ideally, we want to have symmetrical quad strength, or at least greater than or equal to 80% on the painful side versus the non-painful side. So definitely want to look at those things. And then you can go back and listen to the previous episode about all the other things we're including in pre-op. We also want to consider psychological preparedness. So we explain to the patient what the post-op kind of rehab looks like. What are your general time-based, criteria-based progressions? Like, generally folks will start some light plyometric training maybe at month 3. They might return to run around month 4. They might return to sport somewhere between months 9 and months 12. We want to make sure the person understands this, and they know that just because they have a friend that got back at 6 months, that's not the norm. Understanding this is a huge thing. I think these patients, they don't get to spend a ton of time with their surgeon. So when they come in to see us before PT, we can really lay out the roadmap for them of what this is going to look like. This is a big barrier to their life. It's going to change the way they do things. And we want to make sure we give them good information before. So none of this is a surprise. They can kind of plan out the next 9 to 12 months of their life and have some idea of what's coming. And I think they find that reassuring, and they really appreciate when we take time to talk about those things. So I think that's a big part of this first key.
Yeah. Yeah, I totally agree with you. I think setting patient expectations is really important. And I think the ones that are particularly important are talking about, let's say, pain, swelling, and just knowing that it goes up and down a lot. One of the biggest things I see is that patients have some extra pain. They're like, oh, retore my ACL. And you're like, probably not. Obviously we can go back to the doctor if we're ever concerned about these things, but there's the likelihood that it just goes up and down over the course of time. It's normal. It's natural. It happens. If it's bad enough, yes, we can go see the doctor, but this can be a part of it. If patients have that in the back of their mind, then they get a little bit less freaked out. I've never had an ACL reconstruction, but obviously we've both been injured several times. And the psychological warfare that your body kind of plays on you as you progress along is terrible, right? When you feel more pain, you're like, oh God, what's going on? Why is this hurting? Did I hurt something else? Like, oh, I got to stop everything. Oh man, I'm not gonna be able to get returned back to my, it's ridiculous. So if you set these expectations from the onset and just stick with it and just let patients know, like, yep, that's normal. It's okay. It's all good. I think that actually helps out quite a bit. So good point there. And I'm going to back that up and say that's definitely real.
Okay. So key number 2, your patient has already had surgery. Kind of the first big thing we have to do is reduce the post-op pain and inflammation. We want to try to expedite this process as much as possible so we can start doing the things that we know we need to do to get back to sport, which is ultimately the end goal. So it's well established that pain and swelling reduce quadriceps inhibition, they increase quadriceps inhibition. They reduce quadriceps activation. So we know that. How do we work on pain and how do we work on swelling? So for pain, I think it's okay to tell this person to ice. I know we as a profession, we're kind of getting away from icing a little bit. I think it makes a lot of sense in certain populations. And we'll talk about the relevance and importance of icing for arthrogenic muscle inhibition a little bit later. But icing post-operatively can be very helpful for pain. So I know a lot of the surgeons in our area, some of the local surgeons will send patients home with an ice machine or recommend that they rent an ice machine. And I do think there's utility in that, and patients will report they feel great using their ice machines at home. So, don't be afraid to ice these folks. I think it's important, and they feel better. Electric stim, TENS, something like that, it might help pain as well. Maybe something to consider. We know passive range of motion is helpful for pain. So some of these folks come in, they've been at home, locked in extension for a few days after surgery, and they come in and they're stiff. Their leg feels pretty crappy. But almost universally, once you start working on their knee a little bit, they tend to feel a lot better, especially if they trust you and they're not fighting you with the passive range of motion. So that can be helpful for pain. For swelling, we know ice can be helpful. Compression might be helpful. So we tend to recommend that after folks are out of their post-op dressing, their incisions are out, or their incisions are healing and stitches are out, maybe get a compression sleeve. Sometimes people feel better with that. They feel like that compression just feels good and helps their pain a little bit. It might play a role in helping swelling as well. I think an important thing to keep in mind is that obviously we all want the person to get off their crutches. We want them to get out of their brace. How long this happens depends on exactly what happened in surgery. If it's just an ACL reconstruction, you tend to get out of your crutches pretty quickly. If it's a allograft, they're probably on crutches a little bit longer. And if there's like a concomitant meniscal injury and they repair it, they're on crutches for a little bit longer. So you definitely want to know what happened in the surgery. But you don't want to rush this either. Even if the timeline says they can come out of their crutches and you can unlock their brace, you want to wait until they're doing better, their pain's better, they're moving better. If we rush this, we kind of create a bad habit of doing things too quickly. Their knee could get irritated and you could prolong this process. And I think about it as the longer someone's in pain and swollen, the harder it is to get their quad kind of firing again. So definitely something important to tackle early on is reducing pain and inflammation.
Yeah. I'm going to go ahead and just steal your thunder here on purpose. I know, Kevin's going to cover some of this stuff, but just notes on AMI and gait training. I recently made videos. I'll put a link in the show notes, but I go through like all different ways of going through AMI. It's basically things like 10, MES, biofeedback, so on and so forth. So you can see exactly how we like to do that at Champion, both Kevin and I. Also some gait retraining. So I took some videos of this. Usually I try to make follow-up videos to these long form video podcasts. They're just supplements because we're not going to go through all of our gait training drills with you. Like Kevin's not going to stand up and walk in his room and show all the drills, but I'll do that in another video so you guys can check that out. And the other piece I will say is that patients freaking love ice and they love stim. It makes them feel really good. So I can't tell you, I know that we're like Kevin said, we're kind of moving away from these pain modalities. And I agree with that. I don't think that you should be doing a whole lot of ice and TENS as like a major form of treatment, but early on from a rehab perspective, this can give folks a tremendous amount of relief. And it also reduces that AMI. So there's definitely evidence-based reasons to use these, and patients will tell you like, man, that ice machine saved my life. I love getting on that. I felt amazing, right? So if you're taking that away from patients, you're potentially taking away something that gives them a lot of relief, makes them feel really good, does influence your long-term outcome. Maybe not, right? But the other part is like, it makes them feel amazing in the beginning. Why not recommend that,
Totally. Key number 3 here, restore full range of motion. So you're improving pain, you're improving swelling, try to get motion back. And one of the studies that we have linked in the show notes is showing really good, I believe it's that first paper with Lynn Steiner-Mackler. She has some kind of normative timelines of when people are hitting certain things and regaining full knee extension, regaining full knee flexion. And not every patient is going to fall within those guidelines, but we want to kind of reference that and see if we can kind of match our patient to that. So limited extension is considered the most common complication after ACL reconstruction. So this is something we have to educate our patients about, the importance of working on this. Patients will tend to self-select a little bit of knee flexion because it just feels better. So when they're sitting, hanging out at home, if they pop off their brace, they're going to sit with their knee bent to about 20, 25, 30 degrees. It just feels good. It doesn't feel good to keep it straight. But the problem is the longer you do that, the more often you do that, the worse it feels to move into extension. So kind of hammering this early and often is important. So what things can we do to work on knee extension? From a clinician standpoint, soft tissue to kind of the posterior structures, the hamstring and the calf could be helpful. Low, long duration stretching, I think, is very, very helpful. So in our area, a lot of patients will have a CPM machine that helps them work on flexion after surgery. That depends on the doc and if they prescribe that or not. So it is important that they understand when they're not working on their flexion, they should be sitting with their leg propped up, nothing behind their knee. And if you can accumulate, 4 or 5 bouts of 12 to 15 minutes, something close to an hour per day, it can be really helpful for regaining knee extension. The other thing we'll have patients work on is that when they're in that position, just do some quad sets or stand up and do some terminal knee extensions and just actively get yourself into extension as well. And I think one thing that, we've referenced our coworker Lenny a bunch. One thing he does really well with his patients is when they come into the clinic, before he does anything else, he checks their range of motion, particularly their extension. And that helps him stay on top of it. And it helps his patients understand the importance of it, because if it's the first thing they see the therapist doing, they understand that, hey, this is important. We're talking about extension often. We're asking how they're doing at home, work on their extension. So just make this a priority. You want to get this back quickly. And generally, it can be a little different person to person. We do see some very hypermobile folks with 10 plus degrees of hyperextension. Maybe we don't want all of that back right away, but we do want to get, 5, 6, 7 degrees back pretty quickly. For someone who has more a normal amount of hyperextension, about, say 5 degrees, I think we could get that back in the first month. And that's really what we should be aiming for, is getting back extension within the first month. I think that's what we see in the research. Flexion, conversely, it tends to come back on its own. We don't have to go crazy with flexion. And people tend to feel a little more cranky if you're just pushing their knee into a painful amount of flexion. So don't freak out if it's not coming back. Just monitor it. It will tend to come back. We usually want to shoot for at least 90 degrees by the end of the first week, and then about 10 degrees thereafter. So maybe somewhere about that, 6 to 8 week mark where we're hoping to have full knee flexion at that point. This can vary a little bit person to person. I think it depends on how much scar tissue they lay down or how much swelling they still have in their knee. But we do expect to have back full flexion, I would say, by the end of month 2. So as a general guideline, extension in the first month, flexion by the end of the second month. And there's tons of ways to work on flexion with the patient at home. And I get a little more aggressive with this after the first few weeks when they're not having so much pain at end range flexion. And my favorite exercise is the Dan Pope quad rock back. That's trademarked. That's a great exercise. So I know that I've seen you do this with some of your patients, and I actually think this is really, really helpful, and patients like it. If they're not having pain kneeling on their knee, they get into a quadruped position and they just do a quad rock back. And that's a really good way where they're using some gravity eliminated body weight to work on bending their knee. And patients like it. I think it feels good. They feel like they're in control of how far they're pushing. So that's a good one. One that I didn't include here is just having someone put their foot up on a chair or something and lunging into it. Those ways tend to work. I think I like that better than putting a strap around the leg and just pulling in. But that works as well. That's another way. So there are active ways to work on this. And I think you can start adding that into someone's program. Generally, I think for the quadruped one, they need pain to go away with kneeling. So maybe once their incisions are closed and they feel a little better kneeling on that knee, but it can be really helpful. And then the final thing I think important from a range of motion standpoint is just working on patellar mobility. So just keep an eye on this. I think if someone's going through normal range of motion in PT, I don't tend to see it get scarred down too much. I kind of feel like this is something that works itself out, but you do want to just touch base on that and make sure that you're moving the patella. Someone can work on that at home. Maybe they're doing some mobilization with movement with a quad set and just getting the patella to glide up and down. But I tend not to spend too much time on that. I do feel like that comes back a lot on its own, but something to keep tabs on.
I like that stuff, Kevin. Good synopsis. Couple things. I am filming a video. We go over all of our favorite range of motion exercises and manual therapies too. Soft tissue work, patellar mob, so on and so forth. So you can see the infamous quadruped rock back that I like to use. One of the things I will say about range of motion is that, and you had mentioned this, but Lenny just measures knees so much, right? And two things, like you want to make sure that you're making progress, and you want to obviously make sure you're not making progress, but that information is going to dictate how much mobility you need to. Like I don't give my patients low load, long duration stretching from the outset, but if they're stiff into extension, we're having a hard time getting that back, then yeah, I start giving some more of that. It also dictates the frequency of exercises I give, right? And then I want to say that I think it's Lenny's patient, but I think you've worked with him a little bit today or in the past couple weeks as well. He's super stiff into flexion. We're spending a ton of time working on gaining flexion range of motion to the point where that makes up almost the majority of his whole session early on. So if you're having a hard time with a given patient for a specific, flexion or extension, just you can spend more time on it. But you got to measure and kind of understand some expectations. If things are not going well whatsoever, you can just get the doctor back on board. Maybe you are dealing with something like a cyclops lesion or something that you can't change, right, with your hands or stretching, whatever it is. The last piece is that kneeling can be tough for these patients, especially if you have a bone, patellar tendon bone. So if you are doing like a quad rock back, just make sure it's a nice soft surface. You can even offload the patellar tendon a little bit just by having a pad. Maybe the pad ends right at like the tibial tuberosity, right? So their kind of knee is hanging off, and they can do some sit backs without putting stress on that area. So just make sure you're not hurting your patients. I don't think that patients are, but those are a few ideas you can use to at least start with your flexing from a kneeling perspective. I feel like a lot of folks don't get back to kneeling. And they're just like, it's not part of the rehab. And I see this in like post-op knee replacements as well. It's almost like kneeling is this forgotten activity that you don't progress towards. So if you do some of these quadruped rock backs, at least you're addressing some of the kneeling that patients feel like they can't do. And, complete anecdote, I just feel that if you put some effort into kneeling with these patients, it may actually improve better than what some of the outcomes maybe show in our literature, mainly kneeling being problematic in bone patellar bone ACL reconstruction patients. I don't really know. Again, it's an anecdote, but that's a thought. Maybe that is real.
Key number 4, individualize and adjust the rehab program based on the status of the knee. So, I think this kind of goes without saying, but kind of one thing Dan had just said that this would fall in this category is, the dosage of mobility that someone's going to work on at home is totally dictated by how they're doing. So just, it's not a one size fits all. Kind of consider how they're doing and how much you need to prescribe a certain thing. But we should consider and change the rehab program based on different graft types, right? So something to keep in mind is that almost all graft types, they're often stronger than the native ligament. I know Dan talked about this in one of our previous episodes. So, that's a cool, important thing to keep in mind. The bone patellar tendon bone plugs tend to set in about 8 weeks. So something to consider for those folks. And then more anterior knee pain is expected. And that's compared to our allografts or our repairs. So, or a hamstring graft, you're going to get more anterior knee pain with the bone patellar tendon bone. And I would say this holds true throughout a lot of the rehab. Now, how much, I think it depends on maybe the surgical technique and how much the individual person kind of scars down. But they do get some anterior knee pain. So you almost feel like as you're rehabbing, you're dealing with a patellar tendinopathy. That's something that you're treating it almost like that. With the hamstring, the tendon to bone healing takes about 12 weeks. So it could take a little bit longer to incorporate than the patellar tendon. With this, we often see surgeons asking us to delay isolated hamstring strengthening. So I'll say this is definitely true in the hamstring grafts I see is that closed chain or isometric hamstring strengthening, we might be able to start a little bit earlier, but open chain strengthening of the hamstring is often delayed to about 8 weeks. And that period of time is going to affect how much I feel like I have to dose hamstring strength after that. I feel like I really have to bump it up because now we're about 8 weeks behind plus pre-op, whatever we were doing. And the hamstring gets weak. And we know that there are long-term delays in symmetry with hamstring grafts in hamstring strength. So something to keep in mind there. Quad tendon, we also are seeing some anterior knee pain. I think Dan reported on a previous episode. This is less than the patellar tendon. We're seeing a little less anterior knee pain with the quad, but it's something to keep in mind. And anecdotally, that's something we're seeing. And I know you had talked about that challenging case that we have at work right now with the knee flexion. And, you know, he does have a quad tendon graft. So I'd say anecdotally, we're seeing a little more challenge to knee flexion range of motion in that group, which makes sense. You know, when you flex the knee, the quad is lengthening and you might get a little bit of pain with that. We also are seeing that it takes longer for these folks to get quad strength back. So that's a consideration. And you're going to want to individualize your loading program for those folks. So they're doing the appropriate volume and intensity to get that strength back over the course of rehab. Allografts, we have to consider that it's longer to incorporate and mature. We might see some more laxity, and we know that there are higher re-tear rates. So that's going to delay return to sport. Most surgeons that I see their patients recommend allografts wait at least a year to get back to pivoting type sports. So that's a consideration, and that's going to change your rehab. Perhaps you're a little more conservative with your plyometric programming and your agilities and change of direction type exercises with that group. And then just other things we want to consider is, did they have a meniscus injury? Was the meniscus debrided or was it repaired? Because that's going to change how we progress and how fast we can progress. Often overlooked, but important, is, did they have a bone bruise? I think almost all ACLs tend to have a bone bruise. It's just how severe is that bone bruise, because that impacts how they feel after. You know, you may be scratching your head saying, why is this person so swollen and painful? If you didn't get the chance to see him pre-op, maybe they have a big bone bruise and that's playing a role. So that's going to dictate how you're programming a little bit. Was there an articular cartilage injury or other ligament injury? So the more information you get, the better, and you can individualize each program based on these findings. So try to get all that if you can.
All right, good stuff there, Kevin. Yeah, I agree with you for sure. One thing I will say is that was a study, I just brought it up when you're kind of talking there, 2023, called the Evaluation of Muscle Strength and Graft Laxity with Early Open Kinetic Chain Exercise After ACL Reconstruction for Relly et al. And I think one of the big, debates we've had over the course of time is that, is open kinetic chain exercise safe? And the big consideration is basically open chain knee extension, just because we know that's going to shear the tibia, put some strain in the ACL. Is that safe? In this study, it was on ACL hamstring autograft patients, and they incorporated open kinetic chain knee extension 4 weeks, and then knee flexion at 4 weeks. So this was in hamstring autografts at 4 weeks, and long-term outcomes were better in the group that used open kinetic chain, and there was no like adverse effects. You know what I mean? So if the surgeon allows it, I just don't want physical therapists to feel like they can't do hamstring exercise until week 8. You probably just want to proceed with caution, just because we know that can be pretty stressful on the hamstring. Obviously, pull back if it doesn't feel good. But yeah, it should probably be safe for the majority of folks to start the open chain flexion at 4 weeks for the hamstring autograft specifically. So, yeah,
that's awesome. Definitely check with the surgeon. But if no preference, then, that's a good study. Do it up.
Do it up, man.
Key number 5, we want to improve volitional quadriceps control. This ties into talking about reducing pain and inflammation, but we know the longer that lasts, it's hard to contract your quad. There's this phenomenon that everyone's talking about. We hear very often AMI, or arthrogenic muscle inhibition. And this is the idea that quad failure is not simply related to atrophy, but it's also related to neural inhibition. So there's something else going on. It's not just the muscle. There's something going on with the nervous system. What we see helpful for this is that modalities which target different neural pathways to reduce quad inhibition, those are the things that have been studied. And they're mostly looking at motor recruitment via this reflex called the H reflex, and max voluntary contraction as outcomes. So when they do different interventions, are these things improving? There's a whole lot to this, and there's some good studies out there. And I know Dan had said he's going to do some videos showing how to work on these things. But these are
now.
Can't wait. These are
Watch
things
the rest of this video and then immediately watch those.
That's right. just stay on fitness pain-free all day. But these are things we're seeing in the research and something we have to pay attention to, and we want to improve this quad control. So special consideration, I thought this was pretty cool. So the two most proven ways to reduce AMI that I've seen in the research I was looking at is exercise, which I never thought of as a way to reduce arthrogenic muscle inhibition, but it's a very reliable way to do that. And we're already doing that in PT, which is awesome. And the other thing is cryotherapy. That's something that we know the research is showing with very strong evidence that it's worth doing. So all types of exercise seems to reduce AMI, open chain, closed chain, you could do anything. Okay. One of the things that was interesting is that hamstring exercises particularly seem to be helpful at reducing AMI. And the theory is that for some of these folks with quad inhibition is that there's a strong co-contraction of the hamstring and the quad, and that's not allowing the quad to fire properly. So if you do some exercises that over fatigue the hamstring, it's improving quad control and volitional quad control. So, if you have someone who's really struggling, try to smoke their hamstring and see if their quad's moving a little bit better after that. And that is pretty interesting. And this study found that to be a reliable way. The other thing is icing. So one summary statement from the study that I included here is that all included studies showed an improvement in quad strength and or the H reflex through the use of cryotherapy. And what I tended to see for a time required to do this is about 20 minutes. So, an idea that I've had some of my patients do that if they have ice at home on their drive to physical therapy, they'll ice their knee. And then when they come in, they've already iced for that, say they have a 20-minute commute. That's awesome. Now they've gotten that out of the way and we can kind of get right to work in PT. The other thing is you could recommend they do this at home before they do their exercises. There's a window of time where their quad inhibition is decreased, and doing it pre-op or before exercises, pre-exercise can be really helpful. So definitely something I think we should start doing. There's like almost no barrier to entry with that, and it could be pretty helpful. So these authors looked at a ton of different things to reduce AMI, and the modalities which they deemed they can't recommend at this time due to either lack of evidence or lack of high quality evidence. They said TENS and NMES, they provide a small benefit, but at this point it's clinically insignificant. So they can't recommend that we prioritize those things. Vibration therapy and ultrasound, they deem to be questionable at best at this time. So, we could be on the lookout for more evidence for that. But the big things that they said we should be doing, no-brainers, are exercise and cryotherapy. So I'd say be sure to include those. But if you want to work on some of the other things, if you have the time, perhaps it's worth trying. But their recommendation is stay away from other things, focus on exercise and cryotherapy.
Yeah, for sure. I did do basically another video showing a lot of these things. So cryotherapy, like TENS, how we like to set up things like NMES, biofeedback, vibrations with a power plate, which unless you have one of those in your clinic, you might not be able to do. Blood flow restriction training is kind of another one, although that's not necessarily just AMI. But yeah, exercise seems to be the big one. But if you guys want to see how we set up some of these modalities or cryotherapy, all those other strategies, and link in the show notes.
Key number 6, during the rehab process, we want to progressively load, and especially the quad. The quad is kind of the key here. Athletes who return to sport with weaker quads have a higher risk of re-tearing and worse knee function 1 year later. So you see a lot of high quality studies showing this, that getting your quad strength to at least 90% of the unoperative side is so important for reducing risk of re-tear. Open kinetic chain knee extension, as Dan was alluding to, is safe. It's a safe and effective way to strengthen the quads. And we can begin this as soon as possible. So that study by Lynn Snyder-Mackler, she really spent a good portion of the article talking about this and just linking some common activities with their peak strain on the ACL so we can understand why this is safe. So open kinetic chain knee extension, puts about 4 to 5% peak strain on the ACL. That's very similar to squatting, which we all feel pretty comfortable doing early on after surgery. And that's a lot less than the mid stance or the late swing phase of gait, which puts 13% peak strain through the ACL. So if we're okay with our patients walking after surgery 2 weeks out, or 10 days out, we should be okay with doing open kinetic chain knee extension as well. And then something that I always think is interesting is in surgery, after you're on the operating table, they've just reconstructed your ACL, surgeons will do a Lachman test. They'll do an anterior drawer test and a pivot shift test, and they'll stress your ACL on the table. And that puts about 4% peak strain through the ACL. So if we're okay doing these tests to test for laxity, we should be okay doing open kinetic chain knee extension. And we know that doing that will get your quad strength back earlier. And it's a very effective way to get back your quad strength. So don't be afraid of doing that. I would say I'm at the point now where I'm pretty much doing that as soon as the patient can tolerate it, oftentimes within the first 2 to 4 weeks. So, feel free to start working on that. I don't think it's a problem. And most of the surgeons we work with don't think it's a problem either. If your surgeon does have particular guidelines against this, I think you got to proceed with caution, but don't be afraid to. It seems like from a force standpoint, it's perfectly safe.
Yeah, it's pretty funny. I guess a few things about the open chain argument, walking's more strain than just doing an open chain knee extension. So if you're comfortable with your patient walking and they're taking lots and lots of steps throughout the course of the day, might as well do knee extensions, right? The other thing I like to think about is that your ACL is like at its strongest point right after surgery. So right after that surgery, the ACL is probably stronger than it is somewhere between 8 and 10 weeks, whatever it is. So if you're delaying until 8 weeks, which we have research to show it's safe at that point, it's like you're starting maybe at the weakest point there, right? Just kind of interesting. And the last one that I always makes me laugh is like when you do a straight leg raise with a patient after that ACL reconstruction, what's the first thing that happens? The knee bends. It's like you're at almost terminal knee extension right there. So like a straight leg raise, which everyone prescribes, like, why is that okay? Like that's okay, even though the knee is like really close or at terminal knee extension with that quad leg. But like an open chain knee extension, well, be careful when you get towards terminal knee. It's like, well, the exercise right before, we were there the entire time. Why is that one safe? So it's just kind of interesting. It does seem like a lot of folks are being more and more vocal that maybe we should be okay with open chain. I know Kevin Wilk actually is a little less okay with open kinetic chain knee extensions early on with rehab. And to be honest, like if you can do kind of partial range early on the first 4 weeks, like we see decent results potentially staying away from it early on too. So if the surgeon hates it, it's not like it's the end of the world. But if you are able to do it early on, probably better to do it, and if they're having a lot of trouble, you can always back off, use more BFR, whatever it is, reduce those loads, so on and so forth. You may be getting to this, but I know Delaware has a good protocol and they show you how they do open kinetic chain early on, which may be useful for folks to see if you're not going to mention already in the future of this podcast, Kevin.
Yeah, they have a great protocol in general. So I think it's worth checking out kind of based on all this research. But key number 7 here is don't neglect other types of training. So obviously strengthening is so important. We have to load the quad. We have to load the hamstring. Strength is a huge focus, but we can't just strengthen. We have to do other things as well. Perturbation training has been shown to reduce knee stiffness with walking and more effectively normalizes gait than strengthening alone. So a good indication for adding that. Training this early, pre-op and post-op can have positive implications 6 months post-op for gait quality. So keep that in mind. Another hot one right now that you see a lot is neurocognitive training. And this is the general idea that sports are more complex than a single instruction task that we often do in rehab. So when you're having somebody do balance, that doesn't do a great job replicating the demands of sport. We know that there's a lot going on a field. You're paying attention to the defender. You're paying attention to the net or the basket or something, right? There's the ball. There's a lot going on. And we want to try to start working on that in rehab because that's going to be a big challenge that these people face. Research has shown that deficits or delays in sensory, or attentional processing may contribute to inability to correct errors in a complex coordination task, which leads to higher rates of re-injury. So if you have a deficit with this, it could lead to higher rate of re-injury. And then they also have shown that athletes with lower baseline levels of neurocognitive performance demonstrate worse landing mechanics than those with better baselines of neurocognitive performance. So, exactly by what mechanism this is happening, I think we're still learning, but we know that this is an important indicator of someone's risk of re-tear or how they're going to perform when they get back on the field as well. So we want to start implementing this in physical therapy. So we could use these findings to implement tasks that improve processing speed, dual task training, and multitask training. And there are so many ways to start incorporating this. I think even early on, there was a recent paper that I think Kevin Wilk actually published that was in IJSPT about neurocognitive training for ACL, and a lot of cool examples of how to progress exercises with that. I believe that's in our references for this one, so that's worth checking out. And they did a 2-part on that. So there's part 1 and then part 2 is coming out. But a lot of that is just, even early on, someone's doing something as basic as straight leg raises. As they're doing that, you can give them basic math problems to solve, or they only lift their leg when you say an odd number or something like that. This is infinitely creative. You could get infinitely creative with this. And I know there are good people online putting out stuff like this. And I'm sure Dan will be putting out a lot of stuff on neurocognitive training. But we're seeing more and more of this, and don't neglect this. Don't think we can only strengthen the quads and have success. We have to incorporate all these other things as well.
Yeah. Good stuff, Kevin. So a couple things. So, hey, I'm actually planning on making a video using that study with Kevin Wilk. They kind of have like a stage 1, stage 2. What was interesting about that study, just kind of reading over it briefly, is that they recommend a lot of neurocog early in rehab. And I tend to do more later in rehab. You know what I mean? A few thoughts. I think I'm going to put out a video so you can see some of the stuff that we like to use. I'm kind of guilty. I should probably use it more than I typically do. Right. One thing that I hope people aren't doing, I don't think folks are doing this, but neurocog is not just advanced rehab, right? I don't want folks to think that like, okay, to get to the advanced stages of rehab, now I add blaze pods and this is advanced. You still need to work on strength. You still need to work on power. So we want to make sure we restore the ability to sprint, for example, right? And do agility drills well first. And if that looks good, then yeah, go ahead and throw some blaze pods or whatever in the mix. But if your main goal behind your exercise is either building strength or building power, we still make sure we check those boxes. It's just the neurocog is an additional element that you put in. At least in my mind, it goes towards the advanced stages of rehab, just because when you're trying to build, let's say, strength, you probably need to focus on the set of the exercise you're doing over hitting a blaze pod while you're doing sets of 10 or doing math, because that's going to probably make you a little less strong, which is the opposite of what we want to try to accomplish. So neurocog is good. Just don't go overboard. Make sure you're working on all those other important sport qualities that the athlete needs to.
It's such a good point, right? Like we know the principles of training, right? You have to maybe single focus on a task first and then start doing some other things. But there are probably ways we can sneak it in early as well. But you're right.
I agree. It's like some people, like you've seen it in PT, like we're getting more advanced. All right, we go from squatting to Bozu squatting. Like, whoa, you're going the wrong direction here. You know what I mean? Then you're doing like a squat with a press overhead, and that's supposed to be advanced. It's like, well, you're limiting your legs by working the shoulder. Like that's not advanced necessarily. So it just makes sure that people kind of understand that. I mean, just the fact that you incorporate neurocog into your PT probably means that you're ahead of the curve. You know what I mean? From a physical therapy standpoint, but you just want to make sure that, you get a lot of new grads probably that are excited about this, and hopefully they're not like overdoing it, whatever. So
last thing I'll say on it is, we have an epidemic of returning to sport potentially without hitting the criteria of strengthening. So we have to do those basic things really well first. If your person's strong enough, but they need to get the fine details of neurocognitive training in their rehab, that's awesome. But like you said, you can't prioritize this over other things when you still have a 70% symmetry, right? That has to get better. So yeah, all good stuff. Key number 8, progressed by tissue healing timelines and objective outcome measures. So there's a combination of things, right? We can't just say, I think some surgeons I see go based on just time, and they tell the patient that you can start running. It's 4 months. You had your 4-month follow-up. Here's a return to run protocol. Or, you're at month 9, start returning to sport. Or even if you're at month 6, start returning to sport. You hear kind of arbitrary recommendations based on time, and we have to consider criteria. But at the same time, if someone's smashing criteria early on, we have to consider time. We can't just say you're hitting your return to sport marks at 7 months, return to sport, because we have good studies showing that for every month you delay return to sport up to month 9, you reduce your risk by about 50% of re-tearing. So both are important. We have to consider both. It's important to educate your patient about both. So just some basic examples here, but the principle is to consider both. Something like plyometrics, I think you'll see in the research, a timeline-based recommendation is about 3 months. For criteria, we want to say about 70% or greater limb symmetry index. So take a little bit of both and see if you can kind of match those. That's what I use with my patients as a goal. By 3 months, can we be around 70% LSI? Can we be about 3 months out? And now we'll start our plyometric training. Similarly, for return to running, did they tolerate a good plyometric program in month 3 to month 4? Did the LSI improve? Are we close to 80%? Are they about 4 months out? Let's start running. Same thing with return to sport, right? I kind of will give a summary of recommendations, but I'm hoping we're waiting till at least month 9, hopefully a little bit longer, but at least month 9. That's some of our time-based criteria. But then when are they hitting these criteria-based progressions of LSI greater than or equal to 90%, greater than or equal to 90% for high performance testing, which we'll talk about. But blending these two is important. And it's important for the patient to know that you're going off both. So they don't think, hey, it's 4 months. Why am I not running yet? Well, you've already talked about this with the patient. You're not running yet because we only have 65% quad symmetry. And we know that if we start running, you're probably going to get swollen and it's going to be kind of painful. So let's just be smart about this and think about both things in our decision making.
Yeah, for sure. I like that, Kevin. I think it's super important. I like the idea of trying to say, we don't start plyos until we see this number, right? And then we can start progressing to more running when we get to this number. And then I've even seen, let's say, 90% for when you start doing, let's say, drills in practice, and 100% when you actually fully return to sport. So I've seen it kind of every percentage up by 10% is when you can incorporate more and more and more, which makes sense to me. I kind of like that idea. And to your earlier point, I had just a story, and we talked about the same athlete in the last podcast episode, but it was in an athlete who had a cadaver graft years ago, and he was trying to return back to hockey, and his doctor was okay returning at 5 months. And what I found with him, and I've seen with a lot of others, is like they may crush every single test. So his limb symmetry index was great. All his hop tests looked beautiful. Like he looked ready to go. And he went back and he retore. And he did that twice. And both times during that rehab, he looked amazing, right? So you'll see that. But I think on the flip side, you see a lot of athletes that don't hit these numbers, the 9-month mark. I think we were talking about that Bear study in the last podcast. Essentially, it was like 70-75% of folks had adequate symmetry to return at the 1-year mark, and they were closer to the 2-year mark when they actually hit those numbers. So I think what happens as physical therapists, you get frustrated pretty frequently, and you're just crossing your fingers that the handheld dynamometer test, whatever, look good, and oftentimes they don't. And sometimes you have to have a tough conversation. I think you had the same thing with one of your patients recently, and you may actually disagree with what the surgeon has to say. You're at 9 months or 6 months, whatever it is, and that limb symmetry index doesn't look good. And you're telling your patient, like, I know you're 9 months and the doctor says it's okay to return at this point, but you're still at a higher risk, and that stinks, right? Because that may delay all the plans that the athlete has. But unfortunately, I think it happens a lot. Like, I feel like I have this conversation way more often than I like to. And I have to kind of say to the patient, like, yeah, you're at an increased risk, and at this point, I let the patient make their own decision. Like, if they really, really want to return back to sport, like, I'm okay with it. Just that your risk is probably higher than someone who's, at 90+%, right? So I don't know if you have any thoughts on that, Kevin.
Yeah, definitely something we deal with. And the case I have right now is actually, so she's passed the doctor's return to sport tests, which I don't know how well implemented they were because I've done the same tests and she has not passed them. But she's also 6 months, a little over 6 months out, and she was told by the surgeon before surgery that he lets his athletes get back at 6 months. So this is where I have had a lot of conversation with her and with her family, just trying to give them the evidence that we're talking about today and some of the best research out there showing that delaying return to sport to at least 9 months reduces risk of re-tear. And then it's, they need to weigh what the surgeon tells them versus the best available evidence I can give them and, my clinical experience and my rationale. So that's challenging. That's definitely a hard thing that I think it's not uncommon that, especially in ACL, for whatever reason, there are definitely surgeons out there that, whether they think their techniques are better than what you see in the research, or they're just so busy that they're unaware of the research. It's hard to know why they say these things sometimes, but I think we've talked about this in this series of podcasts, is that at least ACL is, the good thing is there's so much evidence out there that, we're not completely guessing. We have good evidence to show that if we wait till 9+ months and if we hit these return to sport criteria, we're reducing our risk of re-tearing or tearing the other side as much as possible. And again, like you said, I'll let the patient make the decision and the family make the decision, but we have to educate them on these things. And it's challenging because you feel like the bad guy and people get upset, but you're trying your best and you're just trying to give them the right information. So
Yeah, I can see why surgeons are pressured to return back at 6 months because the patient obviously wants to get back and they're getting surgery to get back. And if the surgeon says, "Oh, I let you go at 6 months," I find that my patients do okay with that. That's what the patient wants to hear. No one wants to hear it takes 9 months to a year to get back to your sport. That sounds horrible. So I can see why a surgeon might say that. Again, like I don't have all the information as to why they're making that decision, but as physical therapists, we know that's probably going to increase your risk. So I just want to make sure we educate the patients. Sometimes it creates turmoil, right? You might have a surgeon stop recommending patients to you for that reason. Just make sure you know that may happen. But at the end of the day, I think you're doing the right thing, right? I think it's your evidence-based. A little bit of feedback to the patient is probably more accurate than what the doctor is saying. So it is what it is. I think we deal with it more often than we like to as physical therapists.
All right. Key number 9 here is give consideration to psychological readiness. So we're so focused as physical therapists on the physical side, as we should be. That's our role. But understand that this is a huge psychological burden on the patient. And there's more and more research coming out that this stuff is very important to consider and that there are a lot of good referral sources out there. So a 2015 study showed that psychological traits such as self-confidence, optimism, and motivation are key factors to return to sport after ACL. And there's a lot of readiness kind of questionnaires we can give people. So utilization of the ACL RSI. And on this particular readiness index, athletes scoring greater than 60% after 6 months were highly likely to return to sport by 12 months. Conversely, athletes scoring less than 39% after 6 months were highly unlikely to return to sport by 12 months. So, I feel like athletes subconsciously or consciously have some indication of how confident they feel throughout this process, what their confidence is like, how optimistic they are, how motivated they are. That stuff matters. And we're seeing it pan out a little bit with some of these outcome measures. And in the area that we work, I think I'm seeing more and more of this for different types of surgeries. We do work with kids who I feel like are a little bit privileged. They have access to a lot of good things just being in the Boston area, and stuff like that. So sports psychologists are playing a huge role. I think I see a lot of high level athletes who are in high school and they're committed to play Division I college sports, and they're just a ball of stress all the time. And whether it's ACL or some other injury that they're recovering from, more and more often that they're getting good referrals to sports psychologists. So that's something to consider, is that this is outside of our scope and how we treat this. but it's our job to kind of pick up on this and make sure we're including some of these questionnaires for our athletes throughout the rehab process. So we know this is someone who we might need to refer out. But I almost feel like it's becoming a standard of care for these kids, is that if they go to a particular surgeon, they're saying, all right, here's our list of recommendations for physical therapy. You can go check out these places. Here's our list of recommendations for a psychologist or a sports psychologist. Go check these out as well. And I think that's awesome. That's fantastic, because it's not just fear of getting back to sport. It's a lot of times these kids are dealing with depression or anxiety around the fact that their friends are doing all these things they can't do. And these are huge considerations. So just be on the lookout for that, and give that some consideration, and try to establish relationships with a good sports psychologist in the area so they can start helping your patients out as well.
I like, Kevin. Good stuff. Couple things. I think that just to touch on the psychological readiness, there are a few questionnaires, and there's a lot of them out there. Maybe I'll include a couple in the show notes. Some papers will even recommend your return to play. So basically getting back to running, and then getting back to higher level plyometrics, and then getting back to, let's say, practice, but at a lower level doing drills, and then getting back to scrimmaging, and then getting back to like full playing, based on psychological readiness. So kind of like your limb symmetry index, you start at a certain point. As you get your limb symmetry index up, then you start doing more. You can do the same thing with psychological readiness, right? And to kind of touch on your early point about athletes being stressed out, we know they are. They have kind of unique demands. A lot of these folks are school demands, right? Stress with like finals. We have clear research, very interesting, that injuries go up around exam times. Stress levels go up around exam times, and the amount of stress that these athletes perceive directly correlates with the amount of injuries they have too. And one of the things I find interesting is that if you employ a stress management strategy for these athletes, it reduces injury risk. So just by addressing some of that mental strain that's going on for those athletes, it helps them out, right? So if our goal is to reduce injury risk as much as possible, which like we go crazy with that sometimes, right? We're hop testing, psychological readiness, range of motion, all this stuff. You might be ignoring that psychological side. And if you refer to a sports psychologist, and I would recommend a sports psychologist if you can, just because other psychologists may not have the expertise that the athlete needs. They're not used to doing that. You can actually reduce that injury risk. And that's just by trying to intervene from a psychological standpoint, which is really cool. So I just think this is really important. And those are a few easy things you can do, just like Kevin said. So
that's interesting. I wasn't aware of the injury risk, but that makes total sense. And the rates going up during times of finals, and it makes sense. They're more stressed. They're not sleeping as much. They get crazy, which makes sense. I remember horror memories.
Yeah. One of the things and this is one of the things I teach my course and stuff, is that I'm blanking on the name of the author. There's a couple like papers that I mention all the time, but one of the things that was really cool is that in the study, they used some more advanced technology to try to figure out people's stress levels, right? But they also use a really simple score of like a 0 to 3 of how stressed people felt. And they had called like a mood score on the scale of like 0 to 3. And if you're on the higher end of stress, that correlate with more injury. And if you're on the lower end, there's less injury. So a few things, you can use that number and just see if it's high all the time. Like that's probably not a good thing, right? You probably want to try to figure out how you can lower that. But the second piece is that it can potentially dictate what you do with your training. So if you have a high stress day, or you've been having a lot of stress with studying for finals or whatever else is going on, high levels of perceived stress, probably dictates what you do from a training perspective or game perspective as well. Because you might be going into a high risk environment, super stressed out, go play a sport at a high level, you might be more at risk, right? And I don't know if we know that when your stress levels are high, then you're more likely to get hurt. And if you don't exercise that day, you probably remove that risk, or if you like reduce the stress. But I don't have the research to show that's necessarily true. I just think that logically makes a lot of sense. And that's one of the things I advise to my clients and patients, because it's super simple and makes a ton of sense from a logical standpoint. You know what I
mean? Key number 10, implement return to sport testing. So when we're at the phase of should we get back, should we not get back, we're considering the timeline, tissue healing timelines, but we're also considering this criteria of returning to sport. kind of three factors to consider is biological healing, physical readiness, and psychological readiness. So in terms of biological healing, studies on neoligamentization, I think I said that all right, show that it takes upwards of 2 years for the ACL graft to fully mature. And I know Dan said on a previous episode, sometimes we see as high as like 4 years it can take. So how long does it take this thing to fully incorporate? Should we wait 2 years to return to sport? Maybe you could argue that from a biological standpoint, but I don't know if there's a big difference in re-tears between years 2 to years 4. I know most re-tears occur in the first 2 years. And the other thing is that, you know, coaches, athletes, they're just not going to stand for that. So at some point you say it's worth the risk, right? It's you're deciding that you reduce risk to a certain point, let's return to sport. But, you know, something to consider is it does take a long time for the graft to fully mature. The University of Delaware showed a 51% reduction in re-tear for every month return to sport is delayed up until 9 months. So that's a crazy huge statistic. You know, if you say the average return to sport rate, tear rate when returning to sport is something like 10 to 20%. And as you had said, depending on the sport and the study, you see really high, sometimes 25 plus, 30, 40%. Well, we can reduce that risk by 51% every month we wait up until 9 months. So after 9 months, it doesn't seem to be a huge reduction, but that's kind of where my recommendation, which we'll have here in a minute, is that I think we should wait at least 9 months. That's kind of, if we can, that's my recommendation from a timeline standpoint. And then we wait for the other criteria, but that's a huge statistic that I think is really important to keep in mind. And then other studies have shown a 7 times reduction in re-tear rates when waiting at least 9 months until return to sport. So there does seem to be something magical about that 9-month mark. We're reducing risk a pretty fair amount, and I think it's something we should all consider. For physical readiness, there are valid tests that we want to use. So quadriceps strength asymmetry, it's a major risk factor for re-tearing. One of the studies by the University of Delaware, I think it's titled a reduction of 51% for every, simple decision-making rules can reduce re-tear rate. It's in the study show notes. It's one of these references here on the slide. But what they showed is that of all the factors important for returning to sport, quad strength is the most important one. When you isolate all the other ones, if they're not hitting a quad symmetry of at least 90%, that's the biggest risk factor for potentially re-tearing or injuring the other side. So all of the return to sport tests are important, but that's probably the most important one right now, according to the research. And then just in terms of the gold standard, what could we best use to test? The best thing is isokinetic testing. That seems to be the one that we're comparing against. I've never used one. We don't have one at Champion, but a lot of surgeons' offices have one. And I think if you have access to one in your area, it's worth doing. The authors have said that handheld dynamometry with fixation, with external fixation, is a valid way to test quad strength. So definitely, if you have one of those, that's a little more affordable and more easy to get in the clinic. It's a valid way when compared to isokinetic testing. We don't have to feel bad using that. It has good evidence to support it. So you should use that if you can. They also have there is validity for 1 rep max testing on a knee extension machine. And there's validity from testing from 90 to 45 degrees and 90 to 0 degrees. So if all you have is a knee extension machine, you can also feel relatively comfortable using that. But that goes in order, I think, of the best evidence to the worst. So isokinetic testing would be 1, handheld dynamometer with external fixation would be 2, and then 1 rep max knee extension from 90 to 45 or 90 to 0 would both be acceptable. They caution against using a 1 rep max test for a leg press and single leg squatting. They kind of say that there's too many ways you can compensate, and those tests do not seem to be accurate compared to an isokinetic test. So one of these 3 methods is okay. Hop testing, there's a good study that showed a 75% lower risk of re-injury for patients who pass the hop test versus those who don't. And I know that this has been a little bit controversial because there was another study that came out showing that there's a higher risk of re-tearing if you do pass the tests. But there was a follow-up study showing that the methods used in that study weren't phenomenal. So I think it's interesting for people to go back and look at these, and they're all linked here as references in the title of this slide. But go back and look at them yourself, because I think it's important to see that a lot of the times we look at studies and we look at the headline and we take that information and run with it. But when other people go in and look at the methods, they see a lot of times they're combining things that shouldn't be combined, and they're combining cohorts and groups that shouldn't be combined. So, important to consider. But as far as I've come across in this review, hop testing is still a valid way and can predict lower risk of re-injury, and something we should be using. And I think the quality is important to consider as well. So not just what is the objective number showing us with these tests, but how do they look doing it? Is there a huge compensation strategy? Are they a little bit fear avoidant? Definitely important to consider. It's more than just the numbers, but we should be using these. I do think there will be probably some transition to force plate testing as we get more and more comfortable using force plates. Maybe that will overtake these, but I think for now, these are still pretty valid. So the standard 4 that you see often: a single leg hop for distance, a 6-meter timed hop test, a triple hop for distance, and the triple crossover hop for distance. So there are a lot of places you can look for the reliable way to implement those, but those are the 4 that we're using. And then in terms of psychological readiness, Dan had said, and definitely true, there's a lot of different outcome measures we could use for this. The ACL RSI, ACL Return to Sport After Injury, is a validated self-reporting tool. So kind of combining all these things is what we consider return to sport testing. Consider all 3 of the biological, physical, and psychological readiness.
I like it, Kevin. Just one thing to add is that I'm going to be doing a video on return to sport testing too, and I'll cover all the hop tests and also cover how we like to do the handheld dynamometry, isometric testing, measuring things like torque, so on and so forth, just so people have an understanding of how that kind of goes, and they can see it in action and not just like the theory of it as well. So
can't wait. Can't wait. Here's a little chart. Actually, do you want to expand this fully? Yeah, that's better. This is just from one of the articles there linked in the top, and it's summarizing the clinical recommendations for return to sport. So if they gave it an A, this is a SORT evidence rating is what it's called. If they give it an A, it's consistent, good quality, patient-oriented evidence. If they give it a B, it's inconsistent or limited quality, patient-oriented evidence. If they give it a C, it's a consensus statement, a disease-oriented evidence, usual practice, expert opinion, or it's from a case series. So A is the best quality, then B, then C. So initiating pre-op rehab to restore quiet knee and achieve pre-op milestones gets B quality. Initiating quadriceps strengthening in open kinetic chain immediately post-op and utilizing reliable objective testing to monitor progress also gets a B. Utilizing both biological and criterion-based timelines to inform decision-making gets an A. Delaying return to sport after ACL reconstruction with a minimum of 9 months and allografts a minimum of 12 months, and after successful completion of return to sport battery gets an A. So I think that's amazing. That is where I feel like we can really have confidence saying we should be waiting at least 9 months. Utilizing both biological and criterion-based timelines to inform decision-making gets an A. The ACL RSI is a valid tool to monitor psychological preparedness after ACL reconstruction gets a B. Return to competition should be stepwise after restoration of pre-injury conditioning gets a C. So that's kind of saying that we don't just return to sport. You pass your test, go play in the game. Let's make this a stepwise return where maybe we're going to practice without contact and half the practices during the week. And then we're going to all the practices without contact, and then we're adding in, contact. So a little bit of a progression there. And then a secondary prevention program should be performed 2 times per week throughout the athletic career. And that's also with a B level evidence. So I think some good things there to consider, kind of see where these recommendations are coming from and how strong and confident we feel in them. But again, to reiterate, I love the A for waiting at least 9 months after completing the return to sport test battery. So that's pretty good.
Yeah, those are really good recommendations. And just so people understand, like the grading of C doesn't necessarily mean that it's wrong. It just means we don't have research. It's just consensus or expert opinion.
Mhm.
I really like Kevin Wilk and his research because he talks very much about a stepwise progression back to sport. And I feel like that's very much lacking in most kind of rehab to return to sport protocols. And maybe research over the course of time will show that's not important. You can just run straight back. But in my mind, it makes no sense that it's not important, right? Despite it getting a grading of C. But really cool, what did get a grading of A, and that's probably something you really need to focus on as a physical therapist, making sure that you have nice criterion-based, stepwise progression back, hitting all those milestones seems to be really wise.
Mhm.
The last thing I will say is that we didn't talk much about this, but I'm going to be doing a video about prevention programs after you've had like ACL reconstruction or prior, and you're trying to reduce your risk of having ACL injury. So you can see some of what these studies show to be beneficial for folks because they seem to be pretty dang helpful. And this is a total anecdote, but it's just been like my mantra. I've gotten a lot of injuries over the course of time, and I feel like half of my training sometimes is trying to prevent recurrences. I think my like calf strain is one of those. Like I'm just constantly doing so much calf stuff, but and I will find if I slack off sometimes. I know you hear this all the time. When patients tell me this, I'm like, yeah. But folks will say like, yeah, I've been doing my back exercises for 10 years. I stopped doing it. And lo and behold, my back started hurting. In my mind, I'm like, yeah, probably not. It's probably something else. But anecdotally, more recently, if I drop off certain things, I notice those areas start getting sore again. So maybe that is the way we have to go with some athletes, just that, for the high risk ones, they're always doing some sort of prevention. For the folks that have a past history of these injuries, then yeah, they really do need to make sure they stay on top of these things. So we'll go over some of the research, and we'll talk about some practical strategies for you too.
Yeah, and I'll just say our boss Mike Ronald often talks about like the utility of those clinical commentaries. They're those level C evidence according to that level of grading, but it has so much utility and you learn a lot from it. But you just know that it's not the level A or B, and we want more of those. But it's okay to look at the level C. Doesn't mean it's not good quality. It just means that it's expert opinion, and you understand that, you take it with a grain of salt. But some people do this really, really well, and we want to do what they do because they've been doing it a long time and they've gained a lot of wisdom. So I love that kind of study.
Yeah.
Yeah. Key number 11, important here, I think, is collaborate with others to assist in return to sport decision making. This isn't just your guidelines and what you would like to do for return to sport. This is a huge decision that goes into the whole process here. So it's working with the athlete, it's working with the surgeon, you as a physical therapist, the family if it's a younger patient, sports psychologists if they're involved, the sporting schedule, the coaches. This is a huge kind of village that makes these decisions. Ultimately, it's up to the athlete and the person and their family, but everyone's playing a role here, and we're trying to all provide them with the best kind of advice we can give them. And they're using all of our advice and information to make a decision on when they feel safe to return to sport. So just understand this is a team thing, and this is kind of very true with ACL, but I think it's true for almost anything that we're treating. Is we're not the sole arbiter here and the one telling the patient what they need to do. Their whole life, it's a biopsychosocial thing, right? As we learn in school, and all of that is important. So there's a whole team that makes those decisions, and we're just a small part of it. But we like to work with everybody else, and I think we're getting better at that over time.
Good stuff, Kevin. I think that open lines of communication make the experience so much better for the patient. So essentially, if you can reach out to the surgeon if need be, if you can talk to the coaches or the trainers, right? You have everybody on board, helps so much. And I think it really makes the patient cared for. and it makes your rehab process a lot better. So if not already, try to form some active communication with the surgeons you're working with. And as you get towards the later stages of rehab, if you want to start talking to the coaches or the trainers, whoever they might be, that also really helps with that transition from PT over to return to sport. So super important. And then oftentimes, if you don't have good communication, that becomes messy, right? It becomes kind of a problem. You have contradictory opinions, and it just becomes kind of a pain. So yeah, communication is good.
All right. This is the one we've been waiting for all episode. I think the most important key for successful post-op rehab is to follow fitness pain-free. You want to subscribe, you want to rate and review. You want to share it with all of your classmates and friends, because then everybody does a better job treating ACLs. So I think that's the best part. I think with this whole podcast episode here, I could have gone into like very detailed, like here's what you do phase 1, here's what you do phase 2. I know you're going to go over a lot of great videos with exercises, like you had said, and return to sport testing videos and neurocognitive videos and all that good stuff. I thought this kind of overview approach would be a little more helpful for people. And so I hope these were helpful and you can really kind of help guide your return to sport and your whole post-op rehab decision-making with some of these principles. And check out some of those papers too, because I think they help. They get into a lot of detail that I didn't put on here because it would be a 7-hour episode. So check those out and follow Fitness Pain Free.
And as always, if you like this content and you want to earn some CEUs, if you're an athletic trainer or a physical therapist or physical therapy assistant, then consider subscribing to Insiders Academy. It's just $1, and you can earn some CEUs for watching this exact material. And if you like this video and you want to go a little deeper, we have an entire master course for you that I did with Mike Reinhold and Kevin Coughlin, where we go over exactly how we like to rehab ACL reconstructions at Champion PT and Performance. Again, link in the description, and see you in the next video.